Very good afternoon. Of the organization. It is my pleasure to extend a very warm welcome to all of our guests and delegates to this inaugural function of the CME on tuberculosis, recent updates and emerging trends. Jointly organized by IMM Odisha chapter and American Society for Microbiology. I request Dr. Vajanti Mala Mishra Madam, Organizing Secretary and the President IMM Odisha chapter, to deliver the welcome address.
President of Odisha chapter IMM, Professor Vimoch Pati, our Secretary Odisha chapter IMM, dear faculties and friends. On behalf of Organizing Committee and Indian Association of Medical Microbiologists Odisha chapter, I welcome you all to this first online quarterly meet of Odisha chapter, IMM and American Society for Microbiology. We are thankful to both this organization for giving us the opportunity to conduct this online CME on tuberculosis on this eve of World TB Day as a mark of observation of World TB Day, which is tomorrow, 24th March. I'm highly grateful to our director who has extended all his support for organizing this event, who of course could not join because of his extremely hectic schedule. My sincere thanks to our Dean, Professor Gupta, and our Medical Superintendent, Professor Mahanti, for gracing this occasion, who are always the source of guidance for us always. Our Medical Superintendent has provided us all the support, particularly for tuberculosis diagnosis facility, so that it can reach the poorest of the poor. I'm delighted to say that this event has a huge number of participants from across the country, beyond Odisha, from various states of our country. And we are honored to have many eminent speakers for the day. Just to name some of them, Dr. Digambar Behera, who is Padma Award and a former chairman of National Task Force of NTP India, will be joining us also for his lecture in person here. Dr. Singla from National Institute of Tuberculosis and Respiratory Disease from Delhi. Dr. Shampa Anuparva Madam from BHU. Dr. Uma Devi, who is a scientist from National TB Research Institute, Chennai, ICMR Institute. Here, I'd also like to express my sincere thanks to all the members of Odisha chapter IMM for believing me to give this position of President of Odisha chapter for this year, for this prestigious association. Now, during this year, actually, we are putting all the efforts to increase our academic activities. We have added quarterly, half day to quarterly meet, and this is the first of that quarterly. And this year onwards, we want basically to make this Odisha chapter of IMM as one of the active state chapter of IMM, like Delhi chapter or Maharashtra chapter, because we now have a very excellent microbiologist network from all our state, all over our state, to have an excellent network of microbiologists. So we can do actually many more things what we are doing now. So this is just one step to increase some academic activities. And also what I feel that as microbiologists, beyond the lab work, we also have a important role to play in the society to spread the knowledge of microbiology, like for example, the awareness regarding antibiotic resistance and hand hygiene. So as a scientific society, we must start this community involvement program. Lastly, I would express my thanks to American Society for Microbiology for selecting me as the country ambassador for Eastern India, which actually will help us in conducting various scientific activities in various forums. And in fact, I'd like to thank ASM for providing some prizes to our best poster and the winner of poster competition. This ASM also will make this Odisha chapter visible in the international platform. So on that note, I'd like to seek the support and cooperation from each and every member of Odisha chapter and all over the Eastern India region. With this, I express my thanks again to the dignitaries and to our speakers, to our chairperson, all the faculties and participants. So I welcome you all and thank you.
Thank you, ma'am. Ladies and gentlemen, now it's time for the inauguration function for the CME, and we regret to inform you that our director, sir, Dr. Mukesh Tripathi, will not be joining us for the inauguration because of his busy schedule. So now I request our dignitary, Dr. Devasis sir, our dean sir, Dr. Satyanarayana Mohan sir, our medical superintendent sir, Dr. Vicky Patnaik ma'am, past immediate president, IMM Research Chapter, Dr. Vinod Prajnapati ma'am, and Secretary IMM Research Chapter to kindly join us for the inauguration. That is the live ceremony.
Director boardroom has been better.
Ya kundendu susaraharadhakara ya subra vastravrata ya veena varadandamanitakara ya sweta Padmasana ya Brahma Shita Shankara Prabhuti Eve Sada Vandita Sama Saraswati Bhagavati Nisesha Jadya Mahan Nisesha Jadya Mahan. I request our dean sir, Dr. Devasis sir, to address this.
Dr. Vaijanti, head of the Department of Microbiology and Bhubaneswar, Professor Satyanarayana Mohan, our medical superintendent, and many dignitaries on and off the dais and participants of this particular CME. We have been observing this World TB Day. I remember when I was a first year MBBS student at SAG Medical, and our seniors celebrated. We know TB is a disease and people suffer, and we didn't have much awareness of TB that time. Then when I became an MBBS, then I did my subsequent studies and I became a faculty. Then I know that it is not as simple as it looks. Despite providing free medication and improved healthcare facility, still we are not able to control the disease. Then some people started expressing their views that it is a lifestyle disease. People who follow the instructions, the treatment is longer, and people just unable to take the full medication on time. Then subsequently, last few decades, we have come across the emergence of MDR tuberculosis, XDR tuberculosis, now total resistant tuberculosis. So now it is really a challenge to all of us. we are a medical fraternity, and this is a real challenge. And this challenge that has again complicated by the emergence of HIV and also the last 2 years, the COVID pandemic. So we have actually neglected many of the deserving patients who should be treated because of the lockdown and shutdown situation in the country, not only in our country, globally. So many people, they are deprived of getting the full treatment. So now it is a bigger challenge this year, 2022, how to mitigate this situation, because we are now getting multiple challenges. Tuberculosis alone, MDR tuberculosis, HDR tuberculosis, and with comorbidities and with co-infection. So it will be a big challenge for the microbiologists, not only the microbiologists, also all medical fraternity who are in the treatment of tuberculosis. And I welcome all the dignitaries on behalf of AIMS Bhubaneswar to participate, and you must take a vow that you contribute significantly for eradication of this deadly disease, and let us not keep this as a disease of the developing nations, and we must cooperate and extend our hands of support for eradication of this. And I welcome all these speakers, delegates, and all the participants of this show or this CME, and I wish all success to Team Bajanti and all. Thank you.
So, that beautifully highlights what are the challenges we are facing for the disease tuberculosis. So now I request our Honorable MS Sir, Dr. Satyanand Mohanty Sir, to begin.
Dr. Devasis, Dean of AIMS Bhubaneswar, Madam Bajanti, HOD Microbiology. Two more professors are here. Aditi is very close to me. The other lady, of course, is known to me. And the faculties of microbiology department, other participants. Many known beautiful faces on the screen. I think we have 362 participants as of now. This is a CME on tuberculosis, recent updates and emerging challenges. Very good topic, very good initiative, and I was told it is quarterly it is being done. Every quarter we will do it. It's a good thing. Dr. Bajanti always takes the lead. We are happy that the American Association, they've also recognized her. Why not? Actually, I will, before going to the topic proper, let me go back to the creation of AIMS. It was under PMSSY, they had two objectives. One was to see for the regional imbalances. Because in those days, most of the patients of different categories, they used to go to AIMS to Delhi. So they thought, let us establish AIMS in different state capitals. And the other, which is very important, was they thought that every fellow who is in the queue, the last fellow also should get the treatment free of cost. Those were the two basic aims why the PMSSY division was created by the government of India. And because of that only, we have now almost 22 aims, and they have upgraded 75 medical colleges, which includes Berhampur and Cuttack as well. And the whole idea of creating aims was to disseminate knowledge. And conduction of CME on the topics like this is also a sort of dissemination of knowledge by the experienced faculty of AIMS and other participants, mostly aiming to the peripheral doctors. See, the whole idea why why we are facing challenges. It's a long-standing disease. It's there mostly probably, I think 100 years or 60, 70 years, I do not know exactly. But still we are unable to control the disease or minimize the number of cases. I was going through a literature. It is said that 2 persons die every 3 minutes in India because of tuberculosis. This is a huge challenge. How we can overcome the challenge, that the whole idea of sitting here and disseminating knowledge. I have certain knowledge why we are unable to overcome. I would say the most important thing would be the lack of infrastructure at the peripheral level. That I would say one. Number two, inappropriate and inadequate use of the tubercular medicines or drugs. And third, I would say, which is the most common cause of all the diseases in India, is the poverty. So if one can overcome all these three things, if the government will take initiative to provide infrastructure, whatever is required, the minimum at the peripheral level, because at periphery, mostly the people, they do come and report to the doctor. And the use of drugs, inappropriate and inadequate use of drugs is also one of the reasons from the resistant cases of tuberculosis. So these are 2-3 things. What are the challenges as far as my knowledge is concerned? So I hope that the CME will disseminate their knowledge. They will discuss more on the issues like emerging challenges and recent updates, so that the participants, they will gain the knowledge, and the exchange of ideas and the thoughts will improve the knowledge, and at the end, the patients will get the best treatment, so that we'll be able to eradicate tuberculosis, if not now, maybe later. Thank you very much for inviting me. I'm really thankful to the organizers. My good wishes for this year. Thank you.
Thank you.
आवाज नहीं आ रहा है. सुनो, let madam speak from there. उधर से आवाज नहीं आएगा. लैपटॉप के सामने बैठेंगे, लैपटॉप का माइक ऑन करो, पूरा सुनेगी.
Yes.
Thank you, sir, for your words of encouragement. Now I request Organizing Secretary, IMM Odisha Chapter, Dr. Vimoch Prajanapati, ma'am, to share her report. Ma'am, please.
Respected Medical Superintendent Dr. Mahanti, our President, IMM Odisha Chapter, Dr. Baijayanti Mala, Dr. Dipti Patnaik, our past President, IMM Odisha Chapter, all the members present, esteemed participants, and respected speakers. A very good afternoon to all. First of all, I am welcoming all of you to this academic forum of our Odisha chapter, in which we are having our academic activity almost around after 2 years. So after 2 years, this first quarter CME is organized by AIMS Bhubaneswar. I must congratulate Professor Baijayanti Mala Mishra and her team to take pain to organize such a nice event on the in a very apt way. In topic is selected just near the World TB Day. So topic is very nicely selected on the right day. So I must congratulate her for that. Then coming to our Odisha chapter, I want to inform you all that this year we are holding the national conference of IMM by the members of the state chapter in KIMS Bhubaneswar under the leadership of Professor Nirupama Chaini Madam as organizing secretary. Coming to the performance of the Odisha chapter, since its inception in 2007, we are moving or taking baby steps every time to reach a level of academic excellence. In this way, we have, in this year, we have made 3 developments. One is with a huge effort by our treasurer, Dr. Asoka Mahapatra, we are able to organize the life membership, that is life membership and temporary membership of our chapter. And of IMM, Dr. Pallav Rai sir has also helped us to finalize this logo. So this is the Odisha chapter logo we have produced or prepared for further use. So we are taking small steps to move forward. So the next CME will be in August, around in August in Apollo. Now we will try to move forward and strengthen our Odisha chapter. And now I wish the organizer best of luck and success to the CME. Thank you all.
Thank you, ma'am. Now I request our Joint Organizing Secretary, Dr. Ashoka Mahapatra, ma'am. Ma'am is additional professor in our department to propose the vote of thanks, ma'am. Thank you, Kavita. Respected Medical Superintendent, sir, respected Dean, sir, and our HOD, Baijanti Malla madam, and all the colleagues and junior present here, and all the delegates and speakers. So it is a great pleasure for me to extend the vote of thanks to all those who are present here and to make this CME successful. We are very thankful to our director, Dr. Mukesh Tripathi, who is, although he could not make it possible to present here, but he has extended all supports to conduct this event. We are also thankful to our Dean, Professor Devashish Fotta sir, for his constant guidance and kind presence. We express special thanks to Professor Sachidananda Mahanti, who is our medical superintendent. He has extended every support. He is the chairman of the Institute Core Committee and extended all support to establish the diagnosis of tuberculosis in our institute. We are privileged to have eminent speakers from reputed institutes like Dr. Digambar Behera, who is a Padma Shri awardee, and right now he is the chairman for National Task Force for NTEP. We have Dr. Rupak Singla, who is professor and head of National Institute of Tuberculosis and Respiratory Division. We have Dr. Sampa Anupurba, who is the professor in BHU in the microbiology department, and she has enormous contribution in the research of tuberculosis. We have also K.R. Uma Devi, professor and head for NIRT from NIRT Chennai. In addition, we have few more speakers from RMRC Bhubaneswar as well as from AIMS Bhubaneswar. So we must be thankful to all our speakers as well as our chairpersons for accepting our invitation in spite of their busy schedule. And our event could not be complete if I won't mention the name of the IT department, because Mr. Sujan Mahanti, the team leader, and his team, they have provided all kinds of supports to make this online event successful. We are very, very thankful for the overwhelming response of the audience, which beyond our expectation, they have joined in a huge number. And lastly, I must thank to each and every member of our department from the family of microbiology AIMS Bhubaneswar, who are giving continuous support in different aspects. So we hope we will meet all the expectation, and we will try our best to meet your expectation in this academic fest. Once again, thank you all. Thank you, ma'am. And with this, we have come to the end of our inaugural function, and we will begin with our academic session with the first session on tuberculosis current scenario. I request our chairpersons, Dr. Pritil Tapanda, ma'am, Professor and Head, Department of Microbiology, PRM Medical College, Baripada, and Dr. Dipti Patnaik, ma'am, Department of Microbiology. Ma'am is a professor in Department of Microbiology, KIMS Bhubaneswar, to chair the session. So over to Dr. Pritil Tapanda, ma'am, and Dr. Dipti Patnaik, ma'am.
Hello, good afternoon, everybody. I am Dr. Pandya from PRM Medical College, and due to some other engagement, I cannot present physically. So I welcome all the participants, dignitaries, and our organizing secretary to have such a nice session. Now, welcome the first speaker, Dr. Siddharth Giri, who has a brilliant career, having he is the scientist in the ICMR RMRC in Venezuela. He has won the several awards from Indian Council of Medical Research and more than 50 publications, both in the national and the international level. So I welcome and invite Siddharth Giri to present his presentation.
Is it visible? Is it visible full screen?
It is visible.
Yes, it is visible.
Okay, so good afternoon to all. I am Dr. Siddharth Giri, scientist T from ICMR Regional Medical Research Center, Bhubaneswar. And during the next few minutes, I'm going to talk about the global epidemiology of tuberculosis. At the outset, I would like to thank IMM Odisha chapter, the ASM, and especially Baijanti Mala madam for giving me this opportunity to present this topic. So as this is the first lecture, I just wanted to give a very short background. So we all know that in 1882, Robert Koch discovered the causative agent of tuberculosis, which marks the World TB Day. And it is caused by Mycobacterium tuberculosis complex. TB continues to be a major source of morbidity and mortality, particularly in low and middle income countries. Although it is primarily a pulmonary pathogen, it can affect most of the body sites. Patients with TB can present as latent TB infection, which is asymptomatic and non-transmissible, or active TB disease, which is transmissible, which is what we see in mostly pulmonary tuberculosis. The standard treatment for TB comprises of 4 antimicrobials, which is rifampicin, linezolid, pyrazinamide, and ethambutol, and resistance to all these drugs are possible, can occur. The risk factors for TB includes HIV infection, which is the most important. The other risk factors are undernutrition, indoor air pollution, type 2 diabetes mellitus, excessive alcohol use, and smoking. So, looking at the major burden of TB worldwide, the World Health Organization came up with the End TB strategy, and this was adopted by the World Health Assembly in 2014. And it aims to end global TB epidemic as part of the newly adopted Sustainable Development Goals. And as you can see, by 2030, the aim is to have a 90% reduction in TB deaths, a 80% reduction in TB incidence rate, and to have 0% TB affected families having catastrophic costs due to TB. So looking at the top causes of death in 2019, which was the last year when WHO published all the causes of global deaths, tuberculosis was the 13th leading cause of death worldwide, and the top cause from a single infectious agent. And but probably in 2020, it is anticipated that TB will rank second to COVID-19 as the most important infectious agent. We all know the disastrous impact of COVID-19 on human health during the past 2 years. So coming to TB incidence, I have given the TB incidence globally as well as the WHO region-wise. So the worldwide, an estimated 9.9 million people fell ill with TB in 2020, which is equivalent to 127 per 100,000 population. And these figures are small declines compared to what we saw in 2019, both in terms of incidence rate and absolute number of cases. There has been a slow decline in 3 of the 6 WHO regions. However, the good thing is that we have seen faster declines in the European and African region, as you can see in the arrow pointed in the graphs. And Another region of concern is the Americas, where there has been an increase in incidence due to the increased trend in Brazil since 2016. So this is a worrying trend for the Americas. So coming to 2020, most TB cases in terms of numbers were reported from the Southeast Asia, which contributed to 43% of the total cases, followed by Africa and the Western Pacific. So the 30 high TB burdens countries currently contribute to 86% of all estimated incident cases worldwide. And 8 of these 30 high burden countries contribute to 2/3 of the global total, in which India contributes to a massive 26%, followed by China, Indonesia, Philippines, Pakistan, Nigeria, Bangladesh, and South Africa. So if we look at the global map on the incidence of TB, it varies widely across countries, ranging from less than 5 to more than 500 cases per 100,000 population per year. And in this whole graph, there are 57 countries where actually the incidence of TB is less than 10 cases per 100,000 population, mostly in the Americas and European region. The 30 high burden countries, which I mentioned, actually report around 150 to 400 cases per 100,000 cases deaths by the WHO regions. And the global pattern of an increase in TB deaths in 2020 was evident in 4 of the 6 WHO regions. The exceptions were Western Pacific and the African region, where you can see a flat trend. So it's good that they had the same number of deaths as 2019. Are the slides visible? Okay.
Yes.
Thank you so much. I was talking about the TB deaths by WHO regions. The global pattern of an increase in TB deaths was evident in 4 of the 6 regions. The good news is the exceptions were the African and the Western Pacific, where there was a linear trend, not an increase shown. And the number of TB deaths increased in 2020 in most of the 30 high burden TB countries. So I have talked about the TB incidence and the TB deaths. And now I will go to one of the most important aspects of TB epidemic, which has affected TB epidemiology during 2020 to 22. So that is the impact of COVID-19 on TB. So because of COVID-19, which emerged during December 2019, and India got affected badly from March 2020 onwards, April probably. So there was a large global drop in the number of people newly diagnosed with TB and reported. So it decreased from 7.1 million in 2019 to 5.8 million in 2020, which was a drastic 18% decline. And we went back to the 2012 levels. As you can see from the graph, 2020, there was a drastic reduction in TB notifications. And 16 countries accounted for 93% of this reduction, with India, Indonesia, and Philippines contributing the most. So they were responsible for the major reduction in notification of TB cases. So this shows again the drastic decrease in TB cases across the 6 WHO regions. So continuing with the impact of COVID-19 on TB, there was reduced access to TB diagnosis and treatment, which has resulted in an increase in deaths due to TB. In 2020, if you look at the graphs, 1.3 million TB deaths occurred among HIV negative people, which was up from 1.2 million in 2019. And an additional 214,000 people, HIV positive people, died from TB, which was more than what was reported in 2019. So basically, the COVID pandemic has reversed years of global progress in reducing the number of people who die from TB. The other impact of COVID-19 has been reductions in the number of people provided with treatment for drug-resistant tuberculosis and TB preventive treatment. And there has been a drastic fall in global spending on TB diagnostic, treatment, and prevention services. So here I would like to point out some of the reasons for this substantial reduction during COVID times. One was the reduced health system capacity to continue to provide services, less willingness and ability to seek care in the context of lockdowns and associated restrictions on movement, concerns about the risks of going to healthcare facilities during a pandemic and getting infected with COVID-19, and the stigma associated with similarities in the symptoms related to TB and COVID-19. And we have seen regional and country-wise variation also during COVID pandemic. So the reasons for this could be differences in when the countries were first affected by the COVID pandemic, the severity of the impact, the extent to which restrictions were put in place and adhered to, and the capacity and the resilience of health systems. Although I talked about the negative impact of COVID-19 on tuberculosis epidemiology, there has been some success stories at the country level. One of the significant is that 7 of the high burden countries have achieved the End TB Strategy 2020 milestone of a 35% reduction in the TB deaths, which is actually extremely good news. And 9 countries in the high burden list have actually achieved the End TB Strategy 2020 milestone of a 20% reduction in TB incidence rate between 2015 and 2020. So this is very encouraging, and it actually helps other countries also to focus, and we hope that we will have more countries achieving this these kind of achievements in the next few years. One of the concerns in TB is the missing millions. As you can see from the graph on the right, the estimated number of cases, which is in green, and the actual notified cases, which is in black, there is a wide gap. So we are actually missing millions of cases. And in 2020, 10 countries collectively accounted for 74% of this global gap, which is quite a matter of serious concern. And the top 3 contributors were India, 24%, Indonesia, 11%, and the Philippines, 8.3%. The reasons for the gap, again, combination of underreporting of people diagnosed with TB and underdiagnosis owing to people being unable to access the healthcare system, or not being diagnosed when they do access the healthcare system. Another concern in TB epidemiology is bacteriological confirmation of TB cases. So on the proportion of bacterial-confirmed TB cases across the WHO regions, to increase this percentage, for drug resistance, and it allows the selection of the most effective regimen for treatment. Then another issue defined in TB epidemiology is drug-resistant TB. So the WHO uses 5 categories to classify drug-resistant TB. One is isoniazid-resistant TB, rifampicin-resistant TB, multi-drug-resistant TB, which is resistant to both isoniazid and rifampicin, pre-extensively drug-resistant TB, which is resistant to rifampicin and any of the fluoroquinolones, and extensively drug-resistant TB, which is resistant to, which is MDR TB plus resistant to any of the fluoroquinolones plus resistant to bedaquiline and linezolid or linezolid. So globally in 2020, 71% of people, that is 2.1 million, who were diagnosed with bacteriologically confirmed pulmonary TB were actually tested for rifampicin resistance, which is higher than the percentage in 2019 and 2018. And the bad news is that we have close to 132,000 cases of MDR TB and close to 26,000 cases of XDR TB. So, but however, I would like to point out here that the good news is that the proportion of people recovering from MDR TB after MDR TB treatment has continuously risen from around 50% in 2012 to 59% in 2018. And we hope that this increasing trend will continue over the coming years. Of course, one of the major issues is TB and HIV. One good thing is the global coverage of HIV testing among TB cases in 2020 was good at 73%. However, the absolute number of TB cases who knew their HIV status fell from 4.8 million in 2019 to 4.2 million in 2020. At the regional level, the highest coverage for HIV and TB diagnosis was in the WHO African region and the WHO European region. So the coverage of antiretroviral therapy among people diagnosed with TB known to be HIV positive was 88%. And if you look at the figure on the right, the success rate for people treated for TB with first-line regimen was 86% in HIV negative cases, and it has reduced to 77% in HIV positive cases, although we can hope that this percentage rises in future. Just to give a glimpse of about what is happening in TB in India. So we all know the National Strategic Plan for Tuberculosis Elimination 2017 to 25. The TB National Strategic Plan has been revised. Now it is 2025 document, which has been published by the Government of India. And the aim is to eliminate TB by 2025. And as I said, this document replaces and refreshes the National Strategic Plan 2017 to 2025. And the intention is that the new NSP will accelerate the national response to TB. So in India, the TB notification from 2015 to 19 had shown quite an improvement. We were actually catching up with the WHO estimates. The difference between the notified cases and the WHO estimates was decreasing. You can see a linear trend, a linear increase in our reporting. However, all that changed in 2020 when COVID-19 struck India. In this figure, you can see month-wise difference in COVID-19 in tuberculosis reporting during 2019 and 20, and you can see the drastic decrease during 2020 due to COVID-19 pandemic. And finally, coming to notification progress in the public and private sectors of India, although there was a 25% decrease in reporting, the good news is that the contribution of TB diagnosis by the private sector has increased from 20% to 31% during 2020. So this gives a very broad picture. Actually, due to time constraint, I have not been able to present more data on India, as my topic was global epidemiology. So to conclude, progress towards TB milestones and targets have been hit hard by the COVID-19 pandemic. In 2020, number of people dying from TB has increased, as I showed in the figures. Previous declines in the annual number of people with TB slowed. Far fewer people were diagnosed and treated for TB or provided with TB preventive treatment. There has been a drastic reduction in the spending on essential TB services. In 2020, TB was probably second only to COVID-19 as the single cause of death from an infectious agent. Modeling projections have shown that the situation, the number of people developing TB and dying from TB will worsen during 2021-22, which is a matter of grave concern. Now, because of the COVID-19, as I have said, global TB targets are mostly off track, although we have seen there are country and regional success stories. So the most important point is actions to mitigate and reverse the impact of COVID-19 pandemic on TB are urgently needed. So with this, I end this lecture, although it was a very concise presentation. This is a huge topic, and it will take probably 1 hour to discuss all the aspects. But I would like to just mention that, you know, ICMR RMRC Bhubaneswar, in collaboration with the Odisha Vigyan Academy, is going to come up with a special issue on tuberculosis in Science Horizon and Vigyan Diganta. This will be published in 1st April, and it has contributions from faculties and scientists from AIIMS Bhubaneswar, ICMR headquarters, ICMR Bhubaneswar, SCB Medical College, PRM Medical College, SLN Medical College. So I would request all of you to access this information, spread this information to school and college students as well, because these are very simply written. So with that, I would like to thank again the organizers, and especially Baijanti Mala Madam, for giving this opportunity. Thank you everyone for patient hearing. Thank you.
Thank you, sir, for your elaborate presentation on the epidemiological aspect of such an important disease, tuberculosis. You have covered in detail the burden of tuberculosis, the risk factors, and its relation with COVID-19 in COVID-19 era. Thank you, sir. Now it is open for discussion. Any question is invited from the audience. They can type it in the chat box. I have seen only one question in the chat box from Professor Sushant Kumar Sahu, Professor HOD, SLN Medical College, Koraput. He has asked regarding the trend of MDR TB. Sir, can you please give some idea regarding the trend of MDR TB?
Yes, in terms of absolute numbers, we have seen a decrease in MDR TB, although, you know, in 2020 we still have a huge number, that is 132,000. The decrease which we see is mostly due to the less reporting of TB cases, not that there has been any real decrease in MDR TB. And the MDR TB also varies by geographical regions. It is very high in certain Eastern European nations, and lower in the Americas and Europe. So that's the current scenario.
We will switch over to the next speaker. Should we?
Thank you very much.
So now I have the pleasure to invite our next speaker, Dr. Baijanti Mala Misra Madam, who is the present president of our IMM Odisha chapter. She is currently holding the post of professor and head Department of Microbiology, AIIMS Bhubaneswar. She has several degrees to her credit. She is also the fellow of Infectious Disease Society of America. She is also the member of the fellow of Royal College of Physicians, London. She is also fellow of Royal College of Physicians and Surgeons, Glasgow. And to her credit, she has more than 100 research publications in her credit in all reputed journals. I cannot say more because she actually, in short form, to be precise, she is a true academician. She takes a keen interest in all the academic activities. This CME is the proof that she is trying her level best to create such academic environment in the Odisha chapter, which will help all the postgraduate students and the faculty members. So now I will invite Dr. Baijanti Mala Misra Madam to deliver her speech.
Thank you, Chairperson, for the kind words. So very good afternoon to all of you. My topic is recent updates on laboratory diagnosis of tuberculosis. Now, when we say diagnosis of tuberculosis, it actually can be diagnosis of active tuberculosis or diagnosis of latent tuberculosis. Being from India, a tuberculosis endemic country, when we say diagnosis of tuberculosis, we mean actually diagnosis of active tuberculosis, which again actually encompasses two components: detection of Mycobacterium tuberculosis and detection of the drug resistance, because gone are those days when we are detecting the pathogen and we are happy with the diagnosis. So presently it actually encompasses both these components. Tuberculosis diagnosis has come actually a long way from clinical to radiological, and now presently completely dominated by microbiological diagnosis, particularly the molecular ones. Now, in microbiological diagnosis, again, we have come a long way from smear microscopy, the age-old Zille-Nelson staining, from fluorescent microscopy, solid culture, liquid culture, and finally the molecular platforms. What the microscopy tells us? It tells us whether this is acid-fast bacilli or not. We are still holding with the Zille-Nelson stain for this microscopy, and presently the fluorescent stain using the Oramin rhodamin, using the LED microscopy, which is a part of the NTEP or National Tuberculosis Elimination Program, and present in all designated microscopy center as a part of the program. And why microscopy we are still holding on to it? Because of its rapid, easy, and inexpensive, and particularly it can be done at the periphery level. Though we know that it needs high bacillary load to be detected, it cannot differentiate from MTB or NTM, viable or dead bacilli, whether it is sensitive or resistant strain. Why it's coming like this? Why this line is this?
That works.
And more importantly, the microscopy cannot differentiate between the sensitive.
Some participant is doing that nuisance.
Whether this is sensitive or resistant strains. Now, to grow the bug, we have various culture media, solid media, and liquid media. And of all the media, what is important and more commonly used is the solid media, LJ media, and the Middlebrook 7H9 liquid broth. The beauty of culture is it is the definitive evidence of the bacteria's presence of the bacteria, and it is much more sensitive than microscopy, and more importantly, it can be subjected for the drug sensitivity assay. The liquid media is currently the WHO recommended method for culture and drug sensitivity testing, which has even the higher yield than the solid media, almost by 10%, though it is more prone for contamination and needs additional biosafety level. But most importantly, it has decreased the turnaround time of solid culture DST from 3 months to an average of 3 weeks, which can be achieved by liquid culture DST. And in automated culture system or culture methods, we have various or 3 platforms mainly, Midget, BactiAlert, and VersaTrack. These 3 methods, they work on various different principles for its detection. And it has, WHO has endorsed BactiAlert and VersaTrack for culture, and Midget has got the WHO approval for both culture and drug sensitivity testing. Now, there is a slight role of this antigen detection assay of this lipoarabinomannan assay, which has a limited applicability and recommended by WHO in HIV positive individual who have signs and symptoms of TB or seriously ill, or when the CD4 count becomes less than 100 cells. Now, coming finally to the molecular detection of MTB and drug resistance, This current guideline or latest guideline, which came up in 2021, has actually come up with various new approvals, various modifications. So we have now an entire spectrum of different types of molecular assays which can detect MTB DNA. And there are assays which can detect MTB DNA along with rifampicin resistance, then along with rifampicin and INH, then rifampicin, INH, fluoroquinolone, and second-line injectable drugs. So entire spectrum is now available. The TB LAMP assay or loop-mediated amplification, that is for MTB detection, DNA detection only. It has few steps. And the main advantage of this assay is it detects almost 15% more than the smear microscopy. It is a quite robust system, and the main applicability, it can be done at the periphery level. So WHO has recommended this as a replacement test for sputum smear microscopy and also as a follow-on test to smear microscopy when further testing for sputum smear negative specimen is required. Then gene expert MTB reef assay, or what we know as the CBNAT, or in 2010, WHO recommended the use of expert MTB reef in both pulmonary and extrapulmonary tuberculosis. And when this came, it actually acted as the game changer. It completely changed the scenario of TB diagnosis. Why? Because it can detect MTB DNA as well as rifampicin resistance, and it is applicable both for pulmonary and extrapulmonary TB. And it is quite rapid. It can do its job only in 3 to 4 working hours. So now it has come from 3 months to 3 weeks. Now it is almost 3 hours. And rifampicin, why rifampicin resistance is important? Because rifampicin acts as a surrogate marker for MDR-TB, because more than 90% of rifampicin resistant isolates are also resistant to isoniazid. So it acts as a surrogate marker for MDR-TB. And the working principle of this CBNAT or expert platform is extremely simple. It has an integrated sample processing and PCR system. After the sample processing, all steps are automated, and it also has a excellent sensitivity specificity both for MTB detection as well as for rifampicin resistant detection. And it has analytical sensitivity of 131 colony forming unit. So in a way, we can say that gene expert MTB reef assay can diagnose majority of MDR directly from sample in just 2 hours. But still, it misses some of the possibacillary cases. So there is an improvisation of expert MTB reef by adding 2 additional targets to detect MTB, by improving the assay chemistry and cartridge design. So that has made now what is available as expert ultra, and the limit of detection has increased to 10-fold. From 131 CFU to it has come down to 16 CFU. And also this is a very fast, it's faster. It can do only in 90 minutes. Then we have another similar system, which is from an Indian company, TrueLab, which is again a chip based, which can do MTB DNA detection as well as rifampicin resistant detection. But the difference from expert system is here the steps are multi-sequential step. So you have to do the DNA extraction followed by MTB DNA detection. And if it is positive, then you go for the next step of rifampicin resistant detection. Now, because of its high diagnostic accuracy of TrueNAT, it has been, WHO has approved this as an initial test to diagnose a TB, replacing the sputum smear microscopy, and the performance of this TrueNAT, MTB, MTB plus, and MTB RIF diagnostic assay is comparable with all the other approved WHO tests like expert MTB RIF or Ultra or TB LAMP, and even the line probe assay. So what is missing? Missing is those cases who are rifampicin susceptible but INH resistant. So this percentage is also quite high, 13% in newly diagnosed cases and 17% in previously treated. So to bridge the gap, to detect INH resistance, now several moderate complexity automated NAT platforms have developed. which has been approved in 2021 by WHO. They are less complex to perform than phenotypic DST and line probe assay, which is quite complex. They're a high throughput platform and largely automated and also faster. It can do in 3 to 4 hours only. So these are the approved platforms by WHO, the Ross, Abbott, and BDMAX, and the fluorotype by Hen Life Science. So these are the 4 platforms which have got the WHO approval for both rifampicin and INH detection. So these assays or these platforms we can do directly from the sample, or digested decontaminated sample can be done. And the sensitivity specificity for detection of MTB, reef-resistant, and INH, all 3 are actually excellent. You can see here. So the next is the detection of extended drug resistance, that is addition of fluoroquinolone and second-line injectable drugs. XTR actually constitutes 2.5% of all drug-resistant tuberculosis. Now, we have line probe assay for that, which detects MTB DNA and identifies the genetic mutation for both first-line and second-line drugs. In first line, it detects resistance to rifampicin and INH. In second line, it detects to 2 of the fluoroquinolones and 3 of the aminoglycoside, which are the injectable drugs. So it eliminates the delay of phenotypic assay, because it came actually in 2008 WHO approval. But here the problem is nothing is automated. And there are several steps. The first step is DNA extraction, then the amplification of PCR for multiple targets, then the hybridations assay, which is quite stringent. It has to be done, where the pre-coated probes are there and the amplified target has to be coated onto it. And how it appears, it is present available in 2 different separate strips for first-line drugs and for second-line drugs. In the bands are come for the panel of wild type bands and the mutant bands. So for each drug, we have wild type bands and the mutant bands, and how it is to be reported. When the wild type bands are present and mutant bands are absent, then it is not resistant, or resistant is not detected. When the mutant probes are present, whether wild type is present or absent, then it is called resistant is detected. When wild type is absent, but mutant is also not present, then it is called resistant inferred. These are the various targets of different drug resistant detection, which is used in LPA. Now, how this clinical analysis of drug resistance is done from this LPA result, that depends on the level of drug resistance. Now, whether it is high level or low level, and that is again depends on the location of the mutation. For example, if it is a CATG mutant is present, the CATG of INH, then it is considered as a high level resistance. If it is INH A, it is low level resistance. Also, it depends whether resistance is detected or inferred. So if it is high level drug resistance, drug is not going to be effective even with the increased dose. So that is how it is clinically interpreted. Now in this WHO manual, the detail of the clinical interpretation is given for the first line drugs as well as for the second line drugs. The overall performance for of LPA for first line drug is excellent, near 100% for both sensitivity and specificity. For second line drugs, the specificity is near 100% and the sensitivity is slightly less than 90%. The advantages, of course, are many when it is rapid, where we can get result in only few days. Both and expanded panel of first line and second line drug resistance. But problem is disadvantage is equally heavy. It is labor intensive, it requires highly trained personnel, it requires dedicated laboratory space and equipment. So, you know, we always edil mange more. So what we want here is we want to detect extended drug resistance, but the assay has to be simple, rapid and accurate. So we have now the WHO approval for expert system. Now the expert system is again back with the extended drug resistant platform, which can detect the resistance to the panel of the drugs, isoniazid, fluoroquinolone and amikacana, and ethionamide. You can see here the sensitivity specificity as compared to the phenotypic DST and as compared to sequencing. As compared to sequencing, we can see the sensitivity specificity almost near 100% for all this drug. What is important here, it requires a higher model of platform, that is the 10 color model gene expert platform is required. Now the problem is in 2021, this platform got approval, but at the same time, WHO also changed its the definition of drug resistant. For MDR, it is still the resistance to rifampicin and INH. The pre-XDR is now MDR plus resistant to any of the fluoroquinolones, and XDR is pre-XDR plus bedaquiline or linezolid. So now the XDR has removed the second line injectable drug because in the regimen, the injectable has been removed. So on one side, we have XDR definition change, but also at the same time, the expert has come up with the, this injectable drug, or what we think that it actually detects extended drug resistance. So the question arises whether this expert XDR system can really fulfill its promise. Now, this has come as an article in this last month, February 2022 in Lancet Infectious Disease, where we can see that actually this expert XDR can detect INH resistance. By that, which it means that it can detect the true MDR cases, not only the surrogate marker. It can detect resistant to fluoroquinolones, so it can detect all the pre-XDR, and also it can detect to injectable second line drugs. So it can actually detect all XDR as per the previous definition to 2021. So it can detect approximately 97% of patients with drug-resistant tuberculosis. So therefore, it's likely to make an invaluable contribution both to patient as well as to the program. Now, just to categorize the different molecular tests available for NTB diagnosis and drug-resistant, these are the different platforms which can detect only DNA or DNA with MTB with resistant, with rifampicin and INH, and all the XDR platforms. And many of these have got the approval in 2021. Now, also these molecular tests have been categorized as per their technical complexity. Low complexity, in which expert platform comes, MTB Reef, Ultra or XDR, and also the TrueNAT. Whereas in moderate complexity, all these platforms which have got the approval for detection of INH and rifampicin along with the TB lamp, and in high complexity, we have the line probe assays. So what finally the WHO recommend test for TB diagnosis and DST? For initial diagnostic test without drug resistant, it is the TB lamp and TrueNAT system and lamp for HIV patients. For with drug resistant detection for pulmonary TB, the recommended tests are TrueNAT along with the moderate complexity platforms have got the approval. Whereas with drug resistant for both pulmonary and extrapulmonary TB, it is the expert MTB Ultra or MTB Reef has been approved. Whereas for the follow-on test, that is for the confirmed MTB cases, expert MTB XDR has got the approval as a follow-on test, and also the line probe assay, which we have. And also there is another type of line probe assay, which has got the approval for pyrazinamide drug resistant detection. And there are some modification in 2021 regarding the sample, approval of sample. And these are for particularly for expert MTB Reef and expert Ultra. For pulmonary TB in children, along with the sputum sample, now WHO has also approved the stool and a stool sample, nasopharyngeal and gastric specimen. In extrapulmonary TB, along with other previous sample like lymph node aspirate tissues and various fluids, urine specimen has got the approval. And in disseminated TB, the blood sample has been approved by WHO. And these all are for the expert Ultra so far. So it is time, friends, to invest to end TB and save lives. So this is the theme of the current theme of the World TB Day 2022. So with this, I end my lecture. Thank you.
Thank you, madam, for your excellent presentation on different modalities of the diagnosis for tuberculosis, both conventional and the recent diagnostic methods, including all advantages and disadvantages of all the diagnostic modalities. Now, there is a question in the chat box that is from Dr. Bibhudatta Rautrai. Can all extrapulmonary samples like urine fluids, blood can be done in CBNAT or TRONAT? Madam, please give your.
So far, WHO has approved urine specimen or whatever modification I mentioned for this clinical specimen. Those have been for expert MTB, RIF and ultra. Because when there is no evidence, because studies on other platforms have not yet been conducted. So this is the approval so far by WHO.
There is another question that is, please comment on lipoarabinomannan urine strip test, which is also endorsed by.
Yes, lipoarabinomannan actually has got, is recommended by WHO only for HIV positive individual. And when HIV positive individual have the signs and symptoms of tuberculosis, or they are very sick, or when they don't have the signs and symptoms of TB, but the CD4 count is less than 100. So this is the present recommendation of lipoarabinomannan detection in urine sample.
I think the question that was raised, probably they have got their answer. Thank you, madam, once again for the excellent presentation. Thank you. Now,
I invite Dr. Bhunia for the next presenter to deliver his speech. And also again, I am to thank Dr. Baijanti for his nice presentation and catchy slides and for easy understanding of all the participants.
thank you.
And Dipti, can you read out the CV?
Yes, ma'am. Now the last speaker of this session is Dr. Saurin Bhunia. Presently, he is the additional professor in the Department of Pulmonary Medicine and Critical Care, AIIMS Bhubaneswar, and he has more than 50 publications in reputed journals to his credit. Can I request Dr. Saurin to have his presentation? Dr. Saurin, please. It's visible.
Okay. Thank you very much. And I'm extremely sorry for the delay because I had tried to join from my laptop, but because of some technical problem, again, I had to join from my desktop. So I am I'm really sorry for that. So at the outset, I would like to thank Baijanti Pillai madam for giving me this opportunity to be a part of this wonderful CME on the eve of World TB Day. My job is to take you through the management of drug-sensitive tuberculosis. We all have been treating tuberculosis across all specialties because TB, as we know, affects almost all the systems of our body. So nothing much has changed over the last 1 year in the treatment of drug-sensitive tuberculosis. So basically, it's going to be a recap of what we already know. So the outline of my talk would be, briefly, I would just touch upon the scientific basis of anti-tubercular therapy. Then, of course, the treatment regimen for drug-sensitive tuberculosis. I will discuss in brief some issues or rather controversies in the treatment of some of the extrapulmonary tuberculosis. And of course, the most important aspect, the management of the common adverse drug reactions of the anti-TB drugs. And also, I will discuss briefly about the management of TB and some of the special clinical situations. So first things first, what are the goals of the anti-TB treatment? So we all know that the early diagnosis and effective treatment of all drug-sensitive tuberculosis patients is very important to render the patient non-infectious, to break the chain of transmission, and to decrease the pool of infection so that the patient ceases to be a threat to the society. Secondly, early and effective treatment decreases the morbidity and also fatality, and by ensuring a relapse-free cure so that there is no chance of any relapse in the future. And also to minimize and prevent the development of drug resistance by early and effective treatment of tuberculosis. So what is the pharmacological basis of treatment? So unlike the normal bacterial pathogens, we all know that Mycobacterium tuberculosis is a very stubborn organism. So it is very important to achieve the peak serum levels of all the drugs simultaneously to have the maximum bactericidal effect. And because of this, so it's very essential to administer all the drugs at the same time so that these peak serum levels are achieved rather than the peak, the MIC level. So coming to the short course chemotherapy, which is given for the drug sensitive tuberculosis, the short course chemotherapy, as we all know, is for 6 months. And we also know that it has got 2 phases. The first is the intensive phase and the second is the continuation phase. So what is the role of this intensive phase? The intensive phase role is to achieve the rapid killing of the actively multiplying bacillary population so that we are able to eliminate the naturally occurring drug resistant mutants. So there can be different proportions of naturally occurring drug resistant mutants depending upon the bacillary population, so that we can further prevent the emergence of drug resistant mutants. Now, what is the role of continuation phase? The continuation phase, the role is to ensure elimination of persisters or the semi-dormant group of bacilli, which are mainly responsible for relapses. So if we give a continuation phase for 4 months, then most of these persisters are eliminated and we can achieve a cure from tuberculosis. Now, the treatment for drug-sensitive tuberculosis, now we all know there is just one regimen, that is 2 months of 4 drugs, which we give, the isoniazid, rifampicin, pyrazinamide, and ethambutol, and then 4 months of 3 drugs. Pyrazinamide is removed, so we are left with isoniazid, rifampicin, and ethambutol. So this is the 6 months regimen now given for all the drug-sensitive tuberculosis, whether it is a new case or previously treated case whose the drug sensitivity pattern is not yet known. So the previous all the categories have been abolished. Now only one regimen is left with us. So the drugs are given on a daily basis now, daily under direct supervision. The dose of the drugs are according to the body weights, which we'll be seeing in the subsequent slides. So now the treatment is given in the form of fixed dose combination tablets, which are given as per the weight bands, the number of tablets, and also loose drugs are also available, which are given in special situations like patients who have adverse drug reactions or with some comorbid conditions where we need to modify the regimen. So now there is no provision for extension of the intensive phase. Previously, there was a provision for extension when the patient again turned out to be sputum smear positive after the intensive phase. There was an extension for 1 month, but now there is no extension of intensive phase. We have to straight away go to the continuation phase, and if his patient is positive, we have to send the sputum sample for drug sensitivity testing. But the continuation phase can be extended by 12 to 24 weeks in certain forms of extrapulmonary tuberculosis like TB meningitis or the skeletal TB or severe forms of disseminated tuberculosis. And this is mainly based upon the clinical decisions of the treating physician. So, but we have to remember that any extension beyond 12 weeks should only be recommended by the experts in that concerned field. So this is how the tablet looks like. The fixed dose combination tablet, the 4 FDC, which is given in the intensive phase, which has got each tablet contains isoniazid, rifampicin, pyrazinamide, and ethambutol. And this is how the continuation phase tablets look like, which contains the isoniazid, rifampicin, and ethambutol. This tablet is a bit smaller in size than that which is given in the intensive phase. Now, that each tablet contains 75 milligram of isoniazid, 150 milligram of rifampicin, 400 milligram of pyrazinamide, and 275 milligram of ethambutol. So that is the fixed dose combination of each tablet. And depending upon the weight bands, either a patient gets to take 2 tablets, 3, 4, 5, 6, as per the weight bands mentioned here. So it starts from 25 kg, below 25 kg, the pediatric weight band. We have to refer to the pediatric weight band table. One important thing to be noted here is that if during the course of treatment, if there is an increase in the body weight by 5 kg or more compared to the baseline weight, then the patient has to be switched over to the next weight band, and the dose has to be increased. So this is very important thing. And also tablet pyridoxine is given in high risk patients who are at risk of developing peripheral neuropathy. Now, after the initial, after the treatment is at the end of intensive phase, as I told, if smear is positive, we have to send for drug susceptibility testing, and there is no extension of intensive phase. And at the end of treatment, a sputum smear or culture done for every patient, and the long-term follow-up is done at every 6 months till 2 years. We have to remember that all household contacts, especially the household contacts, have to be screened for tuberculosis, and children less than 6 years of age who are close contacts of TB have to be evaluated for active tuberculosis. Active tuberculosis have to be ruled out by a pediatrician, and then they have to be given this prophylactic INH prophylactic preventive therapy. So recently there has been a change in the guideline of preventive therapy, and previously it was 10 milligram of INH every day for 6 months. But now, apart from this, there is also a regimen, weekly regimen containing INH and rifampicin. But most important thing is that we have to rule out active disease by proper screening. Then only we can give this preventive therapy. So now coming to the treatment, that was so far as the treatment of pulmonary tuberculosis was concerned. Now coming to the treatment of extrapulmonary tuberculosis. So there are few issues, rather few controversies during the duration of antitubercular treatment in some forms of extrapulmonary tuberculosis, like the lymph node tuberculosis or the abdominal tuberculosis or the CNS tuberculosis. So how long should ATT be given? Is it only 6 months, or we need to give for a longer period of time? So as per the index TB guidelines for extrapulmonary tuberculosis, for lymph node tuberculosis, 6 months, the recommendation is only 6 months of antitubercular treatment. For peripheral lymph node TB, so it has been found, the guidelines, the committee of the guidelines were unanimous in the decision that there is no difference, there is no extra benefit by giving treatment beyond 6 months. They had compared 6 months and 9 months treatment, but there is no benefit in terms of relapse rate. It was found to be same in both the groups. It has been seen that there are some group of patients where the size of the lymph nodes, maybe a small sub-centimeter lymph nodes, persists even after 6 months of treatment. But the group recommends that observation is enough. A few months of observation is enough. No need for giving antitubercular treatment in such cases. Coming to abdominal tuberculosis, again the recommendation is 6 months only. ATT, no need for giving more than 6 months. However, in some group of patients, the patients continue to be symptomatic, but the group has clearly stated that it is found that the persistent symptoms are mostly due to the sequelae of the abdominal tuberculosis, like either there are peritoneal adhesions or luminal strictures. So there is symptomatic treatment can take care of such sequelae rather than extending the antitubercular treatment regimen. Now, coming to tubercular meningitis, this is the form of the extrapulmonary tuberculosis where there is a strong recommendation that should be treated with ATT for at least 9 months. Again, there are some groups of some groups of researchers who recommend a minimum duration of 12 months to 18 months. But as per the index TB guidelines, they have recommended a minimum of 9 months. However, it can be extended on a case-to-case basis depending as decided by the treating physician. Now coming to the carriage spine or TB spine, usually it is reasonable to start antitubercular treatment with a strong clinical and radiological MRI evidence of TB spine. And here also again, an extended course of ATT is recommended, 2 months of intensive phase plus 10 to 16 months of continuation phase, depending on the site of the disease and the clinical course. Again, it depends upon the treating physician or the surgeon. Now, the second issue is whether to give corticosteroids in these forms of extrapulmonary tuberculosis like TB pericarditis, TB meningitis, or pleural tuberculosis. So again, as per the index TB guidelines, TB meningitis, there is a strong recommendation that steroids are strongly recommended in TB meningitis in HIV negative people. So it has been seen that in all the randomized controlled trials which they had analyzed, there is a significant benefit in the mortality aspect. So mortality is low if we give corticosteroids. And the duration of steroid treatment should be minimum of 4 weeks and then tapering as appropriate from case-to-case basis. It can at times go up to even 6 to 8 weeks also. And also steroid can be given in HIV positive people with TB meningitis, provided the life-threatening opportunistic infections have been ruled out, totally ruled out. Then only we can give steroid in HIV positive with TB meningitis. In TB pericarditis, corticosteroids are recommended for HIV negative patients with TB pericarditis and pericardial effusion. It has been seen that giving steroid in TB pericarditis decreases the progression to constrictive pericarditis, and also it reduces the need for pericardiectomy. But it is not recommended for steroid is not recommended in patients who present with constrictive pericarditis. That means in patients where already the constrictive pericarditis has developed, there is no point in giving steroids. In early cases only it is given so that it prevents the development of constrictive pericarditis. And also it is recommended in HIV positive with pericarditis, with pericardial effusion, but of course we have to rule out the opportunistic infections. In tuberculosis pleural effusion, steroids are not recommended in pleural effusion. It's a clear-cut recommendation. It is no benefit, no added benefit by giving steroids in pleural tuberculosis. Now coming to the management of adverse drug reactions, so it's very important because the side effects or the adverse effects can be an important cause of patients stopping medication. We have frequently seen patients stopping medication in between just because they have developed some adverse drug reactions. So the prevention of and early detection of side effects are needed. So we have to take the history. Alcohol, smoking, and use of illicit drugs increase the side effects. We have to counsel the patients. We have to ask the patient regarding such abuse of alcohol or illicit drugs. And we have to keep educating the patients and counsel the patients, and we have to reassure the patients for self-limiting side effects so that they do not discontinue the treatment. And we should encourage them to report and to get back to us if they develop any such side effects, so that we can take care of the side effects as early as possible, so that they can resume their treatment. And for any side effects, whether it is mild or severe, we have to take immediate action and refer the patient to the concerned specialist. We'll be discussing in brief the most commonly encountered side effects like nausea and vomiting. So all first-line anti-tubercular drugs or even second-line anti-tubercular drugs are capable of causing nausea and vomiting. So how to prevent it? It has been seen that if the patient takes the tablets with banana, it decreases the nausea and vomiting to some extent. So we can give this advice or the tips to the patient. And also the management is mostly symptomatic management, and we have to, of course, exclude other causes of nausea and vomiting like hepatitis and hepatotoxicity. Then if the deranged liver function is, if we come across deranged liver function, which we commonly come across, if the enzymes are up to 2 times the upper limit of normal, then in such cases, the suspected drugs can be pyrazinamide or isoniazid or rifampicin. Pyrazinamide is the most hepatotoxic drug, so we have to be very careful. So up to twice the upper limit of normal is not that serious, and we should not discontinue the anti-tubercular drugs. Drug-induced hepatitis is reported in 8 to 30% of patients. We have to avoid simultaneous other hepatotoxic drugs, and to prevent further worsening, we should keep a track of the liver function test every 15 days in the high-risk patients. And usually anti-TB drugs are not withdrawn, I told, then and we have to check for other potential hepatotoxic agents like whether the patient has been taking alcohol or not. In case of severe hepatitis, when the AST and ALT levels are more than 3 times the upper limit of normal, with symptoms of nausea, vomiting, anorexia, jaundice, or if the enzyme levels are more than 5 times without any symptoms. So in either of this situation, it is labeled as severe hepatitis, severe drug-induced hepatitis, and again the same hepatotoxic drugs, pyrazinamide, INH, and rifampicin. So early detection is very important, so that we have to stop the anti-tubercular drugs in such a situation, and supportive treatment has to be given, and we have to again reintroduce the drugs one by one. When the enzyme levels comes back to normal, we have to wait for 2 weeks, maybe 4 weeks, 3 weeks. Here, one important thing to be noted is that if patient is infectious, the patient has got severe category of disease, then we have to substitute with other non-hepatotoxic drugs like either streptomycin, quinolone, or ethambutol, so that the treatment is not discontinued during this period. Another very commonly encountered adverse effect is skin rash or urticaria. Again, all the oral anti-tubercular drugs are capable of causing skin rash. So we have to seek the past history of allergy before starting treatment. And coming to the management part, if the rash involves less than 10% of the body surface area and not associated with mucous membrane involvement, then we can just treat with antihistaminics. That will take care of the skin rash. We have to stop the suspected drug and refer to a specialist if required, and desensitization can be attempted if it fails substitute with alternate drugs. So again, this desensitization has to be attempted in a particular sequence. The least potential drug to be started first. Usually the first drug to be reintroduced is the isoniazid, then rifampicin, then pyrazinamide, then ethambutol. This is the sequence because ethambutol most likely causes the skin rash. Now coming to the next common side effect is arthralgia or arthritis, and most commonly caused by pyrazinamide. So patient usually complains of joint pain, swelling involving one or more joints. On investigation, we usually find high uric acid levels. Demonstration of tophi crystals in joint is confirmatory of gout. Patient may develop drug-induced gout. So early diagnosis and management can prevent the further progression. So we can just give simply paracetamol or any NSAID for the pain relief, and colchicine can be given in case of gout. Coming to peripheral neuropathy, which is at times very difficult to manage. So the suspected drugs can be isoniazid, PAS, ethianamide, cycloserine, and linezolid. Linezolid is known to cause very severe forms of peripheral neuropathy at times. So how to prevent? Usually pyridoxine is given in the dosage of 5 to 10 milligram per kg per day, while patient is on INH, or 50 milligram per day while patient is on linezolid, or 50 milligram per day when if the patient is taking second-line drugs like cycloserine. Every 250 milligram of cycloserine, pyridoxine 50 milligram has to be given per day. Coming to the management, usually drug withdrawal is not indicated in peripheral neuropathy. To alleviate the pain, we can give paracetamol or NSAID, and pyridoxine given in the dosage of 100 milligram per day. If there is no response, we can increase to 200 milligram per day. And also we can add amitriptyline if there is no response. And then we can refer to a specialist, the neurologist, if needed. Now, coming to management of TB patients in special situation, there are some certain specific clinical scenarios. I think something happened. Is my screen visible now?
Yes, visible. And Dr. Sorin, how many slides are there?
Madam, 4 or 5 slides are left, madam. Madam, if you, in the want of time, shall I stop now?
Slides, 4 or 5 slides. Please finish.
Okay, madam. So tuberculosis in pregnant and lactating women. So we have to take a history whether there are any currently ongoing pregnancy or any planned pregnancy. So usually all the first line drugs are safe during pregnancy except streptomycin, and breastfeeding should be encouraged during the course of antitubercular treatment. The mother has to be advised regarding cough hygiene measures. And of course, we should remember to give the baby 6 months of isoniazid preventive therapy and also pyridoxine supplementation. Now, the contraceptive pill usage during antitubercular therapy. So usually the efficacy of oral contraceptives decreases due to rifampicin, vomiting, and secondary antitubercular therapy. So what option does the woman has? So either she has to use an oral contraceptive containing higher dose of estrogen, or use an alternative method like barrier or IUD. So coming to TB in patients with liver disorders. So in patients with pre-existing liver disease, clinical and liver function test monitoring should be done. And there is no, patients who have got hepatitis or acute hepatitis, current excessive alcohol consumption, they can continue to use to have antitubercular drugs, provided there is no evidence of chronic liver disease. But if the baseline serum, the enzymes are more than 3 times, alternative regimens have to be considered, like the 9-HRE. There are various different regimens as per the choice of the physician can introduce. Now, coming to TB patients with renal failure, the patients suffering from chronic kidney disease are at increased risk of developing TB. TB should be considered in all patients with unexplained systemic and peritoneal TB is very common in patients on peritoneal dialysis. So in such cases, usually the doses should be thrice weekly for ethambutol, paracetamol, and aminoglycoside. And the treatment can be given immediately after hemodialysis or 4 to 6 hours before hemodialysis. Now coming to TB in patients with seizure disorders. So isoniazid and rifampicin may interfere with many of the anti-seizure medication. Higher dose of isoniazid should be avoided in patients with active seizure disorder, and prophylactic use of pyridoxine is usually given to prevent seizures. So summarizing whatever we had discussed, so we have seen that effective treatment with a complete course of anti-TB regimen is the most important way to decrease the morbidity, mortality, and emergence of drug-resistant tuberculosis. Prevention, early detection, and management of side effects of anti-TB drugs is crucial in ensuring completion of anti-TB treatment. Educating and counseling the patient from time to time helps in successful treatment of tuberculosis. And it is always advisable to refer the patient to a specialist in case of any adverse drug reaction or associated comorbidity or any emerging complication. So thank you very much for your patient listening.
On the treatment of the drug sensitive cases, whether it is pulmonary or extrapulmonary tuberculosis cases, the detailed description of the side effects, how to manage those things, and in special situation like severe disorder and CKD, the situation where you have to manage with anti-TB drugs. Now there are certain questions, Dr. Saurin. Is there any study that has shown a decreased nausea and vomiting when taking banana while the patient is on ATT?
Madam, I am not aware of any particular study, but it has been recommended in the guidelines, the national guidelines, that if we give the antitubercular drugs along with banana, it decreases the nausea and vomiting to some extent.
Question or not, we don't.
That is not a question. Okay, thank you, Dr. Saurin, for your excellent presentation. There's another question. Now I will request Pritilata Madam for the concluding remarks for the entire session. Personally, I would like to thank all the speakers who have given their excellent presentations, which are very informative also. Madam, give the concluding remarks.
Okay, Dr. Dipti, this session is very good and very informative. Everybody enjoying, I think everybody has enjoyed this session knowledge-wise, and their expertise deliberation will enlighten their knowledge. Later.
Dr. Jyoti Madam को भी अनुरोध।
Yes.
Hello. Can you hear me now?
Yes, yes. Kavita, bolo.
Yes, ma'am.
Okay, good afternoon, everyone. Thanks, Vajanti, for inviting me, and congratulations for organizing a great meeting. And it's really great that you're organizing a series of meetings. So congratulations and thanks both together. So I have a proud privilege to invite Dr. Shampa Anuparva, who's a dear friend and know her since long, and she's a supportive as always for everything. She is professor at the Institute of Medical Sciences, BHU Varanasi. She has been awarded with Commonwealth Fellowship in 2006, and she's been a fellow of National Academy of Medical Sciences. She is nodal officer, Culture DST Lab, NTEP, and SNAC. More than 100 publications to her credit, and of course she's doing great work. She has also been involved with IMM very actively. She has organized the IMM conference also very nicely, and we really enjoyed. So it's a proud privilege to invite her to deliver her talk, Diagnostic Discordance in Drug Resistance TB. So over to you, Shampa.
So thank you, Dr. Basri. It was really a surprise that you were going to chair my session. And I thank Dr. Vajanti for giving me such an important topic to discuss. Let me first share my screen. Okay. I hope my screen is visible. Can anybody tell whether my screen is visible or not?
Yes, ma'am. Your screen is visible. You can continue, ma'am.
Thank you. It's a very important topic that I've been allotted, that is diagnostic discordance in drug-resistant TB. Only when I was given this topic, I came to know that there is so much to learn about this topic, and I hope I'll be able to do some justice to this topic.
Ma'am, there is some background noise from your side.
Here, I don't think there's anyone. I'm just sitting all alone and talking. Anyway. Anyone?
No, in between it's clear. Now it's clear, ma'am.
What should I do then? There's nobody here. I'm all alone sitting and presenting. Should I stop and or is it clear now?
Not clear.
Ma'am, you can change the microphone because the microphone is the problem. There is some sound in the microphone.
Microphone कैसे दूसरा लैपटॉप
Because here I'm sitting in front of a desktop.
Ma'am, start your audio from your phone and you can present from your laptop.
Yes, this can be done.
From my mobile. Just a minute.
Okay.
Okay, sorry about that. Is it all right now?
Yeah. Yes.
Audio is clear.
Okay. So with all the talks that we have already had, we now understand that a very accurate and timely drug susceptibility testing is a cornerstone of a successful treatment, whether it is drug-resistant TB or drug-sensitive TB. And inadequate drug susceptibility test results will lead to poor clinical outcomes, which will allow ongoing transmission of the disease. In recent years, laboratories have seen an accumulation of several methods. Dr. Baijanti has already highlighted all the methods very nicely. But a natural consequence of this is that discrepancies are bound to occur between the different methods. And it is very difficult to detect these discrepancies because drug susceptibility testing is expensive, technically challenging, and laboratory usually will only have one method available. So we will not actually know whether we are giving a correct result or not. And if there is a high discrepancy rate of the chosen method, it will have direct clinical consequences. Again. So my talk will be mainly focused on three main areas. That is, whether is it really a matter of concern? What are the reasons behind this discordance and how to troubleshoot some common issues in the laboratory? So at the beginning, let us just have a look at this diagnostic algorithm for drug-resistant TB. Up till now, drug-sensitive TB has been discussed. So we will have just an overview of drug-resistant TB. So we know that all patients could be presumptive TB or notified TB or non-responding to treatment. They should be giving samples for the nucleic acid amplification test, which could be gene expert or TrueNAT. And we will get a result, either rifampicin resistance not detected or rifampicin resistance detected. We could also get a rifampicin indeterminate result, for which a repeat sample, I mean, of course, 2 samples are given for the nucleic acid amplification. So second sample, again, we test for when there is indeterminate result. And if the second sample also gives an indeterminate result, then a fresh sample is asked. Now, if rifampicin resistance is not detected, we have to look for INH resistance by the first line LPA. In the first line LPA, if isoniazid resistance is also not detected, then we give drug sensitive TB treatment, which has just now been discussed nicely. But if in the first line LPA there is isoniazid resistant, then we have to do a second line LPA and the DST for pyrazinamide. And if there is resistance to pyrazinamide or there is resistance to quinolones, then we have to do a DST for moxi at 1 microgram per ml and linezolid. So this is for resistance for INH. And if rifampicin resistance has been detected, then we have to do first line LPA, second line LPA, and DST for moxi, linezolid, and pyrazinamide. Clofazimine, bedaquiline, delaminid up till now are not available in all the labs. So this is the algorithm which we have to keep in mind while discussing discordance. So I want to here highlight that there is at no point are we doing rifampicin susceptibility. So we are taking it for granted that what nucleic acid amplification test is detecting, whether it is resistant or sensitive, we are taking it to be resistant and sensitive. And there could be problems with this. So is discordance a matter of concern? The Lancet Infectious Disease in 2019 has shown that mortality was higher among TB patients in high prevalence countries when the AST results were inaccurate. And what is the result of these inaccurate results? In disease endemic settings, this can lead to misinterpretation of the disease burden, undermining the TB outcome, and incorrect planning of the TB control programs, which has huge public health implications. So public health importance is a very important component of our TB control program, which may be derailed. Also, discordant results will lead to multiple repeat testing to exclude laboratory and human error, which will incur more costs and further delay in instituting appropriate treatment. So there again, if the patient is not treated at the appropriate time, he will be a source of transmission of the disease. Clinicians face difficult decisions on whether to initiate the MDR-TB treatment based on the molecular result or stop MDR-TB treatment based on a DST result. So this has clinical significance, which will result in adverse patient outcome. And most importantly, patients would be possibly transferred to a MDR-TB facility and exposed to the resistant MTB strains. They might be harboring a sensitive strain, but if they have been diagnosed as MDR-TB, they will be naturally referred to a MDR-TB facility and will be exposed to the resistant TB strains. So now we know that how important this diagnosis of drug resistance is. Now, what are the reasons behind this discordance? First and foremost is the laboratory or human error, which is the root cause of discordant results, which can range from human or laboratory errors, either pre-analytical, post-analytical. I'll be subsequently elaborating. Then there can be discordance between phenotypic and genotypic, between different genotypic results, and between different phenotypic results. This depends on the limitation of the assay itself. So sample can be mixed up due to clerical error, and this is the most important cause of discordance, which is overlooked during the TB-DST testing. These laboratory errors can occur within a lab, between the labs, between different methods, and in the same method itself. So what are the pre-analytical factors? Either insufficient sample or incorrect sample, improper collection, misidentification resulting in transcription error, transportation error if they are not transported in cold chain, or the incorrect test is ordered, or reagents and media have expired. Analytical problems can be due to equipment malfunction, cross-contamination between specimens, if SOP has not been followed properly, or quality control has failed. Different bacterial populations are tested from different specimens. So like, for example, one is an original isolate, one is a subculture isolate. They might give a different result. Size of the inoculum is very crucial. And phenotypic DST from an old culture with bacilli no longer in growth phase, then also you have your problems. Post-analytical problems can be during reporting and interpretation, erroneous validation of the data, or improper data entry, test result loss, and excessive turnaround time. So if your samples have been kept for a long time, then also the efficiency, the accuracy of your results will be lost. It will be inaccurate. So before we, so this was all about the human or the laboratory errors. And now I would like to discuss the discordance between phenotypic and genotypic. And before that, I would like to emphasize that phenotypic DST itself is prone to several technical errors. Correct performance of the phenotypic DST requires understanding of the resistance and interpretive criteria, stability and antimicrobial activity of the drugs, interpretation of results and reporting growth kinetics of the strains. And it requires skill in preparation of the critical inoculum size, which is needed to reduce the variability for the DST methods. And of course, the human error will always be there for all the methods if there is labeling error, cross-contamination, or specimen mix-up. So keeping this in mind, now there can be discordance between phenotypic and molecular tests. When molecular and phenotypic DSTs are performed sequentially or in parallel, these discordant results can invariably occur. Now, resistance at the phenotypic level, which means that molecular, it will be sensitive, but phenotypic, there will be resistance. When will this occur? If mutation is outside the targeted hotspot. So we target the hotspot, the maximum 97%, 98% mutations will occur within here, but there may be some which will be outside the hotspot, which we have not targeted. And so we will not detect at the molecular level, but when we do a phenotypic DST, we see that it is resistant. Then resistance at the molecular level. So genotypic, there will be resistance, but phenotypic, it will be sensitive. This again, there will be technical errors, but apart from that, there may be silent mutations which are not expressed, or a low bacterial load, disputed mutations, and heteroresistance. I'll be coming to each one of them subsequently. So phenotypic DST versus gene expert, it has been seen that now widespread use of expert MTB-RIF assay or the gene expert has revolutionized the diagnosis and management of the RIF resistant TB. This is what Dr. Baijanti just now told, that it is a game changer because it has integrated real-time PCR, which is developed to simultaneously detect TB and RIF resistance via mutation in the rifampicin resistance determining region of the RPOB gene. But one should keep in mind that there can be discordant results between the gene expert and phenotypic DST. Similarly, phenotypic DST versus LPA. So there has been a study which has shown that overall discordance was 7.2% for INH and 14.6% for RIF after ensuring quality control between phenotypic DST and LPA. So taking culture-based DST as the gold standard, if all clinicians initiated treatment based on the initial molecular result, that is LPA, then 25% of patients would be incorrectly treated for MDR-TB and 5% of patients with MDR-TB will be inadequately treated with susceptible antitubercular drugs. This is from a paper which was published only in 2020. So now we understand that there is discordance between phenotypic and genotypic detection of resistance. Now, if, as I told in the beginning that if there is mutation outside the targeted hotspot, then phenotypically it will be resistant, but genotypically sensitive. So there, it has been observed that 30% of MDR strains had a mutation in the 491 position, which is not detected by the expert MTB-RIF. And according to algorithm, if we will definitely miss these cases, and phenotypic DST is not indicated when they are sensitive on gene expert. So we don't do a phenotypic DST, and we will definitely miss these mutations. We will consider them as resistant. So patient with an isolate with a significant mutation in the RPOB gene are treated with a regimen based on primary drugs. They will be at high risk of therapeutic failure, resulting in community transmission of the isolate. And when there are silent mutations, what happens actually is the nucleotide change is changed, but the amino acid does not change. In the presence of silent mutation, the molecular probe will not hybridize, indicating a mutation of the RPOB gene. So patients with silent mutation are treated for resistant RR-MDR or MDR-TB and unnecessarily will be treated with a prolonged and toxic regimen. These cases are being overtreated according to the algorithm due to expert result interpreted as resistant. This is also a condition very low bacterial load. Discordant results have been observed in specimens with a very low bacterial load. Cases falling within the very, I think, before this, let me just remind everyone that in the gene expert, according to bacterial load, we have high load, moderate load, low load, and very low load. This is also shown in, we get the report. So cases falling with a very low group may more likely to be misdiagnosed as RIF resistant. And occurrence of false positive results is due to unequal efficacy of the probe binding. So all the 5 probes should bind in order to give sensitive. In a very low bacterial load, if the probe binding is not proper, then it gives a false RIF resistant result. And when do we get this low bacterial load? Mostly in pediatric or extrapulmonary or HIV co-infected pulmonary TB patients, the samples have extremely low bacterial loads. So in such cases, a RIF resistant has to be rechecked, cross-checked, because we are not sure whether it is a true resistant or a false resistant. Then this is a very important category of disputed mutations. So here, the DST can yield highly discordant results among proficient laboratories with absolute all quality controls due to the existence of strains with borderline susceptibility. These mutations affect the fitness of the MTB, causing it to grow slowly during the phenotypic DST, mainly by the liquid culture. So they have a very slightly increased MIC compared with the wild type. So, and it still falls in the sensitive MIC. So RIF resistant disputed mutations are frequently missed by the midget 960. So many mutations, this is not a complete list, but these are some of the mutations which are missed by the midget 960, like 516, 526, 572, 511, 533. These are associated with discordant DST results. So these mutations will lead to low level or borderline resistance and known as phenotypic occult MDR. So we have seen that phenotypic and genotypic DSTs vary greatly when detecting this occult rifampicin resistance. In another study, it has been seen that 16.2% will exhibit RIF resistance in gene expert, but phenotypic susceptibility. And sequencing has shown again that 25% was due to 511, followed by 17.3% 533, 9.6% 526, and 6.7% at 516 position. So earlier it was thought, when we did not know about these disputed mutations, we thought that probably expert assays incorrectly giving them rifampicin resistance. So in 31% of cases. But when these cases were followed up, so based on phenotypic DST, we were not actually giving importance to the expert RIF resistant, and based on phenotypic DST, it was seen that treatment failure was significantly associated with the presence of mutations that were not detected in the DST. So clinically relevant resistance may not be detected by high critical concentrations for scoring RIF resistance, and modification of the existing testing methods is recommended in order to detect RIF resistance. So there are some studies where they have recommended different modifications, like prolongation of the incubation period, or using a larger inoculum size, or lowering the critical concentration, which may be more sensitive at detecting the gene mutations that confer low level RIF resistance. So now it comes to whether our culture should be considered as the gold standard. So it has been seen that midget 960 is an accurate method for DST against isoniazid, but fails to detect low level yet clinically significant rifampicin resistance. So it should be reconsidered as a gold standard for detecting resistance to rifampicin. In the same line, of course, we don't do phenotypic DST for rifampicin anymore, but we are doing for moxifloxacin, and the critical concentration of moxifloxacin has been lowered from 0.5 to 0.25 for midget. And the clinical breakpoint has also been lowered from 2 to 1 milligram per liter. This has captured most low-level resistant mutants, which were earlier not captured when it was 2. So when it was 2 earlier, it was not detected, so we were reporting as sensitive, but now it has been decreased to 1. So for any strain that is moxifloxacin resistant at the clinical breakpoint of 1, should not be considered as an effective drug in the regimen. This has come in the technical report series of WHO. Now, what is the implication of disputed mutation? Are we actually wrongly treating the patients? Results of rifampicin susceptibility, of course, should be complemented with DNA sequencing based method when the suspicion for resistance is high. And WHO has deemed that, but what we are doing according to algorithm is that any mutation, excluding the silent mutations, identified in the rifampicin resistant determining region of the RPOB gene is known or assumed to be associated with rifampicin resistance. So here we are actually not missing. We are not doing a phenotypic DST. So here, in one way, it is good that any mutation, of course, we are not able to exclude the silent mutations, but at least we are, the disputed mutation cases are all included under resistant category. And we are, as per algorithm, these patients are considered resistant and treated accordingly. Now, heteroresistance. When there is high rate of MTB transmission in highly endemic populations, it increases the prevalence of mixed infections. And cultures that contain both susceptible and at least 1% resistant bacteria are defined as heteroresistant. Mixed infections with multiple strains of MTB create a challenge for DRTB testing and treatment. And clinicians receive results that are dependent on the level of detection of the assay utilized. Heteroresistance is picked up by the line probe assay, molecular typing, or by genome sequencing, but we usually miss it by the gene expert. Line probe assays explicitly detect heteroresistance with both hybridization of wild type probes as well as mutant probes known as mixed patterns. So I will just tell that Dr. Baijanti has told that we have resistance detected or resistance inferred. This is also resistance detected, but it is both wild type as well as, so if only wild type is present, it is sensitive naturally. And if probe is present, it is resistant. And here both are present, so it is mixed, it is heteroresistant. But expert assay has an increased false negative rate for detecting rifampicin resistance with mixed infections. In hyperendemic settings, where mixed infections are common, expert results might need further confirmation. Existence of heteroresistance, silent mutations, disputed mutations warrants that all RIF-resistant TB cases diagnosed with the expert should be referred to specialized centers with access to a DNA sequencing. So I'm giving the background that how much DNA sequencing now is important, because with so many methods, there is problem in true diagnosis. So we have discussed about human error. We have discussed about discordance between phenotypic and genotypic. Now we'll come to discordance between molecular platforms. So concurrent dual use of differing platforms has created a challenge of discordant results, creating a diagnostic dilemma. There can be human error, of course, but it can be also due to both the platforms not looking at the same segment of DNA. Like, for example, one may be looking at a particular SNP in one codon, whereas the other is looking at 30 codons. So there will be difference. And of course, about heteroresistance, I've already told. So in such cases, again, DNA sequencing analysis may be helpful for identifying the reasons for discordant results between the two molecular tests. And there has been a study in this week. The most common reason for discordance identified were possible false expert RIF-resistant results in 22% cases, mixed infection in 16% cases, transcription error 7%, and erroneous interpretation of the LPS strip 7%. So this is a report which has been published in 2021. Now, this is also an important study where 23 discrepant results between LPA and gene expert were studied by sequencing. So they found that there was 91.3 concordance with LPA, but only 8.7% concordance with expert. And so they concluded that expert MTB RIF results may be a disastrous step for TB control programs, as this test gives alarmingly high false negative results, and resistant MTB isolates are falsely labeled as susceptible. And this is a study actually done in India by Dr. Sharman Singh's group, who has, and this is published in 2014. On the other hand, there is another study which shows that sequencing of the core region for 8 discrepant isolates revealed that expert is more accurate than LPA for detecting RIF susceptibility in discrepant results. So we cannot actually tell LPA is better or expert is better. Some studies will show expert better, some will show LPA better. The summary is that between the two molecular tests, there can be discordance. Now, the discordance between the phenotypic methods, that is solid versus liquid. In one study, it was seen that ethambutol was discordance was higher compared to rifampicin, isoniazid, and streptomycin. That means 49% isolates were falsely susceptible to ethambutol by liquid culture compared to the solid, whereas 20% streptomycin resistant results could be categorized as false resistant. And it was mainly discussed or explained. The explanation given was that hetero-resistant population are slow growing, so in liquid medium we might miss them and we might give a false sensitive result. And these are the same positions of hetero-resistance, and it has been seen that the midget DST fails to give a result or declares the strain susceptible. So this mutation systematically missed by midget are either located at the extreme ends of the RPOB hotspot region or outside the core region, and location of mutation may interfere with the fitness of the strain, pointing towards slow growth as a factor responsible for drug susceptibility. So with this, now I would like to just briefly discuss a few cases, which are actual cases seen in the lab. So this is a LPA strip which just shows a TUB band, and there are no other bands, no wild type, no mute, nothing, no quality control, nothing is there. So, but the report that they have given, because interpretation is wrong, they have given as resistant and isoniazid resistant. So in such cases, if such a patient is notified and MDR treatment is started without actually verifying, there's no way. I mean, if you give the result, it is fine. If you don't give also, you can start the treatment. So there is a problem here, which can occur and must be occurring. And now that we have TrueNAT, so TrueNAT, the disadvantage of TrueNAT is that you have to first test for MTB and then test for rifampicin resistance. So from the periphery, when we are getting, mostly I find that they are not even doing the RIF resistance. Once TB is detected, they are sending. So they are reporting as either not available or indeterminate. But anyway, we have to do first line LPA for all these samples, and again, we have to do second line LPA. Of course, we would have, if RIF sensitive, we would have done both first line, second line. If RIF resistant, depending on the isoniazid result. So but recently there was a case where TB was not detected in TrueNAT, but probably due to the clinical signs and symptoms, the sample was sent to our lab, and in Niksha it has been also reported as TB not detected, but we got, so it is not detected and we are confirming. So there's a screening test and a confirmatory test. So screening it is not detected. Normally, probably we would not have done also, but they have sent and we have done and we got RIF sensitive. So such cases can occur. We have to be alert towards such cases. Then there's a case where RIF resistance was detected by expert, but on DST, INH was resistant, but RIF was sensitive. And when we did sequencing of this, we found that this was a silent mutation. So actually only the codon is changed, but amino acid is the same. So this was a silent mutation. So we can, we should not have, this should not have been given as a resistant case. Then here, this is a MDR-TB patient follow-up second line LPA result. We have done fluoroquinolone has come as resistant, but phenotypic DST in 0.25 microgram comes as resistant, but 1 microgram came as sensitive. And there were many such cases where actually the dose of course, the management will be taught separately. So will be told separately. I'm not going to the management. In such cases, mostly the moxi dosage is increased. So here I would like to show that these are the cases 550, 558, 557 for lab where there are mutations in the GYRA1. But see, molecular wise, all three have 3 different patterns. In one, there is only MUT3B is present, one MUT2 and MUT3B present, and the other wild type 3 absent and MUT3D present. But phenotypically, all of them had same resistant at 0.25 and sensitive at 1. So this sort of discordance can occur. Then peripheral lab gene expert versus LPA and gene expert at the culture DST lab. So peripheral lab reported as RIF sensitive, but when we did LPA, we got MDR, all wild type present and MUT1 was present. So it was a heteroresistant case of rifampicin. And when we repeated, that is the as per protocol, as per algorithm, once there is such discrepancy, one should repeat it again in the CDST lab where it came as RIF resistant. So it was troubleshoot here. We have a RIF resistant case in LPA and a RIF resistant case in the gene expert. So I would like to show that in heteroresistance is not a very rare condition. In one day itself, we had 3 cases heteroresistant. So here, all these 3 are, they have all the wild type 8 bands as well as MUT3 is present in all these 3 cases. So it is not so rare that we should not be thinking about heteroresistant. It is not, we should not think that it is not our problem. But here the troubleshooting was that gene expert also had detected. So there was no problem, but it may not detect. We know gene expert may not be able to detect heteroresistance. At least here we did not have a problem because even if we had repeated, the algorithm says that if there is discrepancy, we have to repeat with gene expert in our lab. And gene expert would have given sensitive. And any 2 out of 3 should be considered. So 2 gene experts at the periphery and our lab would have given sensitive. Only LPA was different. So in such conditions, we might have to give sensitive. But luckily, this was all resistant. So this was all about discordance in drug-resistant TB. Finally, I would just like to show our own study where discordance in diagnosis of TB itself. So we know that all liquid cultures which are diagnosed have to be confirmed by capilla test. So there were 60 such isolates which were capilla negative on capilla. They were culture positive, ZN smear positive, but capilla negative. But they look very much like MTB from the flakes, from the culture growth. They look like MTB. So we, as a part of our study, we did LPA as well as PCR and finally did sequencing. And we saw that all these 10 isolates were having mutations in the NPT64 gene for which we missed them on capilla. So just based on capilla, if you do identification, there may be again some false negative results. So this paper was published in BMC Infectious Disease. So with this, I would just like to show the recommended methods. WHO says that the reference method for rifampicin is not MIGIT, but DNA sequencing. Whereas for the others, it is mostly MIGIT. Pyrazinamide, again, DNA sequencing, and ethionamide, I think. Rest all MIGIT, levofloxacin, moxifloxacin, amikacin, clofazimine is MIGIT. And ethionamide DNA sequencing. So DNA sequencing should be relied upon on rifampicin, ethionamide, and pyrazinamide. Rest all you can confirm by MIGIT. So summing up, accuracy problems in the laboratory will always exist. Laboratories must have protocols in place to detect these errors. With the advent of new diagnostic platforms, laboratories will have to deal with greater discordance between the results, and discordance between genotypic phenotypic tests are increasingly being recognized. But from a laboratory perspective, the resolution of these results is challenging. It is important to know the limitation of all platforms and the causes of discordance. Equally important to look at these results from a bedside perspective. So tests should not be interpreted in isolation. Clinical correlation is very important. It remains pivotal in the appropriate management of patients. So if you are suspecting drug resistance and you give a sensitive result, then the clinician should come up to the laboratory and discuss, or similarly vice versa. If we have given a resistant result and the report has come as sensitive. So there is need for good communication between laboratory and clinician in the management of patients with discordant result. And sequencing-based techniques may assist with the identification of exact SNPs that will be required to resolve a discrepancy. Implementing large-scale sequencing application for routine diagnostic TB is urgent to avoid ineffective drug treatments with fatal outcomes, especially in high-burden TB regions. As we enter an era of complex drug resistance and proliferation of new methods, the importance of this issue will only increase. Understanding the extent to which discordance exists in endemic settings will help guide development of appropriate laboratory diagnostic algorithms and clinical decision making. So the take-home message is that laboratory personnel, clinicians should be mindful of possible discrepancies. Molecular tests detect resistance at genetic level, but not the ultimate phenotypic expression. Conventional DST may be unable to detect low-level resistance due to presence of disputed mutations. DNA sequencing may help in minimizing discordant results. Good understanding of epidemiology and molecular resistance mechanisms is important to appropriately interpret phenotypic DST results. Thank you.
Thank you, ma'am, for that wonderful presentation. So we'll look at if there are any questions in the chat box. So there is one question. Do you think result by molecular method Do you think results by molecular methods in coming years are most effective method for detection of the disease?
I think that we have to now consider sequencing facilities should be given to some of the high throughput labs, and there should be a method of referral, because maybe those who are not responding to treatment at least, because this is, we have laid down very good. I mean, that is very good as per, like for example, now this gene expert, maybe WHO recommendation, but then country there will be difference where there are endemic settings. So more of validation in those places. So all those are required. Like we have gone in general for the whole country, one method cannot be possible. I mean, we cannot have several algorithms. But then if you see that so much of discordance can occur and we have to give more importance to these, then we have to have some way of troubleshooting this discordance, because
GAIR-A and GAIR-B are more focused towards resistance in the fluoroquinolones and the ethambutyl mutations and PNCA. Let me explain a little more about this to give you an idea of what is happening here. So I pulled out one of these databases from the scientific report in the recent publication, where it has shown that in GAIR-A and GAIR-B, which is responsible for resistance to fluoroquinolones, we have different platforms reporting different number of mutations. So what happens here? So this is 69, 18, and 16. Again for CATG and INHA, 30, 13, 11. So there are so many number of mutations. Look at PZA. So we have 1,200 reported by some platforms, 278 and 277. So where are we in terms of where is the uniformity? How do we know which are the most important mutations? What is required? And how do we work with to understand what are the ones that we have to focus on for a clinical outcome or a treatment with all the discordance that is being already discussed.
Hello. Good evening. Batao.
Okay, so let us zoom in on one of the gene to see the sequence of this 81 base pair hotspot region to understand why we are seeing so much of discordance between the different methods and how this mutations has evolved in this particular area. So this is the 81 base pair rifampicin resistant drug resistance determining region. So when you look at this, all the small alphabets with the red are all the mutations that can happen in terms of the wild type gene, wild type allele. So here within this 80 base pair, we have so many different mutations, and at this region alone, we have 4 different types of mutations. All of these mutations contribute to drug resistance. And like what was mentioned, this drug resistance is identified by 2 different ways. In a molecular capture method, in a line probe assay, they give the wild type probe for binding, and they also have specific targeted mutation probes to bind. In case of gene experts, it's on the reverse way. So they have got wild type probes. When a wild type probe for that region does not develop or a CT value is not obtained, they call it as a rifampicin resistance. With this much of complications, it is more important to know what is a specific mutation which is present, which actually decides on the treatment outcome of a patient. In both in terms of understanding which drug resistant mutation is present, and in also understanding which mutation has a borderline resistance, which mutation has a high level resistance. So for borderline resistance, when we go for phenotypic TST with the current cutoff, it is not able to detect the rifampicin resistance. This also we have observed in our own findings, which I'll be explaining to you later. So this is for RPOB, and the same happens for all the other genes like INHA. When you see INHA, you have 5 or 6 of these mutations, which can contribute to about 60% of the resistance that is being attributed to INHA. But the remaining 40% is still distributed across the genome. It is not clustered. And for ethambutol, again, there are 4 or 5 mutations which contributes to about 40% of this drug resistance. Look at CADG, one of the most important high-level drug resistance for isoniazid. It is contributed by 6 or 7 of this mutation, and still it performs only 40% of detection for CADG. And PZA, it is not a hotspot mutation. It is spread all over the genome. And again, with all these known mutations having phenotypic drug resistance, it contributes only 20% of the known drug resistance for pyrazinamide. So with this situation, so it is very essential that we go forward. So how are these commercial tools designed? Basically based on the most prevalent mutation, which has a very good concordance in terms of clinical output as well as in genotype and phenotype combination. Those mutations are picked up and put into the current commercial tools. So what about the rest? If it is only 40% for CADG, what about the rest? And again, 20% for pyrazinamide, what about the rest? This is where the sequencing tools can help and build the data in a period of time to add up more information and give a better sensitivity and specificity even for a molecular kit. So I hope I was able to convince at least sequencing is good help to add a value addition. And just to consolidate the information of what we have from the ancient times till today, we started off with microscopy, then went to solid LJ, then liquid LJ, LPA, and NAT test. Over a period of time, it reduced the time of detection for mycobacterium as well as for drug susceptibility testing. It increased the sensitivity, especially when you go with molecular tests, but the cost effectiveness actually goes higher and higher here. So this is the current scenario. With the sequencing, definitely it's going to be more costly, though we keep saying that the cost is coming down. But the cumulative cost, if you want to do a whole genome and identify all possible drug resistance and compare it with the liquid culture, performing a 12 drug or a 14 drug susceptibility testing, the cost is almost matching these days with a better platform and a bigger platform. So that's the positive aspect. So this is to move on to understanding what are all the current platforms available for genome sequencing. We started off with the Sanger sequencing, which was the oldest method, more tedious method, more labor intensive and more time taking. We moved on to the second generation sequencing, which includes the current next generation. Second generation is the next generation sequencing, which is more roboted, more faster, and less time consuming. And it is also has a high throughput and it's more robotic. The third generation is now what we are anticipating, a point of care testing for whole genomes using the nanopore nanopore or PacBio. PacBio is again still requires an infrastructure development. Till now, sequencing methods cannot be a point of care. Nanopore could be possibly developed further for this reason, but Illumina or other MySeq or second generation, next generation. So this was the understanding. And we also have a new now a publication which has been accepted, and we have tried to show what are all the major important mutations that are present in the circulating strains of our country, which is associated with the drug resistance for CATG and FABG1 promoter region. FABG1 promoter region, the C15T is present, but T-8C is not there in our current diagnostics. And also the INHA mutation, which has cross resistance between ethionamide as well as isoniazid is also prevalent. And rifampicin, we have all the known mutations, prevalent mutations are all present in our strain collections, what we have seen from about 494 isolates that we have recently sequenced. And what we also try to do was try to associate the different types of lineages with the drug resistance. I think all of you are aware that we have different types of lineages of Mycobacterium tuberculosis. And in India, we have from the 486 isolates that we had sequenced, we identified both lineage 1, lineage 2, lineage 3, as well as lineage 4, which is present on the left-hand side. And if you look across the pattern, you can see that the red ones refer to resistance and the blue lines refer to susceptibility. So for the lineage 1, if you look across, we can see that you had both isoniazid and rifampicin in most of the collections, whereas the injectables are now not in place, but we also had ethionamide and pyrazinamide resistance extensively associated with lineage 1. And the more number of drug resistance were associated with lineage 2. So it was both, it was a combination of isoniazid, rifampicin, streptomycin, ethambutol, and also had levofloxacin, moxifloxacin. This was also confirmed both by phenotype as well as by sequencing. This was a concordance rate of both methods that we tried to analyze and understand how is the drug resistant pattern associated in terms of lineage. And though it is not mentioned in the paper, we do see a difference in the distribution of the lineages across the different parts of the country as well. We are coming up with the analysis on that as well. And this is the finding. So where lineage 2 is more associated with this resistance. And to move on, so there were also other publications where they were able to pull out by whole genome sequencing, comparing it with the current WHO's recognized methods of diagnosis with the phenotypic DSD, that WGS definitely gives a value addition in terms of identifying drug resistance. For the different lineages mentioned here, this publication comes up and adds up identification of more drug resistance in all the 4 lineages, and most significantly in the lineage 3 and lineage 4 by the data obtained from the whole genome sequencing. And even in terms of drug resistance, when it was split, they can see that there was an increased identification of drug resistance for all the 4 drugs, and it was very significant when they did whole genome sequencing compared with the current phenotypic DSD and the WHO approved diagnostic methodologies. So the one of the other side of doing a whole genome sequencing is to perform the data analysis, which is huge and intensive. So there are so many different bioinformatic pipelines and softwares available, where it is an open source software for collating the information and identifying either lineage or understanding drug resistance, mycobacterial lineages, speciation, the phylogeny, whether it is lineage 1, 2, 3, 4, 5, or 6, and what kind of inputs to be given, what is the output that can be provided by each of these platforms. So there are so many different ways of doing it. What it did not, even NIRT, we have come up with our own indigenous pipeline, which can differentiate lineage, which can differentiate NTM from MTB, and also understand the resistance. And we have covered most of the known resistance for the 12 MTB drugs that is given to understand this, the mutation patterns on these strains. So what was missing in all of this was, it was all individual independent platforms where everybody took out from the publications, and whatever was felt relevant based on the publication, it was all added into the pipelines that was shown. So what has now done is WHO has come up with a nice guidelines now. So in 2018, the WHO started getting the information on what are all the high-level resistant mutation, borderline resistant mutations, and low-level mismutation based on the public database information and comparing with whole genome sequencing and phenotypic data. So based on that, they came up and shortlisted the number of mutations that could be associated with drug resistance for all the drugs. And this was the first technical guideline that was came up in 2018. Following this, they kept on working on it, and recently they have a catalog of mutations which has been approved by WHO for understanding which mutation is contributing or which mutation is to be considered as the highly resistant mutation, which has a high standard of correlation with the clinical outcome and which should be relied on, and which can be considered the interim ranking, and which can be considered for possible ranking or an inferred mutation. So this grouping WHO has done based on certain classification, and this has been grouped with highly associated with resistance when they have individual strains which had more than five strains with a solo mutation alone contributing to phenotypic resistance. They were considered as highly associated with resistance along with other statistical significance. And the group 2 is associated with interium resistance. And group 3, group 4 and 5 are also categorized. So the group 1 and group 2 assumes more importance because of its association with phenotypic DST, and by being individually present, it constitutes to resistance. I'm sorry. Overall, from the catalog, what has been identified is, I have shown it here for a table. This is an open information that is available on the website in WHO. We can see that for rifampicin, they have identified 24 different mutations which are high association with phenotypic resistance, and 111 which are categorized as interium resistance, and the rest which are either uncertain significance or not associated, which the numbers might change. The interium could move into resistance. This is all based on how many number of strains it can accumulate. And how did WHO get this information? So now they have also refined this catalog, what they had got, and they had now published it in the Lancet Microbes recently. So this catalog is even further refinement of the previous version, what WHO came up on. This is now considered as a WHO endorsed MTB catalog for drug-resistant mutations. So this is now available. So what they have done is, they have collected from the global database the phenotype, and wherever there was a phenotype and a whole genome sequencing data was available, they have merged the two. This information is from about 45 countries and from about 41,000 MTB isolates. And by ruling out and ruling in, they have included 38,000 and odd MTB strains, and they have identified on the total for all the MTB drugs, they have identified 13,211 unique mutations that are linked to one or more of the drugs for M. tuberculosis. And of this, they had classified 7.3% of them to be associated with phenotypic DST, and 107 were deemed inconsistent. And of this, what they have done is try to look at the sensitivity for rifampicin, isoniazid, ethambutol, fluoroquinolone, and streptomycin. These high-level resistant mutations give a sensitivity of more than 80%, and specificity was more than 95%. And because of the number of strains that are available for delaminid resistance, clofazimine, linezolid, and bellaquilin is very less, they are not able to have a very good association in terms of statistics to come up with more mutation. They identified only 2 resistant mutations here. And here what I want to show is from the publication, they have also shown the number of strains which represented each of these mutations has been listed out and put into the graph, which basically shows that you have different distribution, and you have got distribution for all the different drugs in this collection. So the more number of strains added to this collection actually enhances the catalog and strengthens the catalog for identifying the best mutations. And this table actually shows the different types of mutation that has been now collected, and even within the category 1, they have set it up as tier 1 and tier 2, not only based on publications and references, but also based on the current diagnostic kits, the mutation that has had a clinical outcome. All of that has been segregated and sorted out here. So the data is improving. So here they have also shown the sensitivity and specificity based on each of this mutation that they have categorized. So the categorized mutation for rifampicin 1, how it has got more than nearly above 90% sensitivity with a very good specificity. And for isoniazid, again, it is almost like 88-89% sensitivity and a very high specificity as well. So all of this now has a very good sensitivity and specificity based on the WHO catalogs of mutations. What is still missing is all these new drugs and repurposed drugs, where we need to keep collecting information, where we need to sequence, where we need to do phenotypic DST, understand the mutation, look at its concordance, and cumulatively come up with the most concordant mutations which can be added here as a high-level drug-resistant mutations. So this graph basically shows that we have good number of isolates for each of the representation of the drug resistance, that mutation that has been selected, except for these 3 where we have a low number of strains which needs to be built up. So this, I think, it was also discussed. So all that I want to emphasize here is the study from the Lancet Microbe was done compared with the data that was obtained from the local labs where they had done the WHO approved endorsed diagnostic methods for targeted identification of drug resistance versus whole genome sequencing. And what they have identified was at all categories of drug resistance data that was given from the local labs, there was an addition of newer identification of strains by whole genome sequencing. There was an additional drug resistance identification, basically because some of the reasons like what Dr. Champa was mentioning, you have regions outside the RRDR region which would have been missed out as rifampicin resistance. You might have other additional mutations which was not present in the current diagnostic kits. So basically it definitely has a value addition. So even if you look at the monoresistance, you have very little overlap. Look at the pre-XDR or XDR, there is so much of additional value by adding a whole genome sequencing. The whole genome sequencing contributes to additionally 56% of newly identified cases. So there is definitely a new additional cases. And then the study also goes on to compare the mortality based on the drug resistance. When they looked at it, the mortality rate was very high in pre-XDR and XDR compared, then followed by MDR, the monoresistance and the pan-susceptible. When they look at the mortality based on the concordance of the diagnosis or the discordance of the diagnosis between the local labs versus the whole genome sequencing, based on concordance of data, the treatment ongoing, well, the mortality was very less, but based on the discordance, basically leading to undertreatment, like what I said, WGS was able to identify more amount of drug resistance. In those cases, based on the discordance, this is a retrospective data. So they had seen more number of, increased number of deaths, and discordance potentially leading to overtreatment. It actually, the mortality rate was less. So the discordance by overtreatment or overtreatment did not, it reduced the mortality, whereas undertreatment actually enhanced the mortality. Doesn't mean that we have to go for overtreatment, but it did not affect. And the other discordance also led to some amount of mortality. So this is the value addition that we get. So basically under treatment, we have increased mortality rate compared to overtreatment, even as per WHO based guidelines. So this is what we have. And again, this by odds ratio, it has more discordance versus concordance. We have more association of potentially overtreatment having lesser mortality rate and undertreatment leading to over mortality rate. Beyond that, the whole genome sequencing beyond drug resistance can also help us to understand the heteroresistance, what was majorly discussed by the previous speaker as well, because we do find in our own experience up to at least 1 to 2% of the strain collections that we have had some amount of heteroresistance. But what is the clinical implication of this heteroresistance? Depending on the mutation that is present in the heteroresistance, whether the strain will become a more strain which is more fit of survival, so it overtakes the susceptible strain and grows faster and becomes a resistant strain, is something that we do not know. Still an area of thinking and understanding where knowledge has to grow and improve on this. And WGS can also help us with the TB surveillance database. So when we have the WGS based TB surveillance data, it can help us to understand this evolution of drug resistance, understand the confident identification of the recent transmissions and reinfections, whether it is a transmitted strain or it's a reinfection or a relapse. Is the same strain emerging again in the same patient and a treatment failure. All of that information, we can get it based on whole genome sequencing. And based on this information, how can we help the program in planning the TB diagnosis, designing treatment regimens, improving the current diagnostic kits, and providing treatment services, effectively monitoring and providing controlled intervention, develop policies for the program, basically based on the prevalent mutations and the clusters. And beyond that, based on transmission, there are several publications coming out these days on how WGS has helped in understanding the transmission. Example for here, they have identified so many clusters, where individual clusters where the transmission has happened. And most of these clusters, the green circles, the cluster was more towards coming from the MDR transmission. So the country is more focusing towards MDR control here. So this kind of small information, and not only in a small country, but also it was also done in the Euro surveillance between countries, how the transmission clusters are happening, and how are these groups being identified. All this information, everything comes from, I mean, we can get it from the whole genome sequence database. So, and what the current information, I was also intriguing to see this particular publication on this, where they have tried to do a phylogeny analysis of M. tuberculosis and try to compare it with the extrapulmonary or pulmonary tuberculosis disease. This is one of the recent paper that has come out. And I think more information on such not many publications have come here where we have one publications. We try to look at EPTB and see what lineage or what drug resistance is more associated, but want of number, this kind of data and information is not strengthened enough. We are looking forward to more information on this in future based on whole genome sequencing and clinical database that is available. And most importantly, when we talk about sequencing, bioinformatic analysis is a key. And that is why we focus more towards centralized laboratories. So where we can do this. So why is that? Because we need to have a bioinformatician who can actually do this, or we have a pipeline which is currently updated and provides information to target the right mutations and understand which mutation is present in the individual pipeline or the pipeline or in the strains. So those things are very important. So with this evidence provided, I hope all of you will agree there are some advantages of using whole genome technology, where the turnaround time could be reduced. We can have better prevention in the community with more effective treatment and shortening of infectivity time. And transmission can be avoided. And basically, it will improve the effectiveness of public health intervention in controlling and preventing the spread of the TB. And also the global status, some of the labs, some of the countries have already adapted it for drug sensitive testing. And several labs are working to reduce the complexity and cost of this. And basically, this will be possible using targeted sequencing and benchtop sequences. And as usual for any technology, we also have challenges in whole genome sequencing. We need a high quality of DNA and purity of DNA. Currently, directly from the sputum, you will not be able to do sequencing for a whole genome, but targeted sequencing is still feasible with WHO recommended kits. And the cost is one of the concerns for middle and low income countries. And we require technical training on this. It is it's high skilled technology is involved here, and supply issues. Currently all the platforms that we have here for sequencing is all requires imported kits with short expiry dates. So planning has to be done, supply has to be consistent. And most cases, the targeted sequencing approach takes advantage because of the amplification of a selected region where the cost comes down, and resource limited settings can make effective use of this, especially for surveillance purposes. And what was already mentioned, I just want to reiterate, we just have knowledge gaps still existing. We cannot completely overrule the phenotypic DST. We need to get information based on phenotypic DST to understand which mutations becomes important, especially for these new drugs, bedaquiline, clofazimine, linezolid, and delaminid. And the discordance still needs to be sorted out. And the knowledge on the heteroresistance, like what I mentioned, still needs to be worked with. So just to conclude, this WGS has already replaced phenotypic DST in some settings, and the basis of drug resistance surveillance surveys are currently being supported based on WGS and by WHO. And also it has become one of the standards for molecular epidemiology and strain typing, and it has taken over the Miru VNTR and Scoligo typing that was done earlier. But still, we need to move forward in understanding, standardizing and validating efforts need to be continued, and we need to work on the technical and analytical aspects of WGS, need to come up with committed resources for this because it still is expensive, and we need to improve on the WGS based, we need more data based on WGS based TB surveillance, especially a global data will be helpful for developing a catalog like what we mentioned, the mutation catalog. I think I'll stop here and thank you very much. There is any questions? Am I audible? Am I audible?
This is
right side unmute करो ऊपर से पटे ऊपर last unmute करो.
Uma, there is one question for you.
Yeah.
Since the drug resistance in MTB is based on SNPs, would the selection of target SNPs for genotyping be driven by the infecting?
Sorry, I'm not able to hear it. Can you repeat the question, madam? I can't. Can you repeat the question, madam?
I can't find the question now.
Sorry.
Hello.
Sorry about.
So what is the cost?
Sorry, repeat the question. MTB is based on SNPs. Would be based on SNPs would the selection of target SNPs for genotyping be driven by the infecting strain? And for alignment, what is the preferred reference genome?
My understanding of the question is they are asking, can SNPs can help identifying the drug resistance in the genome. So the reference genome, what they are currently using is the H37RB, the laboratory strain, which is drug sensitive. And compared with that, wherever there is a mutation or a SNP difference identified compared to the pan-sensitive strain is what we use for identifying a drug resistance SNP. And these SNPs are the ones, like what I said, different platforms have different number of SNPs that has been thrown in. And now WHO is trying to uniformly give a common platform to understand which SNPs can be considered for drug resistance and which can be used as a high confidence mutation, which can be utilized by the clinician for patient management. I hope I answered that question.
I have few questions, Dr. Uma. Thanks a lot for the very lucid talk, and you really explained everything beautifully. So how much is the cost coming out to be per sample?
Very good question. So it varies depending on the platform that we are using. Currently what we are using here is a MySeq platform, which can give about 15 GB of data, which actually means about 24 million reads, which gives a good depth. That is why we are able to even identify hetero-resistance and mixed resistance and evolving acquired resistance in follow-up samples. But the cost varies depending on the platform. Like here, when we do a 24 genome in one platform, is that what is allowed here? We get the good depth and good coverage, which helps us to understand the good drug resistance pattern. But with only 24 sequences, our cost from culture, DNA extraction, and library preparation and running it on the machine comes to about 15 to 16,000 per sample. But which almost, I think, somewhere averages to the 12 to 14 drug phenotypic DST that is done by Midget DST. But we are using a better platform like a HiSeq or other platforms where you can throw in a lot more NextSeq or HiSeq, which we can for one run we can go with 100 MTB sequences. The cost drastically comes down. We can even go with 5,000 to 6,000 rupees per sample. That depends on the platform that you're using. So the platforms will have a one-time cost, the annual maintenance cost, but the run cost and the sequencing cost definitely comes down.
So what is the depth you are getting for 24 samples?
24 samples, we get up to 80 to 100x depth. This project that we are currently doing, we are focusing on understanding the drug-resistant mutations, hetero-resistance, mixed resistance. So we are going with a very huge depth of coverage, but even a 98 to 100x coverage and a huge depth of 80 to 100x. But with the 30x itself, we can go with the drug-resistant reduction that has been recommended in most publications.
So in routine, one can go with 30x.
30x, yes.
Okay.
Unless there is a difficult to treat patient who has developed over a period of time, had a clinical symptom, dropped the clinical system, again having a clinical deterioration, probably is developing an acquired resistance, we can go for a higher depth.
So you can put more samples in your flow cell.
Yes.
So that reduces the cost?
Yes, that reduces the cost.
How many samples are you
adding?
For
MySeq, we can even go up to 30x, 30 samples to 30. The indexing library, we can go even up to 48 samples for MySeq. That is a limitation.
48 samples, please.
Yes.
Okay. And have you tried any panels like targeted sequencing?
Yes, ma'am. We have tried it with Dplex. We did do it. Yes. It has, when you do it with the targeted and when we are focusing on only 48 samples, we get more than 1000x depth for every SNP. So that's the advantage.
But are you able to get the wide range of the drugs?
Yes, yes. So yes, it by itself has a software and a pipeline, so which pulls out all the possible mutations and covers most of the mutations.
For how many drugs? Like,
for all the 12 drugs.
All the 12 drugs, okay. And that must be coming out to be much cheaper. So what is the cost of the targeted sequencing then?
The targeted sequencing cost goes down. So when we use the same platform, the run kit is the same. So one half of the cost still remains the same. The library preparation differs depending on how many indexes we are using or if we are using a targeted kit. So that is where the cost variation comes. But the run kit is going to be the same, and depending on number of samples, it might vary. So in our for our purpose, we used 48 samples. The run kit cost was the same, just that it reduced to half the cost from the whole genome sequence.
And what is the time taken on an average?
Time taken for a MySeq platform for 24 samples. We don't run more than 24, and even within 24, we have EQC samples or sample from the previous run or an H37 run for an equa purpose. And with that, our time is like 48 hours. We get the result. After the library preparation takes almost a day, and the run takes like 1.5 days.
So
and
1 day for library.
Yes, 1 day almost.
Okay,
and this starts from DNA extracted DNA. So extracted DNA is obtained as and when we get the clinical positivity.
So what method are you using for DNA extraction?
We are following CTAB method, but there are also, we can also use the, we are using this is for research purposes that I've been working on. For clinical purposes, or if you want a turnaround time which is faster, then midget DST, which is positive, is also utilized. And the other countries is they are using that. So the 3-day positive culture can also be used as a starting material for extracting the DNA. The only difference that I have seen is the 30x depth could be right, but we cannot have more than 30 to 40x in those cases because it will be contaminated with other organisms. And even from the sputum, it is very difficult. 8 to 6x is the depth that we can get. The contamination of other DNA masks the sequences.
But you're using the CTAB method for extraction?
Yes, we are using CTAB.
Okay, and you're getting good results.
So even currently, our focus is to enrich the mutation catalog for our countries.
Right, right. So even from midget growth, you're using CTAB method. The method must be the same.
Midget, right? We tried. This is where I use the duplex. So I use the midget positive cultures, 3-day-old culture, and compared it with the LJ culture, which was 1 generation later, and tried to compare them both to understand if I had any hetero resistance that was missed by the 2nd generation in the LJ culture versus the midget culture. But most of it was captured. So it's very important that we go with the earliest generation of strains to extract the DNA and do this sequencing. So we don't miss out any small population of hetero resistance if at all it is there.
So it is midget culture is good enough, or you should do LJ subculture and then do the
definitely the quality improves, the quantity also is much better when we use LJ. But if we are looking for patient management, the time lost can be avoided if we are starting with the midget.
Right. Right.
So there it is more a fast prep method. We don't have to go with the CTAB method. It is more like beating, extraction DNA. That method can be utilized.
Okay, okay. So thanks a lot, and we'll like to have more of your inputs when we are setting it up. Thank you so much, really. Very nice presentation.
Thank you.
Moving on with the second session, we are continuing with the second session. After the brainstorming with about the diagnostics, we'll come to the management of MDR-TB. And for that, we have none other than Professor Rupak Singla, who is the professor and head of Department of TB and Respiratory Diseases, National Institute of TB and Respiratory Disease, Delhi. Over to you, Professor Rupak Singla.
And enable my shared screen as well as please allow me to share my screen, please. Floating. Right. Hey, 30 seconds. Okay, I hope you can see my slides now.
Yes, sir. We can see it.
Okay. Yep. Thank you so much for inviting me here. And I would like to thank the entire team of AIIMS Bhubaneswar CME to permit me to speak on this very important subject, that is management of drug resistance tuberculosis. You see, in India, we are contributing more than 26% of the global cases of drug resistance TB. And this is a disease of great public health concern. So we need to manage it the proper way so that we are able to eliminate TB from our country. Before I proceed, let me share a case study with you, which is a typical scenario in the field. This 35-year-old gentleman weighing 64 kg was diagnosed as pulmonary TB, and he was prescribed INS 300 mg, rifampicin 450 mg, ethambutol 800 mg, and pyrazinamide 1500 mg. Definitely the underdosage for this weight band. He took the treatment regularly for 2 months, improved, and stopped taking the drugs. After 2 months, again he came with symptoms. He went to the next physician. He added levofloxacin and continued the above 4 drugs in the same dosages. This time patient took the drugs irregularly, did not improve in the next 2 months, and he further deteriorated. Now he got frustrated from the private sector and reported to a government facility. And where this put-down examination was done, it showed MDR TB. So as you can see, this prescribing wrong dosages, patient initially improving, stopping the drugs later on, again relapsing, then changing the physician, and next physician adding the fluoroquinolone, and again continuing the underdosaging. Then patient taking the drugs irregularly, not improving, then changing from private sector to the government sector or government sector to the private sector. These are very common scenarios, and these are the main causes which lead to the development of drug resistance. Just let me share. So, ladies and gentlemen, with this brief case summary, I would like to, today I will be talking about the types of drug resistance, although it has been covered earlier, but I would like to emphasize certain points. Then I'll be speaking about the integrated DRTB diagnostic and treatment algorithm. I'll talk about the management of different types of drug resistance, which include H monopoly DRTB regimen, shorter MDR-TB regimen, longer MDR-TB regimen, and finally I'll be concluding. If you look at the types of drug resistance, although it has been covered, but I want to emphasize on certain points. Mono resistance is resistance to one first-line anti-TB drug, like H mono resistance, we need to treat differently than the drug-sensitive TB. And polydrug resistance is resistance to more than one first-line anti-TB drug, other than both INH and rifampicin. But because once it is INH and rifampicin, it becomes MDR-TB. Then you have H resistance TB, which is resistance to INH, but sensitive to rifampicin. Again, it needs a different kind of treatment than the drug-sensitive TB. Then we have rifampicin resistance, that is resistance to rifampicin with or without resistance to the other drugs. Usually, it is seen that in more than 95–97% of cases, once there is rifampicin resistance, INH resistance is also there. But by definition, these two, MDR and rifampicin resistance, they are different. Then multiple drug resistance, it has been talked about from the morning, and so resistance to both INH and rifampicin. Then extensive drug resistance TB, as you note, now the definition of XDR TB, it has changed. Earlier it used to be INH plus rifampicin plus at least a quinolone and injectable. Now it has been realized that injectables are not the key drug for the management of drug resistance TB. These are the group A drugs, which includes quinolone, bedaquiline, linezolid. Accordingly, the definition of XDR TB has been changed to resistance to INH plus rifampicin plus at least a fluoroquinolone plus one additional group A drug, that is either bedaquiline or linezolid. And then we have pre-XDR TB, that is INH rifampicin plus one of the fluoroquinolone, because again this group is also having a poor outcome of treatment with the currently used drugs. So this has been defined separately. Now this is in the country. We are following a particular diagnostic and treatment algorithm. This is called integrated diagnostic treatment algorithm because this is covering both the sensitive as well as the resistance. It looks complicated. I'll try to make it simple. You see the upper part. Whenever we diagnose TB, so all presumptive TB cases or in the key population, once we say key population means PLHIV, children, EPTB, smear negative TB, or excess IST of TB, contacts of drug resistance TB, and other vulnerable groups. So they all fall in the category of key population. So in presumptive TB or key population, all diagnosed cases of TB and among the patient who are on treatment and are not responding. So the first test to be offered to them in these three scenarios are the NAT test, which includes GeneXpert as well as the TrueNAT. And then after this, we'll know whether person is rifampicin resistance detected, rifampicin resistance not detected. So once rifampicin resistance is not detected, we go to the left side of the arm. So next test to be offered is the first-line LPA. Simultaneously, we start the drug-sensitive TB regimen till the first-line LP report is coming. If the first-line LP report says H resistance not detected, we continue the DSTB regimen. If the H resistance is detected, we stop the DSTB regimen and we do the testing for second-line LPA, liquid culture DST for certain drugs, and put the patient on a separate regimen which is called H monopoly DRTB regimen. I'll be talking about this. On the other hand, if you go to the left side of the algorithm, once you detect rifampicin resistance, then automatically we have to go for first-line LPA, second-line LPA, and liquid culture DST to certain drugs. We have to do the pre-treatment evaluation because now we are considering treatment with the shorter or longer MDR-TB regimen. So the basic concept is whenever we diagnose rifampicin resistance, first thing which comes to the mind is, can I give shorter MDR-TB regimen to this patient or not? So for that, we have certain inclusion criteria, certain exclusion criteria. I'll be talking about them. In case there are no exclusion criteria, like there is no fluoroquinolone resistance, no H resistance with both INHA as well as cadmium, there are others also, then this patient will be put on shorter oral bedaquiline containing regimen. On the other hand, in case rifampicin resistance is detected and you find there is some exclusion criteria are there, in that case, not the shorter regimen, patient will be considered for longer oral MDR XDR-TB regimen. I'll be coming later on to all this kind of regimen. So talking about the treatment of DRTB, we have in the last 4 or 5 decades, we have 2 new drugs, that is bedaquiline and delamanase, which are in clinical use. Bedaquiline is a new class of drug, diroquinoline. It is targeting the mycobacterial ATP synthase. It's a strong bactericidal drug. It has shown significant benefits in improving the time to culture conversion in MDR-TB patients. And it has an extensive tissue distribution of 5.5 months. So it stays in the blood for up to 5 to 6 months. It is now approved for children 5 years and above and weighing at least 15 kg in consultation with the pediatrician. Earlier, it was approved only for children, only for adults 18 years and above. So now with this new age, now even the children can get the benefit of using the bedaquiline. The delamanate is the first approved drug in the class of nitro-dihydroimidazoles for the treatment of MDR-TB. And the hypothesized mechanism of action is on the synthesis of mycolic acid. And in India, it is approved for 6 years and above, although the WHO has approved this for 3 years and above. So whenever we talk about the basic principles of managing the DRTB, first thing we should come to the mind is prevention. It is the key which we should use rather than once resistance develop and then we are trying to manage it. So how we can prevent the development of drug resistance, that when we are managing the drug sensitive TB, we should take appropriate actions, use the appropriate regimen, use correct dosages, ensure that patient takes it regularly, ensure that patient completes the full duration. If you are able to take care of these 4 aspects, then chances of acquired drug resistance are practically negligible. Coming back to this, if you see this diagnostic algorithm which we have discussed, so there are 3 kinds of standardized treatment regimen. One is the H monopoly DRTB regimen. Second is the shorter oral bedaquiline containing regimen. And third is the longer oral MDR XDR-TB regimen. So these are the 3 in our country as per the new PM 2021 guidelines. We have these 3 standardized treatment regimen in the attempt has been made to make them simple. Talking about H monopoly DRTB regimen. So as you saw, rifampicin resistance is not detected, do first-line LPA, H resistance is there, and you consider H monopoly DRTB regimen. What is this regimen? It is of 6 months, levofloxacin, rifampicin, ethambutol, and pyrazinamide, and duration is, as is already shown there, is for 6 months. However, we can give this treatment we should give it for 9 months in the following conditions. Patient with extensive disease, once there is extensive disease, once patient has uncontrolled comorbid illness, in all kind of extrapulmonary TB, if they need H monopoly, it should be for 9 months. If you find patient is on treatment and smear at the end of 4 months is positive, you extend it for to 9 months. And if you find due to any reason, any drug has required the replacement, in that case again, give it for 9 months, not 6 months. In CNS TB, skeletal TB, and biliary TB, the treatment can be given for up to 1 year. So now next we are talking about the replacement sequence in H monopoly regimen, that in case patient requires to replace a drug, how and which drug to be used. If you cannot use levofloxacin because of intolerance or resistance, then you replace it with high dose moxifloxacin if second line LPA pattern suggests. That means if mute 3B, 3C, 3D, all three are absent, that means we can use high dose moxifloxacin. And also, whenever you use moxifloxacin high dose, always send the specimen for liquid culture DST for reconfirming the moxifloxacin high dose. And also you do the for pyrazinamide. A moxifloxacin or pyrazinamide, one of these two drugs cannot be used in the regimen, you replace it with linezolid. If linezolid cannot be given, you replace this with linezolid is group A drug. Now you need to replace it with not one drug but two drugs, that is clofazimine and cycloserine. If two drugs like moxifloxacin and pyrazinamide both cannot be used, in that case you need to add two drugs of the three, that is the three are linezolid, clofazimine, cycloserine in that order of preference. In case you can use all the three, you will be using linezolid and clofazimine. In case you cannot use linezolid, you will be using clofazimine and cycloserine. And if during follow-up or any time you find there is a rifampicin resistance, then we need to shift the patient to the appropriate shorter or longer MDR-TB regimen. The next standardized regimen is the shorter MDR resistance TB regimen. So as we have seen, rifampicin resistance detected, then you look for, try to consider the shorter regimen if there are no exclusion criteria. When we talk about shorter MDR resistance TB regimen, there are two kinds of regimen. One is the shorter injection containing regimen. Second is shorter oral bedaquiline containing MDR resistance TB regimen. So what are the inclusion criteria for the shorter injection containing resistance TB regimen? First is it should be rifampicin resistance or MDR-TB, but without fluoroquinolone resistance. In case there is fluoroquinolone resistance, patient is ineligible for shorter regimen. Then presence of only INHA or only CADG mutation. In case both are present, again shorter regimen is contraindicated. It can be given to children, can be given to PLHIV. You see in children, injection containing regimen can be given to any age, but if you consider bedaquiline containing regimen, then only in children 5 years and above, because less than 5 years we cannot give bedaquiline. What are the exclusion criteria? Pregnancy, injection containing is contraindicated throughout pregnancy, while bedaquiline containing oral can be considered in pregnant ladies once they are more than 32 weeks of gestation. After 32 weeks, we can give ethionamide, so that's why we can consider bedaquiline containing regimen. Of course, it's a consultative decision between the patient, the gynecologist, and the treating physician. If there is extensive pulmonary TB or severe EPTB like miliary TB, CNS TB, meningitis, in this situation, the shorter regimen should not be given. Of course, if there is any intolerance or toxicity to any of the medicine, the shorter MDR-TB regimen, then shorter regimen is not to be given. If patient has used the drugs of the shorter regimen, like levofloxacin, ethionamide, clofazimine for more than 1 month, and the DST to these drugs is either not available or is resistant, then again you cannot use the shorter regimen. However, in case somebody has used it for more than 1 month and DST is available which says they are sensitive, in that case we can use the shorter regimen. So very, very important point is that before considering shorter, whether injection or bedaquiline containing regimen, must see that it should fulfill the inclusion criteria and there should not be any exclusion criteria. The reason I am saying so is, in case you give shorter regimen to a wrong patient and he is getting this shorter regimen, then he's likely to develop resistance to the key drugs in the regimen. So we may lose drugs like bedaquiline, clofazimine, and quinolone, which are the key drugs today for the management of XDR or pre-XDR TB. That is for longer regimen. I'll come to it. What is this regimen? So the short injection containing regimen is for 9 months, extendable to 11 months. Intensive phase is for 4 months, which can be extended to 6 months in case smear remains positive at the end of 4 months or 5 months. The continuation phase is for 5 months. In the initial intensive phase, that is 4 months extendable to 6 months, we give 7 drugs. The 7 drugs are moxifloxacin high dose, pyrazinamide, ethambutol, clofazimine, kanamycin, ethionamide, and high dose INHA. This is based on the Bangladesh regimen, where this kind of regimen was tried first. So it's called Bangladesh regimen. And in the continuation phase, these 3 drugs are stopped: kanamycin, ethionamide, and high dose INH. And we continue with 4 drugs, that is moxifloxacin high dose, pyrazinamide, ethambutol, and clofazimine. And we also need to understand it's a package of treatment. If any drug needs replacement, we need to switch to the longer oral MDR-XDR TB regimen. So there is no scope of replacing any drug here, like we did the NH monopoly regimen. And another news is that with effect from tomorrow, that is 24th of March, this injection-containing treatment regimen will be phased out from the entire country, and we'll only have in the shorter regimen, shorter bedaquiline-containing oral regimen. As of now, this is there outside the 7 states where we were using the bedaquiline-containing regimen, but now the ministry has taken a call that this will be phased out, and in the entire country, this injection-containing regimen will not be available, and only shorter bedaquiline-containing regimen will be available. And what is the shorter oral bedaquiline-containing regimen? Again, it is same as this injection-containing regimen, but injection has been replaced by bedaquiline, and moxifloxacin high dose has been replaced by levofloxacin. Another thing to note is that bedaquiline is not for 4 to 6 months; it is for 6 months. So bedaquiline will be given for entire 6 months. Rest of the 6 drugs will be given for 4 months and can be extended to 6 months if required. And these 6 drugs are same: levofloxacin instead of moxifloxacin high dose, pyrazinamide, ethambutol, clofazimine, high dose INH and ethionamide. And in the continuation phase of 5 months, we have the 4 drugs: levofloxacin, pyrazinamide, ethambutol, and clofazimine. And again, it's again a package of treatment. No replacement is permitted. And as you know, initially when the shorter regimen was launched in the country, 7 states, they had the shorter oral bedaquiline-containing regimen. In rest of the states and union territories, we had injection-containing regimen. And with effect from tomorrow, the entire country will have only shorter oral bedaquiline-containing regimen. But again, you see here, in case we misuse this regimen, and in that case, patient can do operations to bedaquiline, to a quinolone, and to a clofazimine, besides other drugs. And these are the 3 key drugs to be used in longer oral regimen. That is for pre-XDR and XDR. These are the 3 key drugs. So, ladies and gentlemen, it's my humble request, be sure that there shouldn't be any exclusion criteria before you start using the shorter regimen. These are the dosages. We have in drug resistance TB, we have 4 weight bands in adults: 16 to 29 kg, 30 to 45 kg, 46 to 70 kg, and more than 70 kg. I'm not going into details for the dosages. And coming to the last standard DRTB regimen, that is longer oral MDR-XDR TB regimen. So as we saw, once inflammation resistance is detected, then we consider shorter oral bedaquiline-containing regimen. If it cannot be given, then we talk about the longer oral MDR-XDR TB regimen. Now let us see what has been the major change today in the 2021 guidelines or WHO guidelines compared to before. This was a landmark article published in 2018. This changed the entire scenario of the understanding of the treatment of the MDR-XDR tuberculosis. In this, they used the individual patient data meta-analysis, which is the highest level of evidence. More than 12,000 patients across 25 countries, including 50 studies. And fortunately, we had 3 studies from India, from PGI Chandigarh, from my institute, and from Mumbai. So out of these 50 studies, 3 studies belong to our country also. So what it showed was that oral drugs like levofloxacin, moxifloxacin, linezolid, bedaquiline, they had greater treatment success, reduced deaths. Clofazimine, carbapenem, they had greater treatment success, but no reduced deaths. Pyrazinamide lowered the mortality only if susceptible, which is important. Drugs like streptomycin, amikacin, cycloserine, tazidone, they had modest benefits. Drugs like kanamycin or terpimycin, these were, the injection were the key drugs earlier. Then they were found to be associated with higher failures, relapses, deaths, and toxicity. So this was the one of the main observations which proved that these 2 drugs are not good. Although the kanamycin was not associated with worse outcomes middle low income countries because of lack of data. The data was not there. Then drugs like ethionamide, prothionamide, PAS, macrolide, amoxicillin, clavulanic acid, they did not have significant benefits or sometimes even worse outcomes. So if you see this, so they emphasize that oral drugs are superior. Injectables like kanamycin, capramycin they should not be used. Then the WHO collected some more evidence. So they had evidence of more than 30,100 records across 40 countries and 53 studies. They also studied the serious adverse events of using these drugs. And then they came out with, in 2020, WHO consolidated guidelines for management of DRT. So they were released, and subsequently in March 21, the guidelines for PMDT in India, they were released. We were part of framing these guidelines. So what they did was, there was a regrouping of the anti-TB drugs for longer MDR-TB regime. They had a group A consisting of levofloxacin or moxifloxacin, bedaquiline, linezolid, and it was recommended that you should include all the three medicines in their TB regimen for MDR, XDR-TB regimen. Group B included clofazimine, cycloserine, or trazodone, and it was recommended to add at least one or both the medicines in the regimen. Then they had Group C, which was the drugs in the Group C were to be added to complete the regimen when you cannot make a regimen using the Group A and Group B drugs. And the drugs in the Group C included ethambutol, delamanid, pyrazinamide, imipenem, cilastatin or meropenem, amikacin or streptomycin, ethionamide, and PAS. And these are in usual order of reference. That is, first, in case you cannot make a regimen, first consider ethambutol, then you consider delamanid, then pyrazinamide, like that. So this was the WHO recommendation. But you see, in India, when the guidelines were revised, we again collected the evidence, the drug resistance pattern in the country, the cost, the availability, the tolerance, everything. So it is in Indian guidelines, the replacement sequence is changed. I'll explain you why it was considered to be changed. As per WHO, ethambutol was the first step to be considered. But in India, the National Drug Resistance Surveillance showed among MDR, ethambutol resistance is seen in almost 46% of cases. So in Indian guidelines, it is placed much lower in the sequence. Then delamanid, by the time Indian guidelines were being framed, we had more evidence for the efficacy of delamanid. And this was considered to be used as the first drug in the sequence. Then pyrazinamide, again in India, it was observed in our drug resistance surveillance that among MDR-TB cases, it was new cases, it was to the tune of 31% resistance, and in the retreatment cases, 20%. So this was third drug in the sequence, was to be used only when sensitive to take care of this aspect. The next drug by the WHO was imipenem, cilastatin. So, but there are definitely serious issues of it's very, very expensive. I have personally used it in more than 100 cases. And there are logistic issues, we have to insert the PICC line there, and we have to give the infusion for 1 hour in the morning, infusion for 1 hour in the evening, and very, very expensive. Most of the patient will not be able to afford it, and we have to give it for 6 months, 7 months, 8 months. So this was used as recommended to be used as a last drug in the sequence of replacement. Then amikacin was there. This was recommended to be second drug in the sequence to be used only when sensitive. Ethionamide, prothionamide, fourth drug in the sequence to be used only when sensitive, because now in the first line LP, in case you find INHA mutation is not there, we know that ethionamide can be used. Similarly for amikacin, in the first and in this second LPA, we have the report from the available, so which can be available earlier that it cannot be used. And PAS was the fifth drug in the sequence, and then was ethambutol, and then imipenem, cilastatin. So the sequence in Indian PMDT guideline is first is delamanid, amikacin only if sensitive, pyrazinamide only if sensitive, ethionamide only if sensitive, then PAS, then ethambutol, and then imipenem, cilastatin or meropenem. In children, we prefer meropenem because of the lesser CNS side effects. Coming to the longer oral MDR XDR-TB regimen, as per WHO 2020 recommendation, as we just discussed, all the 3 group A agents and at least 1 group B agent should be included to ensure that treatment starts with at least 4 TB drugs, which are likely to be effective, and at least 3 agents to be included in the rest of the treatment. Because bedaquiline will have to stop after 6 months, usually. However, in India, the experts, when in the technical expert committee, they concurred to start with all the 5 drugs of group A and B and continue with the 4 drugs in the latter part of the regimen, that is after 6 to 8 months after stopping bedaquiline, if the patient can tolerate the drugs. And this was primarily for the operational needs in the field, because in the field, in case one drug cannot be tolerated, then you need to stop it. So stopping a drug, replacing it with the another drug, it's a challenge in the field. So the Indian experts took a call that we will give all the 5 drugs in the initial intensive phase of 6 months to 8 months, and then in the continuation phase, stop bedaquiline and give 4 drugs. And what is this regimen? This regimen is having 5 drugs: levofloxacin, bedaquiline, linezolid, clofazimine, and cycloserine, to be given for 18 months, which can go up to 20 months. That is, after initial 6 months, the regimen can be extended if required. Bedaquiline is given usually for 6 months only. In some rare circumstances, we may have to give it for longer. Linezolid is given for 600 mg in the 6 to 8 months initial, and then we reduce the dose to 300 mg. For XGRTB patient, the duration of the longer regimen is 20 months. These are the same 4 weight bands, and these are the dosages of the drugs to be used. Coming to the BPAL regimen, it was an XTB trial which investigated the role of this BPAL regimen, that is bedaquiline predominant linezolid. In the XTB trial, it was shown that in 110 patients, if you use these combination, almost 90% of the patient they achieved the treatment success, and 10% had unsuccessful outcome. So it was found to be very useful, and it was given in cases of XDR-TB or MDR-TB patient who failed to treatment, or patient who are not tolerating the MDR-TB drugs. So based on that trial, the WHO has recommended that you can use this bedaquiline predominant linezolid under operational research condition, mind you, and thus does not apply to routine programmatic use. As per WHO recommendation to be used in operational research conditions. Then in MDR-TB patient with TB that is resistant to fluoroquinolone, that is pre-XDR-TB, and provided that patient should have had no previous exposure to the bedaquiline and linezolid, or if at all have been exposed for no more than 2 weeks. So all the 3 conditions should be fulfilled. And in India also, we are doing the study on this BPAL regimen in different dosages and duration. The NIRT Chennai is the principal investigation site. Across 10 sites, there are 10 sites where the study is being used, and it just recently started and the enrollment is taking place. And discussion is incomplete without talking about the role of surgery. When to consider surgeries? When patients are not responding to medical therapy, or you feel that we should add on surgery to prevent the relapses. The requisite is that lesion should be localized, lesion should be resectable, and patient should be fit for surgery. The ideal time to do surgery is between 6 to 9 months of the treatment. And when you combine surgery with chemotherapy, the treatment success is definitely improved. Even up to 90% of cases, they can have lasting cures. These are few of the cases, like left upper lobe thick wall cavity, patient was not responding. And when surgery was combined with the chemotherapy, patient responded. Here, this was the brother of a doctor only, not responding to treatment even after 1 year. So we considered surgery. In our institute, we are doing surgery for last 50 years. All kind of resections, mediastinal tumors, trichoplasties, everything is being done. So we are able to offer surgery to the patient who need it. So with this, I come to the my concluding remarks. So first, I would like to focus again that we should always lay attention on preventing the DRTB by treating the drug-sensitive TB well. We know the phenotypic tests, they take long time, but they are good to assess the response to treatment. The genotypic test cannot be used once patient is being followed up. During follow-up, because you need to grow the culture to see whether the person has culture converted or not. So phenotypic tests, they have a role there. The genotypic tests definitely are faster, and they permit us to start the appropriate regimen at an early stage, which is required, because we cannot go on waiting for the phenotypic test results. So to start the treatment early and to start appropriate treatment regimen, we need the genotypic test. And the neurogenotypic test, Factor Expert, MTB XDR, they will be a game changer for the early identification, because within 3-4 days of patient coming to us, we know patient is MDR or not, whether patient is pre-XDR-TB or not. And then accordingly, we can start the appropriate treatment, because suppose we do not know patient is pre-XDR and you put the patient on shorter MDR-TB regimen, till you have this report of second-line LPA. Sometimes we are seeing in the field for various reasons, reports of second-line LPA are coming after 2 months, 3 months. Sometimes report is available on the NICSHA, but the treating physician or the district TB officer, they are not downloading and not taking the action. This is also very commonly happening. But in the bargain, the patient does not get the benefit of second-line LPA report for 2 months, 3 months. And during these 2-3 months, patient is on a wrong regimen. And during these 2-3 months, patient can develop resistance to bedaquiline, to quinolones, to clofazimine, etc. So this expert MTB XDR, which tells you what the INH, ethionamide, and fluoroquinolone, also in the injectables, the resistance early, so that can help you in starting the appropriate regimen. And we should follow the integrated diagnostic and treatment algorithm for management of DRTB patients. And the new drugs like bedaquiline and delamanid, they look quite promising. Thank you very much for a very patient listening. Thank you all. And thank you for giving me this opportunity to interact with you all. Thanks.
Thank you very much, sir. There is only one question, but I couldn't get this question. What is the ideal time for MDR TB empyema?
Ideal time for MDR TB surgery?
Empyema.
Yeah, even empyema we should not delay. Once there is empyema means there is a pus in the pleural space, and normally the chronic empyema we say once it is there for 3 months it becomes a chronic empyema. But there are disadvantages of waiting for the chronic empyema. So ideal thing is you manage with antimicrobial treatment. If it is tubercular, give anti-TB treatment. If it is pyogenic, you give the antipyogenic treatment. But in case you find patient is not responding, then within 2-3 months we should operate the patient, so that at that time we can do the decortication. We can take out the entire pus and let the lung expand. In case you delay too much, then the underlying lung gets fibrosed, bronchiectatic, and it will never expand. So 2 to 3 months time we should do the in empyema cases. In case you find that they not responding to your antimicrobial treatment, one should consider surgery.
There is another question. New guideline, high dose INH given in CAT-G resistance.
No, you see, basically we just ignore it. There are 7 drugs in the shorter MDR TB regimen, and this is a package of treatment. So in case you see individually, it has inhibindole, it has pyrazinamide, it has high dose INH, you may feel that how this the treatment will be acting. But in the Bangladesh regimen also they found that in case you give these 7 drugs, and only in the MDR TB cases, but you rule out presence of XDR TB patients or pre-XDR, the fluoroquinolone resistance should not be there, and there should not be INH as well as CAT-G. In that case, this regimen is likely to act. And we are collecting the data in the country on the efficacy of this regimen, including the inclusion criteria and ensuring that there are no exclusion criteria. And we'll have the data from this regimen, and then we will see how good or bad this regimen is working. So presently, yes, if there is a CAT-G, you still give this 7-drug regimen, and there is no provision for replacing any drug.
There's one more question. Can empyema be assumed as EPTB?
Yes, empyema is EPTB. Empyema is EPTB because it involves pus in the pleura. This is not assumed, this is EPTB. If it is
There are no more questions. Thank you very much, sir, for the wonderful presentation. So we'll go on to the last speaker in this session.
Thank you.
So it's my proud privilege to introduce the next person who requires no introduction actually. He's the pride of our nation, Padma Shri awardee, former chairman of National Task Force, NTEP, RNDCP, ex-professor and HOD for Department of Pulmonary Medicine, PGI, MPR, Chandigarh, WHO Collaborating Center for Research and Capacity Building in Chronic Respiratory Disease, ex-OSD, AIMS, Raebareli, President, Indian Chest Society, President, Indian Society for Study of Lung Cancer, Dr. Digambar Behera. He will be speaking on challenges in the TB control.
Floating. Right. Okay, I hope you can see my slides now.
Yes, sir, we can see it.
Okay. Yep. Thank you so much for inviting me here. And I would like to thank the entire team of AIMS Bhubaneswar CME to permit me to speak on this very important subject, that is management of drug resistance tuberculosis. You see, in India, we are contributing more than 26% of the global cases of drug resistant TB. And this is a disease of great public health concern. So we need to manage it the proper way so that we are able to eliminate TB from our country. Before I proceed, let me share a case study with you, which is a typical scenario in the field. This 35-year-old gentleman weighing 64 kg was diagnosed as pulmonary TB, and he was prescribed INS 300 mg, rifampicin 450 mg, ethambutol 800 mg, and pyrazinamide 1500 mg. Definitely the underdosage for this weight band. He took the treatment regularly for 2 months, improved, and stopped taking the drugs. After 2 months, again he came with symptoms. He went to the next physician. He added levofloxacin and continued the above 4 drugs in the same dosages. This time patient took the drugs irregularly, did not improve in the next 2 months, and he further deteriorated. Now he got frustrated from the private sector and reported to a government facility. And where this put-down examination was done, it showed MDR TB. So as you can see, this prescribing wrong dosages, patient initially improving, stopping the drugs later on, again relapsing, then changing the physician, and next physician adding the fluoroquinolone, and again continuing the underdosaging. Then patient taking the drugs irregularly, not improving, then changing from private sector to the government sector or government sector to the private sector. These are very common scenarios, and these are the main causes which lead to the development of drug resistance. Just let me share. So, ladies and gentlemen, with this brief case summary, I would like to, today I will be talking about the types of drug resistance, although it has been covered earlier, but I would like to emphasize certain points. Then I'll be speaking about the integrated DRTB diagnostic and treatment algorithm. I'll talk about the management of different types of drug resistance, which include H monopoly, DRTB regimen, shorter MDR-TB regimen, longer MDR-TB regimen, and finally I'll be concluding. If you look at the types of drug resistance, although it has been covered, but I want to emphasize on certain points. Mono resistance is resistance to one first-line anti-TB drug, like H mono resistance, we need to treat differently than the drug-sensitive TB. And polydrug resistance is resistance to more than one first-line anti-TB drug, other than both INH and rifampicin. But because once it is INH and rifampicin, it becomes MDR-TB. Then you have H resistance TB, which is resistance to INH, but sensitive to rifampicin. Again, it needs a different kind of treatment than the drug-sensitive TB. Then we have rifampicin resistance, that is resistance to rifampicin with or without resistance to the other drugs. Usually, it is seen that in more than 95–97% of cases, once there is rifampicin resistance, INH resistance is also there. But by definition, these two, MDR and rifampicin resistance, they are different. Then multiple drug resistance, it has been talked about from the morning, and so resistance to both INH and rifampicin. Then extensively drug resistance TB, as you note, now the definition of XDR TB, it has changed. Earlier it used to be INH plus rifampicin plus at least a quinolone and injectable. Now it has been realized that injectables are not the key drug for the management of drug resistance TB. These are the group A drugs, which includes quinolone, bedaquiline, linezolid. Accordingly, the definition of XDR TB has been changed to resistance to INH plus rifampicin plus at least a fluoroquinolone plus one additional group A drug, that is either bedaquiline or linezolid. And then we have pre-XDR TB, that is INH rifampicin plus one of the fluoroquinolone, because again this group is also having a poor outcome of treatment with the currently used drugs. So this has been defined separately. Now this is in the country. We are following a particular diagnostic and treatment algorithm. This is called integrated diagnostic treatment algorithm because this is covering both the sensitive as well as the resistance. It looks complicated. I'll try to make it simple. If you see the upper part, whenever we diagnose TB, so all presumptive TB cases or in the key population, once we say key population means PLHIV, children, EPTB, smear negative TB or excess IST of TB, contacts of drug resistance TB and other vulnerable groups. So they all fall in the category of key population. So in presumptive TB or key population, all diagnosed cases of TB and among the patients who are on treatment are not responding. So the first test to be offered to them in these three scenarios are the NAT test, which includes GeneXpert as well as the TrueNAT. And then after this, we'll know whether person is rifampicin resistance detected, rifampicin resistance not detected. So once rifampicin resistance is not detected, we go to the left side of the arm So next test to be offered is the first-line LPA. Simultaneously, we start the drug-sensitive TB regimen till the first-line LP report is coming. If the first-line LP report says H resistance not detected, we continue the DSTB regimen. If the H resistance is detected, we stop the DSTB regimen and we do the testing for second-line LPA, liquid culture DST for certain drugs, and put the patient on a separate regimen which is called H monopoly DRTB regimen. I'll be talking about this. On the other hand, if you go to the left side of the algorithm, once you detect rifampicin resistance, then automatically we have to go for first-line LPA, second-line LPA, and liquid culture DST to certain drugs. We have to do the pre-treatment evaluation because now we are considering treatment with the shorter or longer MDR-TB regimen. So the basic concept is whenever we diagnose rifampicin resistance, first thing which comes to the mind is, can I give shorter MDR-TB regimen to this patient or not? So for that, we have certain inclusion criteria, certain exclusion criteria. I'll be talking about them. In case there are no exclusion criteria, like there is no fluoroquinolone resistance, no H resistance with both INHA as well as cadmium, there are others also, then this patient will be put on shorter oral bedaquiline containing regimen. On the other hand, in case rifampicin resistance is detected and you find there is some exclusion criteria are there, in that case, not the shorter regimen, patient will be considered for longer oral MDR-XDR-TB regimen. I'll be coming later on to all this kind of regimen. So talking about the treatment of DRTB, we have in the last 4 or 5 decades, we have 2 new drugs, that is bedaquiline and delamanid, which are in clinical use. Bedaquiline is a new class of drug, diroquinoline. It is targeting the mycobacterial ATP synthase. It's a strong bactericidal drug. It has shown significant benefits in improving the time to culture conversion in MDR-TB patients. And it has an extensive tissue distribution of 5.5 months. So it stays in the blood for up to 5 to 6 months. It is now approved for children 5 years and above and weighing at least 15 kg in consultation with the pediatrician. Earlier, it was approved only for children, only for adults 18 years and above. So now with this new age, now even the children can get the benefit of using the bedaquiline. The delamanid is the first approved drug in the class of nitro-dihydroimidazoles for the treatment of MDR-TB. And the hypothesized mechanism of action is on the synthesis of mycolic acid. And in India, it is approved for 6 years and above, although the WHO has approved this for 3 years and above. So whenever we talk about the basic principles of managing the DRTB, first thing we should come to the mind is prevention. It is the key which we should use rather than once resistance develop and then we are trying to manage it. So how we can prevent the development of drug resistance, that when we are managing the drug sensitive TB, we should take appropriate actions, use the appropriate regimen, use correct dosages, ensure that patient takes it regularly, ensure that patient completes the full duration. If you are able to take care of these 4 aspects, then chances of acquired drug resistance are practically negligible. Coming back to this, if you see this diagnostic algorithm which we have discussed, so there are 3 kinds of standardized treatment regimen. One is the H monopoly DRTB regimen. Second is the shorter oral bedaquiline containing regimen. And third is the longer oral MDR-XDR-TB regimen. So these are the 3 in our country as per the new PMT 2021 guidelines. We have these 3 standardized treatment regimen in the, so attempt has been made to make them simple. Talking about H monopoly DRTB regimen. So as you saw, rifampicin resistance is not detected, do first-line LPA, H resistance is there, and you consider H monopoly DRTB regimen. What is this regimen? It is of 6 months, levofloxacin, rifampicin, ethambutol, and pyrazinamide, and duration is, as is already shown there, is for 6 months. However, we can give this treatment we should give it for 9 months in the following conditions. Patient with extensive disease, once there is extensive disease, once patient has uncontrolled comorbid illness, in all kind of extrapulmonary TB, if they need H monopoly, it should be for 9 months. If you find patient is on treatment and smear at the end of 4 months is positive, you extend it for to 9 months. And if you find due to any reason, any drug has required the replacement, in that case again, give it for 9 months, not 6 months. In CNS TB, skeletal TB, and biliary TB, the treatment can be given for up to 1 year. So now next we are talking about the replacement sequence in H monopoly regimen, that in case patient requires to replace a drug, how and which drug to be used. If you cannot use levofloxacin because of intolerance or resistance, then you replace it with high dose moxifloxacin if second line LPA pattern suggests. That means if mute 3B, 3C, 3D, all three are absent, that means we can use high dose moxifloxacin. And also, whenever you use moxifloxacin high dose, always send the specimen for liquid culture DST for reconfirming the moxifloxacin high dose. And also you do the for pyrazinamide. A moxifloxacin or pyrazinamide, one of these two drugs cannot be used in the regimen, you replace it with linezolid. If linezolid cannot be given, you replace this with linezolid is group A drug. Now you need to replace it with not one drug but two drugs, that is clofazimine and cycloserine. If two drugs like moxifloxacin and pyrazinamide both cannot be used, in that case you need to add two drugs of the three, that is the three are linezolid, clofazimine, cycloserine in that order of preference. In case you can use all the three, you will be using linezolid and clofazimine. In case you cannot use linezolid, you will be using clofazimine and cycloserine. And if during follow-up or any time you find there is a rifampicin resistance, then we need to shift the patient to the appropriate shorter or longer MDR-TB regimen. The next standardized regimen is the shorter MDR resistance TB regimen. So as we have seen, rifampicin resistance detected, then you look for, try to consider the shorter regimen if there are no exclusion criteria. When we talk about shorter MDR resistance TB regimen, there are two kinds of regimen. One is the shorter injection containing regimen. Second is shorter oral bedaquiline containing MDR resistance TB regimen. So what are the inclusion criteria for the shorter injection containing resistance TB regimen? First is it should be rifampicin resistance or MDR-TB, but without fluoroquinolone resistance. In case there is fluoroquinolone resistance, patient is ineligible for shorter regimen. Then presence of only INHA or only CADG mutation. In case both are present, again shorter regimen is contraindicated. It can be given to children, can be given to PLHIV. You see in children, injection containing regimen can be given to any age, but if you consider bedaquiline containing regimen, then only in children 5 years and above, because less than 5 years we cannot give bedaquiline. What are the exclusion criteria? Pregnancy, injection containing is contraindicated throughout pregnancy, while bedaquiline containing oral can be considered in pregnant ladies once they are more than 32 weeks of gestation. After 32 weeks, we can give ethionamide, so that's why we can consider bedaquiline containing regimen. Of course, it's a consultative decision between the patient, the gynecologist, and the treating physician. If there is extensive pulmonary TB or severe EPTB like miliary TB, CNS TB, meningitis, in this situation, the shorter regimen should not be given. Of course, if there is any intolerance or toxicity to any of the medicine, the shorter MDR-TB regimen, then shorter regimen is not to be given. If patient has used the drugs of the shorter regimen, like levofloxacin, ethionamide, clofazimine for more than 1 month, and the DST to these drugs is either not available or is resistant, then again you cannot use the shorter regimen. However, in case somebody has used it for more than 1 month and DST is available which says they are sensitive, in that case we can use the shorter regimen. So very, very important point is that before considering shorter, whether injection or bedaquiline containing regimen, must see that it should fulfill the inclusion criteria and there should not be any exclusion criteria. The reason I am saying so is, in case you give shorter regimen to a wrong patient and he is getting this shorter regimen, then he's likely to develop resistance to the key drugs in the regimen. So we may lose drugs like bedaquiline, clofazimine, and quinolone, which are the key drugs today for the management of XDR or pre-XDR TB. That is for longer regimen. I'll come to it. What is this regimen? So the short injection containing regimen is for 9 months, extendable to 11 months. Intensive phase is for 4 months, which can be extended to 6 months in case smear remains positive at the end of 4 months or 5 months. The continuation phase is for 5 months. In the initial intensive phase, that is 4 months extendable to 6 months, we give 7 drugs. The 7 drugs are moxifloxacin high dose, pyrazinamide, ethambutol, clofazimine, kanamycin, ethionamide, and high dose INHA. This is based on the Bangladesh regimen, where this kind of regimen was tried first. So it's called Bangladesh regimen. And in the continuation phase, these 3 drugs are stopped: kanamycin, ethionamide, and high dose INH. And we continue with 4 drugs, that is moxifloxacin high dose, pyrazinamide, ethambutol, and clofazimine. And we also need to understand it's a package of treatment. If any drug needs replacement, we need to switch to the longer oral MDR-XDR-TB regimen. So there is no scope of replacing any drug here, like we did the NH monopoly regimen. And another news is that with effect from tomorrow, that is 24th of March, this injection-containing treatment regimen will be phased out from the entire country, and we'll only have in the shorter regimen, shorter bedaquiline-containing oral regimen. As of now, this is there outside the 7 states where we were using the bedaquiline-containing regimen, but now the ministry has taken a call that this will be phased out, and in the entire country, this injection-containing regimen will not be available, and only shorter bedaquiline-containing regimen will be available. And what is the shorter oral bedaquiline-containing regimen? Again, it is same as this injection-containing regimen, but injection has been replaced by bedaquiline, and moxifloxacin high dose has been replaced by levofloxacin. Another thing to note is that bedaquiline is not for 4 to 6 months; it is for 6 months. So bedaquiline will be given for entire 6 months. Rest of the 6 drugs will be given for 4 months and can be extended to 6 months if required. And these 6 drugs are same: levofloxacin instead of moxifloxacin high dose, pyrazinamide, ethambutol, clofazimine, high dose INH and ethionamide. And in the continuation phase of 5 months, we have the 4 drugs: levofloxacin, pyrazinamide, ethambutol, and clofazimine. And again, it's again a package of treatment. No replacement is permitted. And as you know, initially when the shorter regimen was launched in the country, 7 states they had the shorter oral bedaquiline-containing regimen. In rest of the states and union territories, we had injection-containing regimen. And with effect from tomorrow, the entire country will have only shorter oral bedaquiline-containing regimen. But again, you see here, in case we misuse this regimen, and in that case, patient can do operations to bedaquiline, to a quinolone, and to a clofazimine, besides other drugs. And these are the 3 key drugs to be used in longer oral regimen. That is for pre-XDR and XDR. These are the 3 key drugs. So, ladies and gentlemen, it's my humble request, be sure that there shouldn't be any exclusion criteria before you start using the shorter regimen. These are the dosages. We have in drug resistance TB, we have 4 weight bands in adults: 16 to 29 kg, 30 to 45 kg, 46 to 70 kg, and more than 70 kg. I'm not going into details for the dosages. And coming to the last standard DRTB regimen, that is longer oral MDR-XDR-TB regimen. So as we saw, once inflammation resistance is detected, then we consider shorter oral bedaquiline-containing regimen. If it cannot be given, then we talk about the longer oral MDR-XDR-TB regimen. Now let us see what has been the major change today in the 2021 guidelines or WHO guidelines compared to before. This was a landmark article published in 2018. This changed the entire scenario of the understanding of the treatment of the MDR-XDR tuberculosis. In this, they used the individual patient data meta-analysis, which is the highest level of evidence. More than 12,000 patients across 25 countries, including 50 studies. And fortunately, we had 3 studies from India, from PGI Chandigarh, from my institute, and from Mumbai. So out of these 50 studies, 3 studies belong to our country also. So what it showed was that oral drugs like levofloxacin, moxifloxacin, linezolid, bedaquiline, they had greater treatment success, reduced deaths. Clofazimine, carbapenem, they had greater treatment success, but no reduced deaths. Pyrazinamide lowered the mortality only if susceptible, which is important. Drugs like streptomycin, amikacin, cycloserine, tazidone, they had modest benefits. Drugs like kanamycin or caprimycin, these were, the injections were the key drugs earlier. Then they were found to be associated with higher failures, relapses, deaths, and toxicity. So this was the one of the main observations which proved that these 2 drugs are not good. Although the kanamycin was not associated with worse outcomes middle low income countries because of lack of data. The data was not there. Then drugs like ethionamide, prothionamide, PAS, macrolide, amoxicillin, clavulanic acid, they did not have significant benefits or sometimes even worse outcomes. So if you see this, so they emphasize that oral drugs are superior. Injectables like kanamycin, caprimycin they should not be used. Then the WHO collected some more evidence. So they had evidence of more than 30,100 records across 40 countries and 53 studies. They also studied the serious adverse events of using these drugs. And then they came out with, in 2020, WHO consolidated guidelines for management of DRT. So they were released, and subsequently in March 21, the guidelines for PMDT in India, they were released. We were part of framing these guidelines. So what they did was, there was a regrouping of the anti-TB drugs for longer MDR-TB regime. They had a group A consisting of levofloxacin or moxifloxacin, bedaquiline, linezolid, and it was recommended that you should include all the three medicines in their TB regimen for MDR, XDR TB regimen. Group B included clofazimine, cycloserine, or trazodone, and it was recommended to add at least one or both the medicines in the regimen. Then they had Group C, which was the drugs in the Group C were to be added to complete the regimen when you cannot make a regimen using the Group A and Group B drugs. And the drugs in the Group C included ethambutol, delamanid, pyrazinamide, imipenem, cilastatin or meropenem, amikacin or streptomycin, ethionamide, and PAS. And these are in usual order of reference. That is, first, in case you cannot make a regimen, first consider ethambutol, then you consider delamanid, then pyrazinamide, like that. So this was the WHO recommendation. But you see, in India, when the guidelines were revised, we again collected the evidence, the drug resistance pattern in the country, the cost, the availability, the tolerance, everything. So it is in Indian guidelines, the replacement sequence is changed. I'll explain you why it was considered to be changed. As per WHO, ethambutol was the first step to be considered. But in India, the National Drug Resistance Surveillance showed among MDR, ethambutol resistance is seen in almost 46% of cases. So in Indian guidelines, it is placed much lower in the sequence. Then delamanid, by the time Indian guidelines were being framed, we had more evidence for the efficacy of delamanid. And this was considered to be used as the first drug in the sequence. Then pyrazinamide, again in India, it was observed in our drug resistance surveillance that among MDR-TB cases, it was new cases, it was to the tune of 31% resistance, and in the retreatment cases, 20%. So this was third drug in the sequence, was to be used only when sensitive to take care of this aspect. The next drug by the WHO was imipenem, cilastatin. So, but there are definitely serious issues of it's very, very expensive. I have personally used it in more than 100 cases. And there are logistic issues, we have to insert the PICC line there, and we have to give the infusion for 1 hour in the morning, infusion for 1 hour in the evening, and very, very expensive. Most of the patient will not be able to afford it, and we have to give it for 6 months, 7 months, 8 months. So this was used as recommended to be used as a last drug in the sequence of replacement. Then amikacin was there. This was recommended to be second drug in the sequence to be used only when sensitive. Ethionamide, prothionamide, fourth drug in the sequence to be used only when sensitive, because now in the first line LP, in case you find INHA mutation is not there, we know that ethionamide can be used. Similarly for amikacin, in the first and in this second LPA, we have the report from the available, so which can be available earlier that it cannot be used. And PAS was the fifth drug in the sequence, and then was ethambutol, and then imipenem, cilastatin. So the sequence in Indian PMDT guideline is first is delamanid, amikacin only if sensitive, pyrazinamide only if sensitive, ethionamide only if sensitive, then PAS, then ethambutol, and then imipenem, cilastatin or meropenem. In children, we prefer meropenem because of the lesser CNS side effects. Coming to the longer oral MDR XDR-TB regimen, as per WHO 2020 recommendation, as we just discussed, all the 3 group A agents and at least 1 group B agent should be included to ensure that treatment starts with at least 4 TB drugs, which are likely to be effective, and at least 3 agents to be included in the rest of the treatment. Because bedaquiline will have to stop after 6 months, usually. However, in India, the experts, when in the technical expert committee, they concurred to start with all the 5 drugs of group A and B and continue with the 4 drugs in the latter part of the regimen, that is after 6 to 8 months after stopping bedaquiline, if the patient can tolerate the drugs. And this was primarily for the operational needs in the field, because in the field, in case one drug cannot be tolerated, then you need to stop it. So stopping a drug, replacing it with the another drug, it's a challenge in the field. So the Indian experts took a call that we will give all the 5 drugs in the initial intensive phase or 6 months to 8 months, and then in the continuation phase, stop bedaquiline and give 4 drugs. And what is this regimen? This regimen is having 5 drugs: levofloxacin, bedaquiline, linezolid, clofazimine, and cycloserine, to be given for 18 months, which can go up to 20 months. That is, after initial 6 months, the regimen can be extended if required. Bedaquiline is given usually for 6 months only. In some rare circumstances, we may have to give it for longer. Linezolid is given for 600 mg in the 6 to 8 months initial, and then we reduce the dose to 300 mg. For XGRTB patient, the duration of the longer regimen is 20 months. These are the same 4 weight bands, and these are the dosages of the drugs to be used. Coming to the BPAL regimen, it was an XTB trial which investigated the role of this BPAL regimen, that is bedaquiline predominant linezolid. In the XTB trial, it was shown that in 110 patients, if you use these combination, almost 90% of the patient they achieved the treatment success, and 10% had unsuccessful outcome. So it was found to be very useful, and it was given in cases of XGRTB or MDR-TB patient who failed to treatment, or patient who are not tolerating the MDR-TB drugs. So based on that trial, the WHO has recommended that you can use this bedaquiline predominant linezolid under operational research condition, mind you, and that does not apply to routine programmatic use. As per WHO recommendation to be used in operation research conditions. Then in MDR-TB patient with TB that is resistant to fluoroquinolone, that is pre-XDR-TB, and provided that patient should have had no previous exposure to the bedaquiline and linezolid, or if at all have been exposed for no more than 2 weeks. So all the 3 conditions should be fulfilled. And in India also, we are doing the study on this BPAL regimen in different dosages and duration. The NIRT Chennai is the principal investigation site. Across 10 sites, there are 10 sites where the study is being used, and it just recently started and the enrollment is taking place. And discussion is incomplete without talking about the role of surgery. When to consider surgeries? When patients are not responding to medical therapy, or you feel that we should add on surgery to prevent the relapses. The requisite is that lesion should be localized, lesion should be resectable, and patient should be fit for surgery. The ideal time to do surgery is between 6 to 9 months of the treatment. And when you combine surgery with chemotherapy, the treatment success is definitely improved. Even up to 90% of cases, they can have lasting cures. These are few of the cases, like left upper lobe thick wall cavity, patient was not responding. And when surgery was combined with the chemotherapy, patient responded. Here, this was the brother of a doctor only, not responding to treatment even after 1 year. So we considered surgery. In our institute, we are doing surgery for last 50 years. All kind of resections, mediastinal tumors, trichoplasties, everything is being done. So we are able to offer surgery to the patient who need it. So with this, I come to the my concluding remarks. So first, I would like to focus again that we should always lay attention on preventing the DRTB by treating the drug-sensitive TB well. We know the phenotypic tests, they take long time, but they are good to assess the response to treatment. The genotypic test cannot be used once patient is being followed up. During follow-up, because you need to grow the culture to see whether the person has culture converted or not. So phenotypic tests, they have a role there. The genotypic tests definitely are faster, and they permit us to start the appropriate regimen at an early stage, which is required, because we cannot go on waiting for the phenotypic test results. So to start the treatment early and to start appropriate treatment regimen, we need the genotypic test. And the neurogenotypic test, Factor Expert, MTB-XDR, they will be a game changer for the early identification, because within 3-4 days of patient coming to us, we know patient is MDR or not, whether patient is pre-XGR-TB or not. And then accordingly, we can start the appropriate treatment, because suppose we do not know patient is pre-XGR and you put the patient on shorter MDR-TB regimen, till you have this report of second-line LPA. Sometimes we are seeing in the field for various reasons, reports of second-line LPA are coming after 2 months, 3 months. Sometimes report is available on the NICSHA, but the treating physician or the district TB officer, they are not downloading and not taking the action. This is also very commonly happening. But in the bargain, the patient does not get the benefit of second-line LPA report for 2 months, 3 months. And during these 2-3 months, patient is on a wrong regimen. And during these 2-3 months, patient can develop resistance to bedaquiline, to quinolones, to clofazimine, etc. So this expert MTB XDR, which tells you what the INH, ethionamide, and fluoroquinolone, also in the injectables, the resistance early, so that can help you in starting the appropriate regimen. And we should follow the integrated diagnostic and treatment algorithm for management of DRTB patients. And the new drugs like bedaquiline and delamanid, they look quite promising. Thank you very much for a very patient listening. Thank you all. And thank you for giving me this opportunity to interact with you all. Thanks.
Thank you very much, sir. There is only one question, but I couldn't get this question. What is the ideal time for MDR TB empyema?
Ideal time for MDR TB surgery?
Empyema.
Yeah, even empyema we should not delay. Once there is empyema means there is a pus in the pleural space, and normally the chronic empyema we say once it is there for 3 months it becomes a chronic empyema. But there are disadvantages of waiting for the chronic empyema. So ideal thing is you manage with antimicrobial treatment. If it is tubercular, give anti-TB treatment. If it is pyogenic, you give the antipyogenic treatment. But in case you find patient is not responding, then within 2-3 months we should operate the patient, so that at that time we can do the decortication. We can take out the entire pus and let the lung expand. In case you delay too much, then the underlying lung gets fibrosed, bronchiectatic, and it will never expand. So 2 to 3 months time we should do the in empyema cases. In case you find that the not responding to your antimicrobial treatment, one should consider surgery.
There is another question. New guideline, high dose INH given in CAT-G resistance.
No, you see, basically we just ignore it. There are 7 drugs in the shorter MDR TB regimen, and this is a package of treatment. So in case you see individually, it has inhibindole, it has pyrazinamide, it has high dose INH, you may feel that how this the treatment will be acting. But in the Bangladesh regimen also they found that in case you give these 7 drugs, and only in the MDR TB cases, but you rule out presence of XDR TB patients or pre-XDR, the fluoroquinolone resistance should not be there, and there should not be INH as well as CAT-G. In that case, this regimen is likely to act. And we are collecting the data in the country on the efficacy of this regimen, including the inclusion criteria and ensuring that there are no exclusion criteria. And we'll have the data from this regimen, and then we will see how good or bad this regimen is working. So presently, yes, if there is a CAT-G, you still give this 7-drug regimen, and there is no provision for replacing any drug.
There's one more question. Can empyema be assumed as EPTB?
Yes, empyema is EPTB. Empyema is EPTB because it involves pus in the pleura. This is not assumed, this is EPTB. If it is
There are no more questions. Thank you very much, sir, for the wonderful presentation. So we'll go on to the last speaker in this session.
Thank you.
So it's my proud privilege to introduce the next person who requires no introduction actually. Is the pride of our nation, Padma Shri awardee, former chairman of National Task Force and TEP RNDCP, ex-professor and HOD for Department of Pulmonary Medicine, PGI MPR, Chandigarh WHO Collaborating Center for Research and Capacity Building in Chronic Respiratory Disease, ex-OSD AIMS Raebareli, President Indian Chest Society, President Indian Society for Study of Lung Cancer, Dr. Digambar Behera. He will be speaking on challenges in the TB control. Over to you, sir.
अनम्यूट तो हो नहीं रहा है अनम्यूट हो नो नॉट ऑल अनम्यूट
Okay, thank you. A very good afternoon, everybody. And thank you, Professor Patnaik, for the nice introduction. I am asked at the very outset, I am thankful to Professor Bhaisanti Misra for giving this opportunity, but giving me a very difficult talk. Actually, it is a very politically sensitive answer that I have to give. But in any case, I will not be political. Neither I will be apolitical. I will just go strictly what is science and what are the facts. So what I like to discuss about the burden, the strategy, how to control TB, and what the program is doing, then something about the neurodiagnostic algorithm, and very nicely what Professor Singla had told you about the treatment. Then I'll try to punch some holes in his presentation also. Sorry and excuse Dr. Rupak, and then some of the other issues. You see, we all know that TB is contagious and airborne. It is the second leading infectious killer after COVID-19, and it is the 13th leading cause of death worldwide. It was also the leading killer of people with a number of comorbidity, and it is again a major cause of death related to antimicrobial resistance. In 2020, an estimated around 10 million people fell ill with TB worldwide, with almost equal number of men and women, and about 1.1 million children. And again, the most important thing is about 1.5 million people died because of TB in 2020. Although this is a reduction from 2.4 million in 2000, we can always say that yes, there is a almost 70–80% reduction, but the death of 1.5 million is a huge number. And globally, the incidence rate fell by only 11% as against our expectation. This is just a slide that shows this is the disability adjusted life years lost because of TB. This has come about few days back in JAMA Oncology. They have tried to estimate the disability adjusted life years because of cancer. And in that, we got a table where it shows a comparison. You see, the disability adjusted life years is in that includes both mortality as well as morbidity, the number of deaths as well as the number of other things affected because of the disease, the disability, the morbidity, and all other things. You see, the respiratory infections and the tuberculosis, it is 5th in the global ranking, and absolute disability adjusted life years lost is about 153 million. And that is almost same as that of other, because of other non-communicable diseases. So it may be just 4 or 5. It was realized about the problem of TB long back in our country. We have got the TB control programs, even starting from the 50s and 60s. At the beginning, the important TB research institute at the TRC Chennai and NTI Bangalore were established. And then we started the National TB program in 1962. And then the program was reviewed in 1992, and it could be seen that only 30% of the patients could be diagnosed. Of these, only 30% were treated successfully. Meaning thereby, if there are 100 patients of TB, so only 9 patients we could cure. Right? 30% means 30% could be diagnosed, and 30% of those diagnosed and put on treatment, they were treated. So meaning thereby only 9 patients out of 100. So has the situation changed? Now we'll see that. And then of course, then the other years about by 2006, the entire country was covered by the RNTCP, Revised National TB Control Program. We had the initial goal and the objectives because they are changed now. And then we have got a definite flow of system, how it should work of the central government, and then we have the central TB division, and then we have got national institutes, and at the state level, is the state TB cell, then the districts and the TUs or tuberculosis units, TB testing centers, then the TB treatment centers, and so on. The only issue, please remember here, mode of management. Let me tell you, it is the central side, and then also there is a state machinery. The central TB division works through the center. I think this is, I will not elaborate further. I am sure you all will understand what I mean and why I mean so. So then these are the various milestones, the evolution of our national program at different times. You know, a lot of work has been done and the strategy has been changed, how to get better result. So actually what happened in the early 90s, the first strategy was the dot strategy. These things still remains, you know, with 5 important components that everybody knows. And then in 2006, it was a stop TB strategy. So here to pursue high quality dots, that was there, how it is to be expanded, then addressing important comorbidities like TB, HIV, MDR TB and other challenges, contribute to the health system strengthening, engage all care providers, empowering people with TB and the social or the societal engagement, and then enabling and promoting research. Then in 2014, the strategy was changed. It was known as the NTB strategy. It was integrated patient-centered TB care and prevention. There are bold policies and the more important system of supporting things were given to the system, and then the research and innovations were intensified. So this is how the evolution started. Then obviously I'm not going to tell you about the stop TB strategy, but now we have got the NTB strategy. So new strategy was passed by WHO in a resolution in May 2014, where the new post 2015 global TB strategy was done with ambitious targets. So what are those targets? The NTB strategy, which is still in vogue. There are the 3 important parameters. One is the reduction in the number of TB deaths. Number 2 is the incidence rate to be reduced. And then third, the TB affected families facing catastrophic cost due to TB. We all know about that. So then at different years, the TB deaths to be reduced by certain percentage in comparison to 2015, and then 20, 25, 30, 35. So the targets were kept, right? So say for example, by 2035, the number of TB deaths in comparison to 2015 should be reduced by 95%. And similarly, the incidence rate should be reduced by 90%, and then no family should face catastrophic cost due to TB. So these are the 3 important strategies, and there are definite pillars. You know, there are 3 important pillars with the so how to go about it, how to so everything was inbuilt in that. I think this seems in pen and paper, it is a very good strategy. And again, you see, this is another modeling that has been done. If you see actually, if you achieve that target, if you start from below, you see that curve, the reduction of TB incidence should be reduced by, if it is by 10%, then by 2035, it should be 17% per year and so on. But actually what is happening in the current global trend is just between 1.5 to 5%. So we have not yet reached, that means we have to push the curve down. That is what called the push the curve down. So that is not happening. And then this is what is called as the 90% strategy, that is 90 they reach at least 90% of all people with TB. As part of this approach, reach at least 90% of the key population, and the treatment success would be at least 90%. That is what is the strategy. And then obviously on 13th March 2018, the Honorable Prime Minister, that was a landmark event towards the complete elimination of TB. And he announced that the targets for ending TB, it was moved ahead by 5 years. This is a very, very ambitious target. But maybe, I think, unless it is always said that some people say it may be dream, but unless you dream, you cannot, achieve. You cannot achieve the target. So you must dream. So dreaming is not bad. Dream is always good for health, right? So this will be emphasizing that it emphasizes certain thing. That means you must work very hard. And then the importance of working together for the cause of the disease. So that is what was possibly the main idea of the Honorable Prime Minister. So now let us see if with all these things, let us examine what the program has achieved or is doing. And so this will be a rough update. You see, since the inception of RNTCP, that is March 2006, this free diagnosis and treatment are provided. More than 20 million TB patients are treated under the program. More than 3.5 million additional lives have been saved. Then 1.4 million TB patients are tested for drug resistance. Then about the 0.14 million drug, the figure is more, the slide is a little older. And then the notification from the private sector has increased. I will also show you slides. So this is a India TB report 2021. I don't have the access to 2022 report, but in any case, I have got some information, but I can't show it here because it will be officially released tomorrow. So please bear with me. This is a 1 year old report, but that will give you a trend, and it is almost the same. You see, again, unfortunately, India has only not only India has 26% of the global burden of TB, followed by other countries. 2/3 of this burden in 8 countries, which is shown here, and India is at the top of the list. The case notification, what happens? How do we know the TB number? It can be on 2 ways. Either it comes, we have got a NICHA system, or what is electronic based notification system. So everybody who diagnosed the case puts him on treatment. So then he is supposed to report it to the NICHA. It should be registered into the electronic system. But how the other way is, so that is the notification. That means patients are diagnosed. So the less number can be because of 2 reasons. Either we are not able to diagnose them, so obviously we cannot notify them. Or the second thing, so there are some people who diagnose them, but they don't notify them. So I'm not trying to tell you the remaining number of cases are all lost. Obviously, some people are treating, some of them are getting treatment, but they are not coming to our system. So this can be 2 ways. So to be very fair, you see what happened. You see in 2018, the case notification was around 21 lakhs of cases. So, but that was about 73% of the estimated number that WHO has estimated based upon the statistics. It should be this number, but this notification was 73%. In 19, actually, we are going. Our case notification rate was 84%. You see, the private sector, the second row, it is again, that is a good thing that it is increasing. From the private sector is now notified. The cases from the private sector are coming, but it is again only 69% of the expected value. So while we are going up and up, then in 20 came the COVID and 21 came the COVID. So what happened? The case notification rate came down to 60% of the estimated number. So that is again a big setback. Say also for the 2021, that is the data is available in the NICHA portal. Anybody can see that. So the number is 74% from the public sector and 67% from the private sector. So overall, it is about 72% of the. So that means here about 18%, about 28%, right? Cases were not notified or diagnosed, whatever you may call it. So this is what again shown in a diagrammatic form in the same way. The green ones are the from the public sector, and then the yellow one from the private sector. As you can see, as we are going up, but again suddenly we have come down. In fact, then comes the issue of again this is the total TB notified, and then the treatment initiated. Again there is a issue here. Even if we notify them about 5% of the cases, they could not be started on treatment by the program because of whatever reason. So again, another 5% lost. So then they are notified and are not initiated on treatment. You can see another, sorry, it is 5%. Notified, then if you go to the next table, you see the treatment success rate. If you see the second row, table 2 below, you see the treatment success rate is 82%. So what does it say? Again, that means if you have got 100 patients of TB, the same formula I told you earlier, then your case notification is 72% in 2020 or 21. So that means 28% is gone. So then those 72%, their success rate is 82%, right? So those 100 original TB patients, because I will take the all cases in the society. So you see, so overall 64 or 65 patients have TB. Actually, they are getting successfully treated. That is how I look at it. I may be wrong, or that is possibly the truth. So then these are the various strategies. Obviously, program is trying to do. Our initial strategy was passive case finding based on the footfall in the health facility patient, those who are symptomatic, they used to report, right? And then came the intensified case finding, where this case detection was done in comorbid conditions like HIV and diabetes. Then active case finding was done through the systematic screening of the vulnerable population like migrants, slum, prisons, contacts of drug-resistant TB, pediatric cases. And then obviously now it is the population-based screening from 2020 onwards, just to increase the case notification. So obviously, whenever there is an issue, the program is going to fill that up. You can see this is how the active case finding, how people go and how the healthcare workers go and they inquire about the case, about the cases, their symptoms, and then the X-ray and the microbiological test is done. So this one is the this slide shows the overall case detection rate, what is the target and what we are getting. So this is actually is not very good. Then in 21 January, 1st January 2021, the name was changed to give a thrust to the thought of Honorable Prime Minister. The name was RNTCP was changed into National TB Elimination Program. So that, whenever you change any name, anything, obviously new enthusiasm, new thrust was given to that. However, we must understand the challenges for TB control is, as I have already said and shown, there is under-reporting and uncertain care of TB patients in the private sector. There is unregulated private sector and healthcare delivery system in the country. Anybody and everybody is handling TB, starting from diagnosis to treatment, reaching the unreached, that the marginalized and vulnerable population is an issue. Then drug resistance, comorbidities, undernutrition, overcrowding, wide geographical variation in the epidemic, and many more that we'll see. So there is a persisting burden, there is a stagnation of case notification, then the drug resistance, HIV, non-communicable diseases and TB, comorbidities, TB treatment outcomes. Of course, it has increased, it is now better. Weak health system, slow decline in incidence, funding gaps, and underlying determinants, which will be seen in a later. So it was realized that, TB is just not a clinical disease, it is just not sputum smear positive, negative, CV node positive, negative, culture positive, negative, and start the treatment. No, I think it has got other dimensions, like it is both public health and social issue that needs patient support, engage all healthcare. So it is good that the program has realized that, and that so therefore TB is not only a medical disease, it is a socio-medical disease. So I think, so all these components are come up. As you can see, maybe if there is a slide or not, now there is a fund transfer, giving support for the travel to the treatment center, and so on and so forth. So, even with that, the program is increasing the diagnostic facilities, starting from microscopy centers. You can see we have around 14.5 thousand in 2017, and now in 2019 it is 20,000, and in 21 it is 22,000 plus. Similarly, for the rapid molecular test, the number again is, you can see, started with 1135, both the gene export and the CBNAT. So they are there, and now the figure is around 3,100 plus, and the plan is it will be extended to about more than 5,000 in the country. These are the diagnosis of DRTB patients. Because of this, you can see the curve is going up, and then the utilization of CBNAT on the right hand side, you can see the number of tests done per month is also increasing. But the question is, yes, this graph looks very impressive. Yes, they're all increasing, but the question is, are they enough? That is the point. Are they enough? Are they reaching to the people where it should reach? That is what is the point we have to understand. So we have got actually expanded very rapidly with the biosafety laboratories, then the intermediate reference laboratories, NRLs, and all those things have come up. So this is about the diagnostic network. You can see the microscopy center, the latest I told about 22,000, the NAT machines over 3,100, culture and DST laboratories which are accredited, 47, IRLs or intermediate laboratories 34, and NRLs are 6. So this is how there is a rapid expansion of the diagnostic facilities. But again, as I said, so how are they sufficient? Then obviously we are issue of TB and diabetes. There is a collaborative mechanism, but question is, are it supposed to be that all diabetics should be screened? Here you can see this is possibly not yet done fully. It causes a lot of interaction between the two. Similarly, we have joint TB and tobacco collaborative activities, and then the TB and the nutrition, the nutritional support to the TB patients, it is there. And then the TB and the pregnancy, it is again another issue. Then the pediatric TB is actually somehow is an issue for this country. It is an important cause of death, and it is expected that about 10% of total TB burden of Indian pediatric patients should be there. The actual report actually, it should be, of the, if it is 10%, so the case notification is around 1 lakh. But actually it should be of the 18 lakh cases that are reported, that is just 5.6%. That means still half of the pediatric cases are being missed, or they are not reported, whatever you may say, because the diagnosis of TB in pediatrics is very difficult. And then this is about the DRTB in the pediatrics population. We have got no official data, but now in 2019, more than 5,000 DRTB cases were reported in case of pediatric population. So we have got now a national strategic plan 2017-2025 for the 8 years with a vision of TB-free India and the goal of universal access to quality TB diagnosis and treatment for all TB patients in the community. And remember, it is all. The objective is early and improved diagnosis, access to high quality treatment, scaling of the access to effective drug-resistant TB treatment, decreasing the morbidity and mortality in HIV-TB, and extending the RNTCB services to the private sector also, because that is a very important component. So therefore, where the TB care in 2016 from 1.5 million, so we have to go to care for nearly 3.5 million cases. So the important strategy, the approach is detect, treat, prevent, and build. This is so to find a TB case with an emphasis and reaching every TB patient in the private sector, treat a TB case with high quality anti-TB drugs, and prevent the emergence of TB in the susceptible population, as I told you, and then build and strengthen the supportive system, including enabling the the public sector. You can see this is we have got the TB units more than 3,600. We have got district units 712. The district units are different than the political districts. And then the designated microscopy centers we have seen. And this we have already told what is how the microscopy centers, laboratories and other things are opening. So the way forward will be both technical and operational guidelines. Then every component is mentioned here, and then we have got a TB elimination strategy by engaging through active case finding, then handling TB comorbidities, having a multi-sectoral response, handling drug-resistant issues, and then the ICT tools for adherence and monitoring and preventive measures. So these are, the 7 important pillars. You can see this is a vicious cycle of TB, poverty, and malnutrition. So then that all becomes a cycle. So I think these are the problem lies there. So it is just TB is not enough. So we have to take care of nutrition. So different type of oil is required for that. And then reaching the vulnerable population. So, that the different population areas. And then this is now we have an effective regimen for the so-called drug sensitive TB. It is already rolled out across the country. And then there are the adherence system, the drugs that we have got a daily regimen. The dose of drugs are according to the body weight. It is a FDC or fixed dose combination. There are child-friendly formulations. The information technology enabled treatment adherence support system. And then the regimen is acceptable to all healthcare providers. So this is what about that. And again, you see, as I told you, the scaling up of CBNAT machines. Then we have got a TB is integrated out the National Urban Health Mission. And then for the social protection, you did the cost of diagnosis and cost treatment, where for the specific population, there is the cost of travel is borne, nutrition, wage loss, out-of-pocket expenditure, cost of diagnosis. So all these things are taken care of. There is a nutritional support, the rupees 500 per month is given. Then this is called the Jan Trinity. This is the Jan Dhan Yojana, Aadhaar and the Nikya scheme, where they are all integrated, linking the Pradhan Mantri Jan Dhan Yojana, Aadhaar and the Nikya. So all these healthcare facilities are being made together. And these are the special vulnerable group where specific attention is given. That is the clients attending HIV care settings, substance abuse, comorbidities like diabetes, malignancies, patients in dialysis and long-term immunosuppression therapy, healthcare worker, household and workplace contacts, then patients with past history of TB, malnourished, then antenatal mothers attending ANC and MCH, then the social like prisoners, occupations with risk of developing TB, like occupational disease like silicosis, people in congregated settings, night shelters, de-addiction centers, old age homes, then the urban slums, hard to reach areas, and indigenous tribal. So these are the vulnerable group where specific attention is given. But question is, they should actually really practicable and practically they should be done. So for the pediatric cases, there are different centers now established. This is one of the slides that shows when it was started at 3 different places. The TB is again a notifiable disease because you are supposed to notify the TB, otherwise you will be jailed or fined. That is all medical. So now coming to the second important issue about the resistance, drug resistance. My first issue comes here. You all know that from 1st January 21, the definition of XDR TB has been changed. So the MDR or RR, rifampicin resistant TB, remains as such. However, for XDR TB, it is a form of MDR TB, as you all know, but it says that it should be also resistant to fluoroquinolone and at least one additional group A drugs. So that means group A drugs is linezolid and bedaquiline. So the point is, have we got that data yet? If you ask, the answer is no. So again, it is a enormous task for the microbiologists to work on that, how to do. So as regards the MDR-TB, again, India is the capital of MDR-TB. It is the capital of MDR-TB in the world. 27% of the MDR-TB in the world is in India. And then that is followed by China, just 14%, Russia, about 8%, and then other 7-8 countries. But India is again leading in that. So the problem with the drug-resistant TB is the underdiagnosis because of missing TB cases, limited testing, although we are increasing, and then linkages and the capacity. Even if the patients are diagnosed, we are told that the CBNAT it takes 110 minutes or 2 hours. But actually go and ask a patient how much time it takes to get the report, and then how much time it takes to start the treatment. So that is just telling that yes, we got a CBNAT within 110 minutes. That is not enough. That is not percolating to the patient who is actually really the beneficiary. I'm not telling everybody is doing that, but or everywhere it is happening, but by and large it is happening. It should not happen. If you have got a test, if you have got a machine, if you have got experts giving a report, why it should not go to the, if somebody is having a heart attack or chest pain, a coronary angio is done and a blockade is found, do you think the doctor says you go and come after 2 years, I will put a stent? No, it is done immediately then and there. So I think that type of approach is required. So it is not happening. Number 2, treatment is obviously long duration. Okay, from 18 months, 12 months, now we have come down to 6 months. The efficacy, particularly of the MDR-TB, then the complexity in the management, and then particularly the issues of adherence, adverse drug reactions, and the severity of the disease. These are the practical points for the MDR-TB I am talking. You see, we have got the data available from 2000 onwards, the percentage of the MDR and the XTR information is there, except the last definition of XTR-TB. So this is one of that was undertaken by the program. This was one of the largest DR-TB surveys in the world, that covering 1.25 billion population. And then we have got the information about all these 13 drugs, first line and second line drugs. So what it says, I think that slide is missing. So what it says, that any INH resistance is to the tune of 22%, new cases about 11%, about MDR-TB new cases 2.8%, in previously treated cases about 13-14%. And then you see, remember, which is again very important, which I'm going to tell you subsequently, and also Dr. Singla, which he had said, if you remember one line he said, in the indication, I'll come to that, but please remember the pre-XTR, that means the fluoroquinolone resistance, is to the tune of 22%. Different survey from this country, microbiologists have reported varying from 16 to as high as 44-43% of fluoroquinolone resistance in cases of MDR-TB, right? That is pre-XTR. And then obviously WHO is at the forefront in making the guidelines, starting from, you can see so many guidelines, depending upon when the evidence is available and they are updated. And this is our PMDT, we call it Programmatic Management of Drug-Resistant TB. In India, it initiated in 2007. And then at different times, there is a strategy. And that I'll show you in a minute. You see, at that time, what we used to call as the CAT4 treatment, or the other one, we call it, what was the name? It was the, the CAT4 or DOTS plus, it was called as DOTS plus treatment. Then these are the 7 drugs for 6 to 9 months in the intensive phase, and another 4 drugs for 18 months. So it varies between 24 to 27 months. And depending upon the 3 weight bands, that is what was being used previously. Then for XTR-TB, again, the duration was between 27 to 30 months. So then, whatever, and then when we first did it under the, under the trial condition, the success was quite okay. It was around 61%. That was first time done in the, LRS Institute at Delhi. But you see what is the program result? You see, this shows from the starting from 2007 till about 2017, when we switched over to the other chemotherapy, which Singla had said. You see the success rate below in green, it is just below 50%. You see, 35 to 48%, it is always below 50% success rate under the program. Then nearly 20%, 1/5 of the patient died during the therapy or during the course of treatment. Then another 20% they are lost to follow-up. So the success rate was very, very disappointing with those regimens, which I showed you. The XTR TB again situation still worse. You see, success rate was only 33%, 33% with the regimen which I had shown you. And then again, nearly 40% of the people died during the course of therapy. So obviously there was a need, and obviously at that time, nobody can criticize anybody because that time those are the drugs which are available. You can't do anything about that. And of course, it is not only in India, also this table compares between the global picture as well as the Southeast Asian countries. They are almost same, maybe 4 or 5% this way or that way. So what I'm trying to say, the treatment response to MDR and XDR-TB was very, very poor. And then another important issue is the availability of the anti-TB drugs. You see, the first anti-TB drug, that is streptomycin, was discovered in 1943. For the next about 20-30 years, obviously different other drugs came, and the last drug was rifampicin. That was somewhere in late 70s or 80s. Then for a good 40 years, nothing happens. Nobody even thought of working on the TB drugs or anything. When the TB Alliance was formed, and then the bedaquiline as the first drug came in 2012. Then after 2 years came the delmanid, which in 2014. So that was again another how TB was a neglected disease. Now these are different drugs are on pipeline. And then what the three important clinical drugs are bedaquiline, delmanide, and pretomanide. So these are the three drugs, and Dr. Singla already has told you about that. So these are the high priority actions. They are to take care of the drug-resistant TB crisis. That is to prevent the development of drug resistance through high quality treatment of drug susceptible TB, so that will prevent MDR or rifampicin resistant TB as a first priority. The second priority should be expand the rapid testing and detection of drug resistant TB cases, and scale up the rapid testing and detection of all MDR RR TB cases. Then provide immediate access to effective treatment and their proper care, ensure prompt access to appropriate care, including adequate supplies of quality drugs and scaled up country capacity to deliver these services. And then prevent transmission through infection control measures, by appropriate TB infection control measures, and then of course increase political commitment with financing for drugs, manpower, and everything else, diagnostics, everything. That is also very important. So these are the 5 important key points. So they are required, and then obviously this is the updated guideline which you have just seen. Then the grouping of drugs, Dr. Singla said, but is the basis of that. In India also we have got our own the DRTB guideline that was released last year. And then again, please have a little focus on this slide, right? The graph, if you see it shows the case detection of drug-resistant TB. The red one that shows the number of cases detected. You see, obviously, this looks an impressive graph if you compare from 2007 to 2020. But there is a catch here. What is the catch? The catch is how many cases you detected in 2020. It is something like 66,000 cases. If you remember my slide, I have told you what is the expected cases in the country, 1,24,000. So what is the percentage? So how many percent of cases you are detecting? You are only able to detect, even with all your effort, it is only 50% or little more than 52, 54%. So where are the remaining cases? So again, this is a gap. It is again I repeat and re-emphasize, these are not political statements, neither it is to criticize anybody. This is the reality check. And then again, the below one, which is a little green slide, that says Even not or even if you have detected with so much effort, you are not able to treat everybody. Still there is a gap, right? Still there is a gap. Why even the 8-10% of cases you are not able to treat them, give them treatment. Again, this slide you have seen by Dr. Singla. But if you remember, you see what he says. It says that all TB patients do a NAT, then first specimen tested at the NAT site, then a rifampicin resistance detected, that is MDR-TB. So you see the left-hand side, then you subject the patient to first line LPA, second line LPA, liquid culture DST to find out the resistance of the drugs like pyrazinamide, bedaquiline, clofazimine, moxifloxacin, linezolid, and delmonide, right? Bedaquiline, delmonide is not yet widely available in this country or laboratories. And then again, you see one of the very important things is the fluoroquinolone. Again, I will come to that. Fluoroquinolone resistance you have to see. I have told you around 20, 25, 22%, whatever may be the percentage. So those number of patients cannot be put on short course chemotherapy. He told you that as one of the contraindications for short course chemotherapy. Number two, he also told you if the INHA, the CAT-G or INHA gene, if both are positive, again you cannot give them that also. So you just add up. So you are trying to take out a major chunk of them. Of course, there are other contraindications. So even if they are good drugs, so a major chunk of these DRTB cases cannot be put on this treatment. So they have to go to the long oral treatment. So that is what is the main point. So again, it's the same thing. He has shown you the slide, INH resistance. We are doing that. That is a good thing. We have shorter regimen. The results have improved up to 68% about all oral longer treatment. Again, the linezolid, there is an issue. There will be, I'm sure, linezolid you are going to face the problem. Linezolid is an antibiotic used extensively by people, critical care medicine and other areas will face the same problem. So this is the duration. Of course, from 24, 27 months, we have come down to 18 to 20 months. Okay, it is good that 6-7 months has come down. So these are the, so without, these are the contraindications we show that when there is no previous exposure to second line treatment, without fluoroquinone resistance, no extensive disease or severe extrapulmonary TB, then, so the what should be the option of treatment? So at least a sizable number will not be offered this treatment. But again, obviously now we are moving towards the injection pre-treatment, both for the INH resistant, mono-resistance cases, and also the short course regimen, bedaquiline containing regimen, which will be declared tomorrow by the Honorable Health Minister. And obviously the result is very good. You can see from below 50% with these drugs, if they can be used, the success rate is good. But again, it is not nowhere near 90%. Remember about that. So then the BPAL, Singla talked about that. Yes, BPAL is under trial. The TRC is doing this trial in the pre-XTR and XTR cases. The ITRC, Indian TB Research Consortium, is trying this regimen for MDR TB cases. The site selection will be done next week. So the protocol is already finalized, and then the site selection is being made. So let us see. So we have to see our main strategy should be prevent, detect, and treat cases. The one last point I'll just tell you before concluding. You have to understand that there are a lot of determinants which are very rampant in this country. The 2 or 3 things, the household contacts we said, you see the household contacts are there. The prophylactic therapy is not yet complete. We have at present our policy is INH. And then number 2, malnutrition, overcrowding, the HIV, diabetes. India was the diabetes capital. The huge number will be there. It is projected by 2025 we will have 30 million diabetic cases occurring. Then the occupation, silicosis, so many things. So prisons, slums, everything is there. So, and then we have got a huge, reservoir of TB infection. 40% of our people are TB, are the tuberculosis positive. So that means they are infected. So this is a huge soil is there. And then opportune moment, then that will be converted into disease. So I think, so there are so many opportunities for TB to grow in this country. So ladies and gentlemen, I will stop here. You see, but all that what I tried to say is not, it should not be taken as that I told maybe many of the negative things, but those are the things. But the positive aspect is the program is expanding, and it is a huge task. Obviously, then you have to convince people. Everybody is convinced about, even during the COVID, people did not want to take the vaccination to start with. So we have to do a lot of effort. Similarly, the TB is a slow disease. Okay, it is coming, so people are not immediately dying. But the enormous amount of socioeconomic loss, and of course the life loss, I told the Delhi's, the disability adjusted life years, creating problem for the family. It is a challenge, both for the patient, the family, to the doctor, as well as to the program also. But I'm sure the things will come up. The only I'll just tell you my last slide and what will be my take. I'll show you my last slide. My own take will be, I'll just summarize my last talk is that, it seems to be a difficult task, 2025. We may have to change or redate the NTB in this country. It is a hard task ahead. It is achievable, but coordinated effort and hard work and good public health response is necessary. And the science does not fail us. We are responsible to fail ourselves and science. I think that is the message. The second thing which I did not try to tell you, I had few slides, but I decided not to show that, because you see the finance and the human resource issue. You'll be surprised to know that the finance, even whatever finance is given, it is a 60-40 ratio. 60% given by the center, 40 is given by the state. The contribution, it is always a fight. The human resource, whatever is sanctioned, they are never 100%. In the many states, you will see the human resource is only 30%. Even they will say this technician, that worker is not filled. The money which is even available, forget about the total amount required. Whatever is available, that is not utilized. I think these are some of the hidden facts we must try to understand. Every one of us must make noise. Then only there are states, because their names were there, so I did not want to show those slides purposefully. The utilization rate is just 15%. How can you work for TB? And as I told you, in one of the meetings when the health minister was taking the meeting, we suggested to him, sir, if you want to do it, don't make this dual responsibility. But the problem is it is a constitutional provision. The health issue center cannot take up its own. It has to be, I think when there is a coordinated effort, it is possible, but it will be very difficult, particularly in this country. Maybe time will come and this thing will come up. So with this, I thank you all. And then you draw your own conclusion. Thank you.
Thank you, sir, for that.
You have to thank me.
Thank you. And there are no questions actually. You have been so lucid, so there have been no questions. Thank you very much, sir.
Good care.
She responded, I think. Yes, she's there. She's there, no? Dr. Jyoti.
Sir, there are no questions. Thank you very much.
चलो तुम कर लो.
I think Jyoti madam, there's some technical problem to connect. So thank you, sir. I think it's an excellent talk, and here also it was a pin drop silence. I hope everybody has enjoyed, and the plus and minus and challenges, how to end TB. So as sir said, draw your own conclusion. So thank you, sir. Thank you for the great talk.
Thank you.
So our second session was very much informative session. So thanks to our chairpersons, and special thanks to our guest speakers for highlighting the facts where we are today. So now we are moving towards the last part of the academic session, which is the interesting case discussions by two of our technicians. And after that, very much awaited event, that is the result and announcement for the posters. So participants, kindly stay tuned and be with us. For the last session, I would like to invite Dr. Vibhudatta Rautre, consultant microbiologist, Amri
Cartoon,
Yes, and Dr. Sunita Sahu, consultant microbiologist, Apollo Hospital, Bhubaneswar, to chair the session. So over to Dr. Vibhudatta Rautre and Dr. Sunita Sahu now.
Yeah. So good evening. Actually, I was attending from 2 o'clock, and I had really a brainstorming session. First, the diagnosis part, then this treatment part by the two eminent personalities. So I have the opportunity. First of all, I must thank Vajayanti madam for giving me this chance in introducing Dr. Mantu Jain. So I'll not waste much of the time because we are already late, almost 1.5 hours down the time. So Dr. Mantu Jain is an associate professor in the Department of Orthopedics, AIIMS Bhubaneswar. He has 65 publications to his credit, and he is also a member of the editorial team of Indian Journal of Orthopedics and also World Journal of Orthopedics. And he will be discussing about a case scenario because day to day as a clinician, we are facing in the hospital. Today only I saw 4 or 5 slides, out of which 2 came positive, and there are a lot of NTM cases.
So very warm good evening, and I thank madam for giving me this opportunity. So, am I audible now? Chairman sir, am I audible? Am I audible now? So tuberculosis has been a great mimic, and spinal tuberculosis is no exception. It's not moving now. So previously, physicians used to give this tubercular anti-tubercular drug to empirically treat diseases which has clinical and radiological similarities with tuberculosis, and this has led to development of drug-resistant tuberculosis on one side, and also precluded to diagnose other potentially dangerous diseases. Hence, the first step is always confirmation of the diagnosis of tuberculosis. But as far as the spinal tuberculosis is concerned, there are few problems associated with it. Number one is that to get a biopsy, one has to go deep inside the tissue, and many times you require some expertise and helping hand in the form of radiologist. The bacteria are paucibacillary, and the growth also is, the growth and culture takes a lot of time. If there is a delay in diagnosis, then this could lead to development of deformities and also neurosurgical complications. So the government of India, along with collaboration with the World Health Organization and the AIIMS New Delhi, came up with this index tubercular guidelines. This has become the holy bible of management of extrapulmonary tuberculosis in the recent times, and spinal tuberculosis has been clearly defined in chapter number 17. So the spectrum of spinal tuberculosis is vast. On the left upper corner, we can see a patient with multiple vertebral body involvement and large number of abscess. This is present inside the body and not visible, but on the lower half, you can see there is a patient with a large psoas abscess. On the right hand upper corner, we see a patient with a craniovertebral junctional tuberculosis, which causes instability. And if the patient is neglected, then it can cause severe kyphosis as seen in the lower corner. So tubercular is mostly a medicinal disease, but yes, there are some indications when you need to operate, and these are basically based on two principles. The first principle is whenever your diagnosis is not confirmatory. So to confirm a diagnosis, one may have to do a biopsy or even open biopsy, and that is the first principle. And the second principle is whenever there is pain, there is a neurological component involved, there is a deformity, or there is an instability. So this brings me to a very important, interesting case in our scenario, and he's a child with a pediatric patient with a spinal tuberculosis, a 2-year-old male child who presented with a bump in the back for 4 months with a history of fever in the past. So apart from the bump, the patient was still able to walk. He had some signs of upper motor neuron palsy, but he had abdominal reflexes which was present. So on examination, we find the X-ray, there is collapse of D11 and D12 vertebra, and there is a kyphosis which is developing at the dorsal lumbar junction, and the kyphosis here is 45 degree. So the MRI was done for this patient, and the MRI shows that there is vertebral body, there is multiple vertebral body involvement, there is an extensive pre and paravertebral involvement which gets enhanced on contrast, and there is also large abscesses, psoas more on the right side, which can be seen on the axial section. So the key here is again clinching the diagnosis. So here with the help of our interventional radiologist, we could get an aspirate from ultrasound guided from the right psoas, and about 20 ml of aspirate was taken, which was then analyzed for pyogenic as well as for gene expert analysis. And you can see the report that Mycobacterium tuberculosis could be detected and rifampicin resistance was not detected. The patient was started on anti-tubercular therapy. So this was his first step. But if you follow the natural history of a patient of a pediatric patient with a spinal tuberculosis, there are certain spine at risk signs. So Dr. Rajshekharan and all have described certain spine at risk sign. So people who have these spine at risk sign, they have a final kyphosis of more than 60 degree, which can cause severe cardiopulmonary compromise apart from late onset neurology. So these spine at risk signs are separation of the facet, posterior retropulsion, lateral translation, and a toppling sign. So if any patient has 2 or more signs, then he requires surgical intervention. So our patient had 2 spine at risk sign. So we took the patient to the operating theater, and here you can see that posterior approach was taken and the spinal cord was decompressed circumferentially, and instrumentation was done 2 level up and 2 level down. Again, instrumenting a pediatric spine is also very difficult because the child is still in the growing age and you don't have the right kind of implants. So here we have used the cervical spine implants of an adult patient in these pediatric patients. So this is his post-operative X-ray, and the kyphosis is corrected from 45 degree to 3 degree. And the patient is mobilized in the ward in the 5th or 6th post-operative day. Now the patient was going on well and he had clinical improvement, but at 4 or 5 months, he presented again with a kyphosis. And this time we went in and got a CT scan done, and we found that there is a broken implant. There was some amount of fusion in the bone process, but as I told you, that the thin cervical implants, they gave away because of the mobility of the patient. So the patient was again taken to operation theater, and this time we used the pedicle set of the pediatric set, and we used the stouter screws and a thicker rod, and this time we also put a trans connector. So the index tubercular guidelines suggest that the first MRI should be taken at 6 months to see if there is formation of any new lesion during the course of the treatment, and also to see the progress of healing of the tubercular lesions. So here we can see that there is healing of the tubercular lesions, and the pre and paravertebral soft tissue shadows, they are disappearing. So this was his follow-up at 1 year after the completion of anti-tubercular therapy. The patient is now having no complaints and he was able to walk normally. So the treatment completes after the follow-up is for 2 years after the completion of treatment to say that the patient is now completely cured of the disease. So this is his follow-up 2 years after the treatment completion, and here the implants are holding good. On the X-ray, you can see that there is a sclerosis of the vertebra, and the same can be seen in the MRI which was done recently. There is no edema, no pre or paravertebral tissue, and there is no any further lesion seen in the patient. So now the patient can be stamped as a treated tubercular spine patient. So this is his final follow-up, and you can appreciate that the patient is doing very well. He has no mobility issues. So to discuss few of the cases which have been done elsewhere, and here is a similar patient who had a T9, T8, T9 port spine, and a corpectomy was done, and the patient here could not be instrumented, and he was immobilized using a body plaster. So this was yet a smaller child of 13 months, and here the authors have used this Stenman pin and used some wires to fix along with a fibular graft. So this was a 3-year-old child, slightly bigger than our child, and here the authors have used the same adult cervical pedicle lateral mass screws as pedicle screws and did an anterior and posterior job. So whenever there is an involvement of more than 3 vertebral bodies, particularly in the thoracic region, and the age of the child is less than 10 years of age, these children are always prone to develop severe kyphosis, that is more than 60 degrees, which can cause cardiopulmonary compromise. Hence, they require some kind of surgical intervention in addition to the medicinal treatment of tuberculosis. However, there is a flip. If you go more and if you do more and more fusion, then these pediatric patients, they can develop iatrogenic shortening of the trunk. They can have a crankshaft phenomena, and they can also develop pulmonary hypoplasia because of restricted growth of rib cage. So to summarize, I would say that tuberculosis management is a multidisciplinary approach. While medicine remains the mainstay of the treatment, and there are only few indications when the surgery is required, the pathway to recovery is smooth. So when there is a curve, a bend, or a hump, then one need to introspect the diagnosis, whether what you are dealing is actually a tuberculosis or not. And if you are dealing with a tuberculosis patient, then probably you have to suspect a drug resistance. More so if there is poor clinical and radiological response after 5 months of treatment, if there is a fresh appearance of a lesion on an MRI which is done at 6 months, if there is the appearance of a new discharging sinuses or wound dehiscence. So I thank you for your patience hearing.
Yeah, Dr. Sumita and Dr. Vibhudatta is there.
Yeah, thanks. Thanks, sir, for this excellent presentation. For this, the port spine is a common where also in Sri Hospital I see do lot many of cases. Now it's over to Ms. Sunita, madam.
Yeah, thank you, Dr. Vibhu, and thank you, Dr. Mantu Jain. That was a very nice presentation. It's my pleasure to invite Dr. Manas Kumar Panigrahi, who is Associate Professor in the Department of Gastroenterology of AIIMS Bhubaneswar. He has more than 50 publications to his credit and book chapters also to his credit. And he is a member of editorial board in Indian Journal of Orthopedics and also in the World Journal of Orthopedics. Over to you, Dr. Manas Kumar Panigrahi.
Hello.
Yeah.
I'm audible?
Yes, you are audible.
Technical team, please answer this screen. Yeah, thank you. And allow me to share. Please allow me to share my screen. Yes. I think it is visible now.
Yes, it's visible.
So at the outset, I would like to congratulate Vajanti ma'am and whole team, our AIMS Bhubaneswar microbiology team, for organizing such an informative session for all of us. And while she told me to present a case, I asked her which case I should present. It is hepatic tuberculosis. As a I am a gastroenterologist, so I asked her which case I should present. Hepatic tuberculosis or GI tuberculosis, intestinal or peritoneal. She told present a case where there is some microbiological input you have got and you have tried to solve the case. Then after seeing the program and seeing all those visionaries and luminaries, I thought I should present a case where there should be some doubt and we have taken some risks to do a thing. So as after listening to these luminaries, experts are there, Behra sir and Singla sir and all other experts are there. They can say whether me and my team has done justice in this patient or something risks we have taken here, whether we have done justice or not, they have to give a comment also. So in this World TB Day, after all this presentation, it is not again surprise that I will present a tubercular cases. So my case is, there is no more surprise. Only some issues are there, clinical issue. I will discuss that thing within a quick time because already we are more than 2 hours late. So my case is getting right for the wrong reason. Uncommon facts about a common disease. So I'm unable to move my slides. Technical team, can you help me? Yes. So our team got a case from actually our medicine department, a patient who has suspected to be essential thrombocytosis. By looking at their platelet count, they thought it is a case of essential thrombocytosis, and they have done a bone marrow biopsy. And after bone marrow biopsy, they have not detected JAK2 mutations. Not detected after, as the patient has presented with diarrhea, they consulted us. We have taken the case to our ward, transferred the case to our ward. So this is a 19-year-old female, comes with complaint of loose motion for 2 months, pain abdomen for 2 months, fever for 20 days, generalized body swelling for 15 days. So this diarrhea, which is a frequency of 4 to 5 times a day, large volume, watery, offensive, having nocturnal frequency of 1 to 2 times, containing mucus but no blood. There is no oily material, undigested food particle, and there is no rectal symptoms. This pain abdomen is insidious in onset, gradually progressed in intensity, initially mild, periumbilical region, later diffuse involve whole abdomen, cramping nature, and there is no radiation, no aggravating factor, no relieving, and no relief after passing stool also. And it is not associated with vomiting, obstipation, bowel problem. Fever is of low grade fever, intermittent, any time of the day, and not associated with rigors and chill, and there is no night sweats. There is generalized body swelling, first feet and leg, then upper limb and face swelling is there. There is anorexia, weight loss of 8 kg in last 2 months, fatigue, irregular menstrual cycle, and there is oral ulcer of, these oral ulcer are present for last 15 days only. There is input and negative history. There is no abdominal distension or flatulence, tetany, muscle cramp, bone pain, easy bruisability, ecchymosis, PTG. Why I am telling all those things? Because the patient presented with chronic diarrhea. Diminution of vision in night, ataxia, downgrade, memory impairment, hair fall, no photosensitivity, flushing, milk intolerance, travel outside, fecal incontinence, drug or laxative intake, recurrent infection, skin lesion, arthralgia, redness in eyes, jaundice, itching, cough, breathlessness. Nothing is there. And past history, patient is not, there is no history, similar history, not a diabetic, no history of ATT intake, or no history of epilepsy or any GI surgery. Family history, nothing significant. personal history, non-vegetarian, no addiction, no high-risk behavior. Socioeconomic, lower middle class group. So on examination, tachycardic, BMI is on a little bit lower normal side, temperature is there, pallor, anasarca. These are positive findings. So to summarize, 19-year-old female with chronic small bowel diarrhea, diffuse crampy abdominal pain, short history of fever, anasarca, anorexia, significant weight loss, oral ulcer, and irregular menstrual cycle. So how to approach this case? So this is a case of small bowel, painful diarrhea with feature of malabsorption syndrome and fever. So my possible diagnosis at that time, of course, in India, GI tuberculosis is first, IBD, CD, that is Crohn's disease, inflammatory bowel disease, Crohn's disease, lymphoma, IPSID, immunodeficiency syndrome, and celiac spore. These are the possible diagnoses. Difficulty arise in these cases to us is very difficult to differentiate GI tuberculosis and inflammatory bowel disease, that is Crohn's disease. Previously, when there is no gadgets or armamentarium to see the lumen small bowel, we used to, general practice is that we used to treat all those cases of CD also. First give the ATT. After giving ATTs, they used to have some symptom relief with ATT also, CD patient, this Crohn's disease patient. After taking full course of ATT, if somebody is developing, again symptoms is developing, we used to think of Crohn's disease and we used to treat that. Of course, now this drug-resistant tuberculosis is a diagnosis in that case also after not responding, but I am talking about 1 decade back scenario. We used to thought that ATT, if not responding, it is CD. But nowadays, thanks to the gadgets and armamentarium, we have added a lot of things, and microbiological diagnosis, all those have come a big way, so we can diagnose CD first time also. But till now, it is very difficult to diagnose because pathologically also there will be granuloma, clinical, pathological, radiological, very difficult to differentiate GI tuberculosis and Crohn's disease in our scenario. So again, coming to this patient, anemic hemoglobin is 7.5, neutrophilic leukocytosis is there, thrombocytosis. Here you can look at peripheral sphere, there is thrombocytosis. That's why they have done bone marrow in medicine department. Pretty increase in platelet counts. CRP positive, ESR positive, uric acid and little bit decrease, iron decrease side, ferritin increase. So anemia of chronic disease, marked thrombocytosis, feature of malabsorption syndrome, anemia, hypoproteinemia, hypocalcemia, there, positive inflammatory markers. So what to do next? So as a patient of chronic diarrhea, we went directly through, we do a colonoscopy in our department. We can see here terminal ileum, it is looking normal a little bit. Cecum, there is small nodularity, ulcerations, unhealthy mucosa are there. Hepatic flexure, again there is unhealthy mucosa. But here you can see this area, this is looking normal. Light reflex are there, normal mucosa. Here skip area are there. Here again, the descending colon, there is large ulcer, deep ulcer with this is longitudinal ulcer. Rectum, again there is ulcer. So there is colonic ulcer with skip area. If you see this sort of picture to any clinician, they will thought of Crohn's disease with deep ulceration with skip area, Crohn's disease. So what we have done, so this is the finding only, IC ball with nodular ulceration, terminal ileum normal, segmental biopsy we have taken in this patient, CVNet taken. So again, thinking of Crohn's disease with this skip area and all those things, we went ahead with upper GI also. To upper GI and segmental biopsy in upper GI we have taken. And we have asked for a CT abdomen also. So in CT abdomen, we can see there is skip area, classical skip area, narrowing, thickening, and the skip area are there. This is the lesion area. In between, there is normal area. Skip lesions are there. Again, there is thickening of this large intestine. Skip area are there. Again, there is here we can see there is celiac axis takeoff side. There is thrombosis. Not there is cutoff is there. So thrombosis is there. Celiac axis origin thrombosis. Again, different view. and few collaterals are you seeing here. This is coronal image, again same thing, celiac axis thrombosis, narrowing. So to summarize, young female, chronic diarrhea with malabsorption, low-grade fever, significant weight loss, anemia of chronic disease, significant thrombocytosis, raised inflammatory marker, colonic ulcer with nodularity, with skip lesions, with aerial sparing, celiac axis thrombosis, collaterals, abdominal necrotic lymphadenopathy with GI biopsy showing neutrophilic palisaded granuloma in colon and feature of ischemic immunological changes in stomach and duodenum. At this point of time, CVNet comes to be negative to the patient. This biopsy suggestive of granuloma, skip lesion in colonoscopy, radiologically we have seen CVNet negative with thought of inflammatory bowel disease and Crohn's disease is the diagnosis. And second diagnosis, of course, TB we cannot rule out. So with this finding, we thought of Crohn's disease and started oral prednisolone 40 mg, azathioprine 50 mg, ruling out active other infection we have ruled out. Started this prednisolone, that is steroid, and azathioprine is a immunomodulator. This is standard regimen to start in inflammatory bowel disease. We have started that. On the 7th day of therapy, we see there is worsening of clinical features, fever and leukocytosis comes into picture. So what to do next? Again, difficulty arises to us. So as the patient was in our ward, we are treating the patient in the ward. We have stopped this steroid azathioprine. We have started broad spectrum antibiotic. Since the patient is with us, we again thought try to go inside and look what is happening inside to the colon. And to our surprise, we find the similar finding again. But again, we have taken biopsy during that time also. So this biopsy shows again same finding, necrotizing granulomatous inflammation, occasional AHB. This time AHB positive bacilli come, and mucosal biopsy this time CVNet comes to be positive. Previously, when you have taken biopsy, that time biopsy is granuloma are there, AHB slide negative, CVNet also negative. But after starting steroid and immunomodulator, after these 2 weeks, we have started CVNet comes to be positive, AHB positive bacilli also we have seen. So our final diagnosis we have kept intestinal tuberculosis with segmental involvement, chronic celiac axis thrombosis with collateral, most probably tuberculosis related. Because there is thrombocytosis, of course it is unlikely, but thrombocytosis is also there. So treatment and follow-up, we have started CAT1 category, CAT1 ATT given, patient is some close follow-up, intensive phase completed in June 19, become asymptomatic 3 kg weight gain, increased appetite, NSR card disappeared, and a sense of well-being. Completed ATT 6 months in October 19, 6 kg weight gain, all parameters normalized. So we have again went into see the colon, all the ulcers, the nodularity, everything disappeared, normal. Follow-up imaging, again, CT wise also everything normal, only celiac axis thrombosis, that part is remain. These are the follow-up imaging, everything normal. So uncommon facts of this common diseases, there is segmental involvement of colon with skip lesion, marked thrombocytosis, celiac axis chronic thrombosis, and IMA collaterals are there, feature of ischemic changes in upper GI biopsy, small bowel diarrhea despite large bowel involvement. So getting right for a wrong reason. So we know from the beginning also TB is a great mimicker in Indian scenario. Ileocecal TB and Crohn's disease is very difficult to differentiate after exhausting all the armamentarium in our diagnosis. Segmental conolic involvement with skip lesion promoted us to treat as Crohn's disease here. However, steroid led to clinical worsening and AFD bacilli and revealed a repeat colonic biopsy. Where we write for a wrong reason is vigilant attitude recover here, because after putting steroid and immunomodulator, there is every chance risk of disseminated tuberculosis is there. Taking that risk, since the patient is with us, we have taken that risk, started steroid, seeing again, taken biopsy, nowhere this approach is not present in any literature or anything. We have taken this risk and given steroid, and after that, interestingly, we have taken biopsy and AB become positive. So should we, because if you start ATT then in a Crohn's disease patient, we are increasing the chance of stricture and all those things. But if you are not taking it, it is starting present in a Crohn's disease. If you are putting on steroid and immunomodulator, if the patient has tuberculosis, then chances of flare and disseminated tuberculosis and death is also there. So we have to take a risk, and very vigilantly you have to take a risk if you are starting steroid, and in hospital monitoring should be done. But it is again still a debate whether we should follow this regimen or not. So take home point, think of common condition first always, necrotic lymph nodes, segmental lesion in around 20%, celiac involvement, steroid challenge is a debate, and thanks to our this armamentarium CBNet, and with that we diagnose this patient. I don't know, our luminaries will give me this input, whether we, that is I and my team, has done right or wrong, I don't know. Started steroid and immunomodulator in this patient, and after 1 or 2 weeks, we have again diagnosed, able to diagnose. So we, this concept of steroid challenge in this confusing IBD and CD and TB group, steroid challenge should be done or not, I don't know. This is still a debate is there. Thank you for giving this opportunity.
Thank you, Dr. Manas. That was a really interesting case, and those reviews were also telling that the case was really very interesting, and it is an eye-opening case. And one question is there in the chat box, that whether TB is can be eliminated or it is a mirage. Can anybody answer that question?
That question is for most only our visionaries, Behera sir.
Yes, yes. So if that can be answered, if it is a mirage or it can be eliminated.
Yeah, I think Dr. Behera sir has already mentioned in his talk that at the end he said, draw your own conclusion.
Own conclusion.
So that we have to see how, from our own angle, like whether it can be, it's definitely, it can be eliminated, but yes, there are a lot of challenges are there, particularly in a country like India. So let us think it positively.
We should always hope for the best.
Yes. Okay.
Thank you, Dr. Manas.
Thank you for the opportunity.
And it was a very nice and very challenging case, because it was a double-edged sword for starting whether to start the steroid, and then it was also dangerous to start the steroid. So at the same time, we should be very clinically oriented, and we should be knowledgeable about such interesting cases. Thank you so much.
Any question?
That is the end of the sessions of the 2 interesting cases.
Interesting cases were discussed in this last session. Thank you to our chairpersons and speakers. Now we shall proceed with the valedictory function, and I would like to invite Dr. Sujna Mohanty ma'am, Additional Professor, Department of Microbiology, and Coordinator, to announce the results of poster. So over to Sujna ma'am.
बाद में शेयर करके बोलने दो ना, मैं कहाँ से शेयर करूँ? अभी मत करो।
Okay, so now we, after this vast academic feast, I think this is the most awaited part of today's program. And I take the opportunity and the privilege to announce the results of the poster session.
Not moving. Change नहीं हो रहा है इसमें.
Okay. we received a large number of posters, 57 in number. And we have put all these posters into collage. So all of your posters are there in this screen. In these 3 screens, we have put all the posters. Now, our esteemed panel of judges, they judged the posters and they included Dr. Immaculata Zes, Dr. Shivsekar Chatterjee, Dr. Sanghamitra Padi, Dr. Sushant Kumar Sahu, Dr. Vijayni Behra, Dr. Gitanjali Sadangi from Institutes of Odisha and outside. So now ready for the results. So the consolation prize is awarded to Gargi Mishra from AIIMS Bhubaneswar for her poster of classic presentation of trichomoniasis in a patient of bacterial vaginosis. Congratulations to Dr. Gargi. Next, winner of the 3rd prize, Aparna Chaudhary from School of Tropical Medicine, Kolkata for phylogenetic diversity of Orientia Shushugamushi isolates in patients with scrub typhus in the state of West Bengal. Congratulations to Dr. Aparna. Now coming to the 2nd prize, the 2nd prize has been backed by Sutapa Rath from AIIMS Bhubaneswar for her poster role of expert MTB RIF assay in diagnosis of tubercular pleural effusion and experience from Eastern India. Congratulations to Sutapa. Now, coming to our winner of the day. The winner happens to be Kamal Singh from Banaras University for the poster entitled Proteomic Analysis of Drug-Sensitive and Resistant Mycobacterium Tuberculosis. Congratulations to Kamal. Congratulations to all the winners and also to all the participants for hugely taking part in this poster session. Now, as announced, we have some surprise gifts for the winners also. For the winner, one complimentary ASM membership prize for the best poster prize winner. And for all winners, directly from ASM, some prizes are there. So their emails will be forwarded, and they will be directly endorsed from ASM. Now the certificates and all, they will be emailed to the participants. Okay. So with this, I come to the end of the poster session. I heartily thank our esteemed panel of judges and also our enthusiastic participants for taking part in this session. Thanks to all.
Thank you, ma'am. We have now come to the end of our academic session, and thanks to all of our guests, speakers, chairpersons, delegates, all of our staff, and including the IT. So we hope that this CME will be useful. Thank you.